Is it afternoon or morning? Okay, it's afternoon. Good afternoon, guys. I'm Ahmed Maqlet. I'm a fourth year, and today, inshallah, I'll be me and Harun, my friend. We're going to be covering the post-midterm lectures for your radiology final, inshallah. I'm going to discuss the two CT lectures, the physics and the clinical application, and I'm going to go through the PET scan lecture too. We know you guys didn't take the PET scan lecture till now, but having it recorded right now and being uploaded on YouTube would be much easier for both of us, I think. And you would go into a lecture with the doctor having a better overview of what's going on with the nuclear scanning. All right. So inshallah, we're going to start with this. Let me. Okay, there we go. As the previous crash course, all those lectures are edited. I edited them. I added stuff in the notes section. I added slides. I deleted slides, stuff like that to make it shوية clear for you guys. So yeah, all the lectures are going to be sent to GND and they're going to give it to you guys, inshallah. So let's start with I think this is the physics, all right? So by now we should have an okay idea about how X-rays work. But if you don't, here's a overview as سريع. All right, you'll have an anion and a cation here. All right, you're going to have a current or voltage going through the wires, releasing electrons from the negatively charged side and traveling to the positively charged side. And those electrons, the blue ones, will interact with the anion, right, giving you X-rays. That's basically how X-rays work. And if you need more details on how they work, you can go back to the previous video that we recorded for the midterm. Again, same thing. This just shows you the filter. The filter is used to filter out low energy waves, which are harmful for your body. Again, more details are in the video, in the previous video. This slide's all of this is just an introduction. It's really just superficial stuff, like stuff that you won't really need to focus on, but like for the sake of being comprehensive. So as you can see here, guys, if you can look here, so you have B1, B2, T1. All these stand for different types of tissues, right? So let's say B1 is air or whatever, like it's just different types of tissues, right? So B2 could be bone, T1 could be muscles, whatever. And the whole point is, X-rays penetrate each type of tissue differently, right? So the amount of X-rays that are going to pass through air is much more than the amount of X-rays that are going to pass through bones, for example, all right, if you can see here. And that's basically it. That's why you get different shades of gray on an X-ray or on a CT. Again, same concept. All right. So what's the difference between a CT and an X-ray scan? Basically, an X-ray scan is a 2D scan. All right. You can't visualize the human body in a 3D view. And that where CT differs from X-ray, because CT is a 3D view of the body. And they both use X-rays. There's no difference in the mechanism of action. They both use X-rays, right? But the difference is you have a 2D, you have a 3D. Basically, that's it, right? Because look at this. So you have a mass here, right? And then on an X-ray, you can say it's on the right? So you can see it on one plane only, and you can say it's on the right lung, right? But you can't say, is it anterior or is it posterior without another view, right? And that's why we use CT, because CT will show you this. Now, it's on the right, it's in the right lung, and it's in the middle, right? It's not anterior, it's not posterior, it's in the middle. And you can see how close it is to the chest wall. So yeah, basically that's it. I really want to get into the actual physics of CT now. All right, again. All right. So as I said, a CT will give you multiple projections. So it's not only one view, because an X-ray will give you either an AP view, a PA view, or an oblique view, lateral view. So it's only one view at a time. What a CT scan does is that it integrates all those views into one scan, giving you what you can see right here. So if you look here, the X-ray tube is actually moving. And that's why you get different scans. So like here is going to be AP, and then it can go all the way behind the patient. It can be PA, and then it can go here and it's oblique. It can be on the right side or on the left side, but it's lateral. And at the end of the scan, it combines all of those pictures and it just gives you one picture, which is the one on the right here, which is a 3D view, right? So basically a CT is multiple X-ray projections in one picture. That's basically what a CT is. Again, same thing. Yeah. By the way, guys, if you have any questions, just ask. I keep an eye on the chat. So if you have any questions, just write them in the chat. I can see them immediately and I'll answer you out. Okay, finally we can get into something useful. All right, so we have different types of CT machines, right? And the first CT machine was so bad that it took 5 minutes for a CT scan to be produced. And 5 minutes might seem like a short period, right? But compared to what we have right now, that's a lot, because 5 minutes is a lot, because right now it takes 2 seconds to get a CT scan. Yeah. So when you compare the first generation CT scan with the last generation CT scan, there is a massive improvement, right? So let's discuss what's the difference between each one. I added a lot of slides here because it will just make it easier for you guys, right? So the first generation CT scan is basically an X-ray tube and a detector, and they are like in front of each other, right? And they move horizontally. They don't rotate. They don't rotate around the patient, right? So what will happen is you will have a source, which is the X-ray tube, this one, right? And it will project the X-rays through the patient and it will be detected by the detector, all right? And this will happen horizontally. So it's just going to go in straight line, right? Until it takes one picture of the body. But this is not enough, because that's basically the view. That's the X-ray, but you don't need that. You don't want that. You need multiple projections. So what happens is it's going to go across the patient once, and then it's going to tilt a little bit. It's going to change its angle a little bit, and then it's going to go again and again and again until it completes a 360 degree rotation around the patient, and to get all the projections. And that took 5 minutes almost, right? That's why it's so slow, because it has to go back and forth to get a good image, right? And the beam used in this generation of CT scan was called the pencil beam, right? Again, this is the same thing, right? It has to go horizontally in one direction, then tilts a little bit, and then it goes back, all right? This is the type of beam used in the first generation CT scan. It's called a pencil beam. Yeah. The second generation CT scans still moved horizontally, all right? But this time it used a fan beam. The beam itself changed. So it's no longer a pencil beam. No, it's a fan beam. And why is this better? Because a fan beam detects a wider angle of tissue at a certain point in time, right? So a fan beam will be only able to detect this part, okay, because it's going to be straight like this, and it's going to be detect this part of the body. But a fan beam increases this angle, so you can detect a lot more at a specific time, right? Hope this makes sense. So this is what a second generation CT scan introduced, a fan beam. But it's still the same. It's still the same concept. You have to go through the body and then back again, right? But this process became much faster because you captured most of the body. So let's say a pencil beam would detect this part of the body, and then it will go and detect this part of the body. You know how the first generation works. Okay, back to the first generation, no problem. All right, again, you have an X-ray tube and you have a detector right here, all right? So the X-ray tube is going to emit the X-rays, and it's going to be detected by the detector. And the X-ray tube is giving a straight beam. The beam is going in a straight line. And it's called a pencil beam, this one, all right? And the pencil beam does not have a wide angle. So that's basically it, right? So you have the X-rays going straight to the detector, right, through the body. And then it has to move through the body because the pencil beam is so thin, all right? It detects a little bit of the body at each second. So you'll have to go through the whole body. See this, the X-ray tube and the detector, they move together and they have to go all the way across the patient to get the picture, right? But this is only one projection. This is basically an X-ray. So what happens is it will go all the way from the right to the left of the patient, and then it will tilt a little bit, just like here. It's gonna tilt a little bit to get a new projection, and then it's gonna be all the way back, and so on. All right, you're welcome. That's the first generation. Second generation, as I said, introduces a wider beam, the fan beam. All right, and this fan beam can capture the human body in a wider angle, so it can cover a lot more at a certain amount of time than the pencil beam. All right, this is the second generation. So it still moves horizontally. How does it take PA view if it only moves in front? That's the point, because as I said, it tilts a little bit, right? Eventually, it's gonna go all the way to the other side. So at some point, the X-ray tube and the detector are going to switch positions because every time they keep on tilting until they go on the opposite side. Does that make sense? Perfect. So the whole point is it's going to have to complete a 360-degree circle. Like it's going to have to go all the way around to get a good CT scan, to get a CT scan. The fan beam doesn't tilt, right? It does. It actually does. Let me show you here. All right. See? Wait, do we have a pen or something? Yes, we do. Good. All right. So if this is a pencil, let's say this is a pencil. In the picture, it's a fan beam. But let's say it's a pencil beam. A pencil beam is going to detect this way, right? Like this. So in 1 second, let's say in 1 second, the pencil beam is going to cover, let's say, centimeters of the human body, all right? A fan beam increases the angle so that at 1 second, it detects 4 centimeters of the human body. So it's still the same mechanism of capturing the image. The whole point is that you increase the angle, so you decrease the time of the scan, because you can now capture a wider angle of the body at 1 second. Does that make sense? So like a fan beam is going to cover 2 centimeters in 1 second, but a pencil beam. But a fan beam is going to cover a wider angle. So it's going to cover 4 centimeters per 1 second. You can capture, okay, you got it, thanks, perfect. Tamam? So basically that's the second generation CT scanner. That's the fan beam. A third generation CT scan still has a fan beam, all right? It's a wider fan beam, but it's still a fan beam, but you increases your number of detectors. So now your detectors are in the form of arch. So it's like an arch. If you go back here, right? The fan beam can be missed by the detectors. So like, because this is a one detector, by the way, it's not 3, it's one detector that keeps on moving, all right? So the fan beam, because it has a wider angle, some of the beam can be missed by the detector. So it's not going to hit the detector. Let's say this is the main detector, right? So it's going to miss it. So what happened is in the third generation, you introduced an arch, this one, of detectors. So كل دول are detectors. So there's no way that the fan beam is going to miss the detectors. And in this case, it increased the quality. All right? So the quality of your image here is increased. In the second generation, what was increased is your time. Here, it's the quality. All right? So that's the third generation. can go back here. Yes, this is a better picture. So this is a third generation, as I said, pencil beam and a single detector, right? This is also, this is the second generation. You have the fan beam now, all right? Now, in the second generation, remember how I said they move horizontally? Like they just move in one plane and then they translate and then they go on again and then وهكذا, all right? And they keep on doing this until they get the picture, right? In the third generation, just to confirm, second generation has only one detector. Not necessarily, no, not necessarily. All right, that was a mistake. I'm sorry about that. Not necessarily one detector, all right? But the whole concept is that it moves horizontally. It moves in one plane, right and left and right, up and down and up, all right? It doesn't move in a circular motion. And that's where third generations come in, all right? So a third generation, you don't have to go through the whole body and then translate and then go again. No, because both are going to move around the patient at the same time. All right, so like, you guys get it? All right, cool. One more time, all right? First and second generations is going to move in a horizontal line, right and left and right. But a third and a fourth generation, they're going to rotate, right? So they don't need to go all the way across, then tilt, then go all the way back. They don't need to do that because they move in a circular motion, right? That's a 360 by both the detector and yes, the detector and the beam. They're going to move. So in the third generation, it's going to be like this, right? But in a first and a second generation, it's going to be like this, tilt, then again go, tilt, then again, وهكذا, all right? So that's the third generation. So what's the difference between the third generation and a first and a second generation? It's the way the tube and the detector move, right? What's the difference between a first and a second generation? Can someone tell me? What's the difference between a first generation and a second generation? CT scanners. Yes, the beam. Exactly, the beam. Exactly. So you have a pencil beam in the first one and a fan beam in the rest, in all of the rest, right? So that's a third generation. A fourth generation, صح? Remember how I said in the third generation, the detectors move with the X-ray tube? In this case, the detectors are a whole, they are a ring. They make a ring around the patient. So they don't need to move. And the only thing that moves is the X-ray tube. So the detectors are already in a circle. They don't need to move. They're all over the place, right? They don't need to move. They're there. What moves though is the X-ray tube. All right. Use the fourth generation. This is the difference between a third and a fourth generation. The detectors are all over the place in the fourth generation, so they don't move. But the X-ray tube will move. In the third generation, both of them move together. This took longer than I needed to. Anyways. Okay, so a spiral or a helical CT scan uses a higher X-ray energy. Okay, this is the first thing. And second thing is it moves in a continuous. It moves in a continuous motion. So in a CT scan, a normal CT scan, the patient does not move. All right, the patient is stationary right there, right? And the X-ray tube is above him or her, and the detectors are under them, and it just spins around them, right? Like this. It doesn't go. But in a helical CT scan, the patient is actually moved. So it's like the patient goes inside the tube, all right? The patient goes inside the tube. That's why it's called helical, or it's called spiral, because if you can see this is a normal CT scan. A normal CT scan is just like this, but this is a helical CT scan, right? Basically, that's it really. You don't need to know anything about the spiral or the helical CT. Just know it uses higher energy X-rays, gives you a better quality image, And yeah, that's basically it for spiral and helical CT. The 7th generation CT scans. This is the last one we have, the 7th generation CT scanners. And by 7th gen, what they added is basically an array. All right. So if you guys can see, this is the detector. Okay. Now you added. The point is, in the previous ones, you have one row of detectors. All right. That's it. There are a lot, but they're one row of detectors. So what happened in the 7th generation is that they added another row of detectors, and then another, and then another. So they increased the number of detectors, as you can see here. They added multiple rows. So 1, 2, 3, and each one has detectors on them. That's basically what the 7th generation CT scanner is, and what we use nowadays. Oh my God. Okay. And when they added this will increase quality. Yes, it will increase quality. Yep. All right. And in this, so in a fan beam, what happened is your beam was on this. Okay, so it was only one row, right? So what happens is it goes like this. This is the fan beam. All right. In a pencil beam, it went like this, right? But because now you have multiple arrays or multiple rows, they introduce a new type of rays, which is called the cone ray. All right. And let me show you. Yes, this. All right. So this is the parallel beam or the pencil beam. All right. As you can see, it's just straight line, right? And this is the fan beam, and this is the cone beam. Because in the previous two, you had only one row. See how it's only one row of detectors? But in the last one, you have multiple rows of detectors, right? Yes, you have multiple rows of detectors. So this is what we call a cone beam. That, right? So you have 3 beams: pencil, fan, and cone. Cone is what's used right now because you increase the number of arrays or the number of rows of detectors. Any questions regarding the generations of CT scanners? Okay, I feel like this was a waste of time, to be honest. The whole generations. Like, what am I going to do with this information? Anyways, moving on to the actual physics. Spatial resolutions and contrast resolutions, they were explained last time, but I'll go through them again. All right. So basically, a spatial resolution is the pixels. All right. So if you have so I'll explain it again, just as I did last time. So let's say this is the lungs, okay? And the lungs are red. They're red in color, all right? What is this? They're red in color. And this is the normal lung tissue. But the pathology is dark red. What is going on? It's dark red, okay? If you have a one big pixel, all right? One big pixel that includes both of them together, you're not going to be able to differentiate between them because each pixel can have one color only, right? So if you have your normal tissue and your pathology in the same pixel, you're not going to be able to distinguish them. So, all right. So how do we solve this problem? We solve this problem by having smaller pixels, right? So if you have a smaller pixel, each pixel is going to accommodate one thing. So one pixel is going to have the pathology in it, and one pixel is going to have the normal tissue in it. So when you see it, you're going to see 2 different colors because they are 2 different pixels, because they are smaller. Does that make sense? Yes or no? Okay. So that's basically the whole thing about spatial resolution. And I need you to remember the definition, all right? Because that's probably what you're going to get in the MCQs. They're not going to ask you about the technical details. They're going to ask you about the definition. So spatial resolution is the ability to distinguish 2 adjacent lines. Remember it. I know it doesn't make sense. Just remember it, okay? So that's basically what the spatial resolution is. And how do you improve spatial resolutions? So as we said, you improve the spatial resolution by decreasing the size of the pixels. And when you decrease the size of the pixels, you increase the number of the pixels. So if you have a lot of pixels, each pixel has to be smaller to accommodate other pixels, right? And how do you get more pixels? You get more pixels by adding detectors, right? So the more detectors you have, the better your quality image is, right? And not only the, because, okay, so let's say you have a square, right? And the square contains detectors. So the smaller your detectors are, the more detectors you can fit in the square, right? So the more detectors you have, the smaller your detectors are. This will lead to what? This will lead to smaller pixels that are larger in number. Okay. Are we good with the spatial resolution? Any questions for the spatial resolution before I move on? Okay, cool. Now let's talk about the thing that's actually specific to CT scans, right? So in CT scan, we give tissues units, right? We give them units, and we give them Hounsfield. They're called the Hounsfield units, and the Hounsfield units basically is the attenuation of tissue, right? And your baseline or your number zero, your benchmark is water. Water is your benchmark. It's your base, and it's 0 Hounsfield units, just like you can see right here. Wait, there you go. Water is your base. It's 0 Hounsfield units. Anything above 0 is going to be whiter. Anything lower than 0 is going to be darker. And there are two things that are under 0 that you need to keep in mind: air and fat, right? Those two are under 0. That's why air and fat are going to appear darker than water, right? Anything else, anything is going to appear lighter or like whiter than water, right? Just keep that in mind. So muscles are going to be more than 0 Hounsfield units. They're 40, sometimes they can go up to 70 or 80 Hounsfield units. Bone is going to be more than 0, is going to be 500, and it can range up to 3,000 Hounsfield units, actually, all right? Depending on the bone, depending on the amount of calcium deposited in this bone and the type of cortical bone, trabecular bone, whatever, all these details you don't need to know. Just know that bone will have the higher attenuation than muscles, than air, than fat, than water, than fat, than air. All right. Can someone tell me blood? Will it have a positive Hounsfield unit or a negative Hounsfield unit? Do you need to know the values? No, you don't need to know the values. But you need to know that bone will have a higher Hounsfield unit than muscle because bone is so thick. Bone has calcium in it. Bone is bone, you know? So it's going to have the higher or the highest Hounsfield units, followed by whatever. So you have muscles, ligaments, or whatever, right? And your base is water. Anything, and then you have two things underwater. You have fat and air. Air will have the lowest attenuation. Air is going to be the darkest thing. Okay? You don't need to remember the values. Just remember that water is 0. Anything above water is lighter. Anything below. Why does it keep on switching? Okay. Blood will have a positive Hounsfield units. Why? Blood will have a positive Hounsfield units because, no, without contrast, حتى like just normal blood, right? Will have a positive Hounsfield unit because blood contains other stuff, because blood contains proteins, blood contains cells, blood contains other stuff, right? And remember, anything that's not air or fat is going to appear lighter or whiter than water. Blood has other stuff that's not fat and not air, like RBCs, WBCs, proteins, a lot of stuff that will make it look lighter. So it will have a positive Hounsfield unit, and blood can range from 10 Hounsfield units to 60 Hounsfield units, depending on like how old the blood is. All right, this is just keep it in mind. Blood will appear lighter than water. Is this slide clear? Okay, cool. This is a table that I added for you guys if you want to go and like, check it out. As you can see here, fat, lungs are minus 500 because of the air, obviously. All right. Blood, as you can see here, it's a positive Hounsfield unit. And then you can go up to bones, and bones, you can see it goes up to 3,000. All right. Again, depending on the type of bone. This is just for you. I don't know if just, I don't know, better understanding, I guess. But you don't need to remember the values. It's just too much. You don't need to. Contrast resolution. Okay. Last time I mentioned, contrast. You have two colors when you use X-rays. You have black and you have white, right? And everything in between. What's everything in between black and white? Everything in between black and white is gray. So you have shades of gray, right? And the difference, why does a CT scan have a better contrast resolution than the X-ray? Is because you can include more gray shades in a CT scan. In an X-ray, you can include up to 16 to 18 shades of gray, but in a CT scan, you can include up to 256 shades of gray, right? That's why you get a better contrast resolution, right? Okay, so this is probably the bulk of the lecture right now, the window setting. So sometimes you will look at a CT scan of the same patient, but you want to focus on something. All right. So let's say this patient came in after a trauma accident and he can't breathe, right? When you hear someone can't breathe after trauma, you think of what? One word. Okay, you think of pneumothorax, right? So you think of collapsed lungs, you think of something wrong with a lung, right? This is the first thing that comes to your mind. So what you do is you want to focus your CT scan on the lungs. You don't want to look at the heart. You don't want to look at the bones. You don't want to look at the muscles. You want to look at the lungs, and that's it. And that's called a lung window, right? And same thing, you have a bone window. You have a mediastinal window. You have a lot of windows, all right? So that's basically what a window is when you need to focus your attention on a specific organ or like tissue, right? So what's the difference between windows, right? So if you guys look at this is the spectrum that I talk about. Water is your zero. You have air and fat are below zero. Everything else is above zero, right? Just keep that in mind. Now let's take a look at this. If you want to get something like will focusing on the window increase the quality? Will focusing on the window increase the quality? Yes, it will increase the quality of the organ you're trying to look at. So if you have a normal CT scan and then you change it to the lung window, you will look at the lungs better. The lungs will be clear, active, right? So yes, it would make the quality better, but only specifically for that specific organ, not for anything else. Anything else will either be black completely or white completely. So you lose any diagnostic value for everything else, except for your window. This will be so clear, right? Okay, so you have two things. You have the window width and the window level, right? On a computer, all right, when you get your CT scan, you can adjust your window width and window level. What's a window width? A window width is how many Hounsfield units are in this area. So like normally what we have is, wait, let me draw this one so it's better for you guys. Normally we have a spectrum of -1000. Wait, okay, -1000 to 1000. What is this? Okay. And 0 in the middle, all right? This is your spectrum, -1K to +1K, right? And 0, we said 0 is your water, okay? So let's say you want to focus on the lung, right? And the lung is a soft tissue, right? So let's say you're going to set your window width between, wait. So this is your lung window. A lung window ranges from -400 to -600. Hounsfield units, okay? Because it contains air, all right? So your window width, you can set it for example, here, all right? In the negative ranges, okay? And let's say it's 500. A width can't be negative. You can't have a width that's negative, right? Just like distance, you can't have -5 centimeters, right? So the width is going to be how many Hounsfields are included in this, okay? So let's say it's 500, and your window level is going to be -50, okay? So -50 is your window level, and the window width is 500. So there are 500 Hounsfield units in this area, all right? What's inside could be negative or positive. I don't think it makes sense, does it? Nobody's replying. How did you know the level? I don't get it, to be honest. Okay, so, all right. All right, like, look at this, all right? This is 0. I hate this so much. What is going on here? Okay, this is 0, right? On a Hounsfield, this is water, okay? Anything more than 0 is whiter. Anything less than 0 is darker. Done? Done. Can you repeat it? Okay, it does. So does the lung is -500 and the width is 100. Okay, yes, sure. In a lung window, for example, take a look at this, right? In a lung window, your level is -400 to -600, all right? With a window width of 1500, of 1500. Keep in mind, width cannot be negative, all right? So if this is -300 Hounsfield units and it's 0, all right, your window width could be 200, even if it's in the negative side, because you can't have a width that's negative. Your width has to be a positive number. It's like distance again. You can't have -5 centimeters or -5. You get me? So your width has to be a number, and this number has to be positive. So if we go, مثلا, if you want to set your level, احنا قلنا lungs is -400 to -600, right? So let's say that your level is going to be -500. You're going to set your level at -500 Hounsfield units, okay? Your width is going to be 1500, right? Your width is going to be 1500. So your width is 1500, right? But your level is in the negative side because you're viewing the lungs, and the lungs have negative Hounsfield units. It's going to be -500. Okay, so your level can be anywhere on the spectrum of -1000 to 1000, right? You can have a negative window level depending on the tissue you're trying to view. So if it's a bone, your window level is going to be in the thousands, right? Because you're trying to view the bones. It's going to be a positive value, all right? But your width is just Okay, let me take a second. No, there's no way to calculate the width. The width is already determined, and you don't need to remember it. You don't need to remember the width. You don't need to remember the levels. It's just, you need to understand how windows work and how a lung window differs from the bone window, and the level is the range. The level is the middle. The level is the middle of your Hounsfield units, all right? So width is how many spectrum are included in the window. Yes, 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 yes. So your width, let's say 500, okay? Okay, so you have 500 Hounsfield units that are included in this area, right? Those Hounsfield units, they could be positive Hounsfield units, or they could be negative Hounsfield units, depending on the tissue that you're trying to view. So if you have a width that's 500, but a level that's in the negative, that's probably a lung window, because lungs are negative Hounsfield units. If you remember this, lungs are negative Hounsfield units. Yeah? So your width could be 500, all right? Your width could be 500. But whatever is inside this 500, it could be positive or negative. Chat. So width is how many, okay, and the level is a specific spectrum for the organ. Yes, 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 you're right, 100%. So your width is how many Hounsfield units are in this area, all right? It could be 500, could be 1,000, but you have 1,000 Hounsfield units here, okay? Those Hounsfield units, they could be positive or they could be negative, depending on the tissue. If you want to view a bone, then your Hounsfield units have to be positive, because bones are positive Hounsfield units right here. But if you're trying to view your lungs are negative Hounsfield units. So Hounsfield units have to be negative. It's going to make sense in a bit. Wait. All right. So in a lung window, your width is 1,500. Okay. So you have 1,500 Hounsfield units in this area. All right. But the Hounsfield units included in this area are negative, because you're viewing the lungs, which has a negative value. It has a negative Hounsfield units. Does that make sense? Another example would be the mediastinal window. A mediastinal window, you're trying to view, for example, the heart and the vessels. The heart and the vessels do not contain air. They contain blood, they contain tissue, they contain muscles. So they're going to be a positive Hounsfield unit. So your width, again, has to be positive, right? Your width has to be positive. So you have 350 Hounsfield units here, right? And inside those, you have to have positive Hounsfield units, because you're trying to view muscles, you're trying to view blood, you're trying to view vessels. But if you're trying to view the lung, it's going to be negative Hounsfield units. This is the mediastinal window. The liver window, again, another example. This is the bone window. A bone window, your window width is going to be 1,800. So you have 1,800 Hounsfield units here. Inside those, you'll have to have positive Hounsfield units, because you're trying to view the bones. As we said, bones have positive Hounsfield units. Does anyone want me to repeat? Because I will repeat. We're not going to move on until I make sure everyone understands this. No questions? Okay. Are you sure? All right. All right. I probably could have explained this better, but like, anyways, in this slide, the doctor wants you to understand one thing and one thing only. Iodine or contrast, IV contrast will increase your contrast resolution by increasing the photoelectric effect. Okay, if you remember from the X-ray lectures, we said that the general X-rays or the general radiation is bad, and the photoelectric radiation is good. Iodine or IV contrast increases your photoelectric effects, which gives you a better picture. That's basically all what you want you to understand from this slide, nothing else. Do you need to know the ranges? No, you don't. You do not need to know them. You don't need to know them. But you need to know that, for example, a lung window will have a negative level, and a bone window will have a level in the thousands, because it's so dense. All right, and muscles, blood, and anything else is going to be in between 0 and the thousands. You don't need to know. You don't need to know that either. You don't need to know. They were just examples to like explain how windows work, but you don't need to know values. All right. Okay, this slide was from the previous lecture command. How do you determine the dose that the patient will receive of radiation, because ionizing radiation, you need to limit the dose to decrease the harm, because ionizing radiation is harmful. So you need to decrease the amount of ionizing radiation, all right? And how do you manipulate the dose? It's by those four measurements. You have the focus, the angle, right? So if you increase it by 10 centimeters, you increase the dose by 10%. If you decrease it by 10 centimeters, you decrease the dose by 10%, right? The KVB has an exponential relationship. So if you give, for example, 20 KVPs, the dose is going to be exponentially increased. So it's going to be, so what's 20 multiplied by 20? 400? Yeah. So your dose is going to be 400. So it doesn't, so if your dose, so a KVP, if you increase your KVP, your dose is going to exponentially grow, right? If you give 2, the dose is going to be 4. If you give 3, the dose is going to be 9, and so on. But in a milliampere, if you double the dose, you double the if you double the milliampere, you double the dose. So if you give 2 milliamperes, you'll get double the dose, right? 4, right? It's a linear relationship, but the KVP is an exponential relationship. All right. So what affects the dose? The angle, right? This is your first thing. The angle, the time that the patient spends inside the X-ray tube, because the longer the patient spends inside this X-ray tube, the more radiation he or she will receive. All right. So the angle, the time, the KVP, and the milliampere. KVP has an exponential relationship. Milliampere has a linear relationship. If you double the KVP, you quadruple the dose. If you double the milliampere, you double the dose. You don't quadruple it. Okay. So we're done with this lecture. If you guys have any questions, let me know. Whatever the questions are. If you don't want to text them on the chat, just you can DM them to me on the chat. If you don't want to just... Any questions you have before we move on, especially in the window thing? I know it wasn't as clear as it was supposed to. All right. The next lecture is going to be a longer lecture. It's the clinical application of CT. Inshallah, it's going to be better than this. I know this one was boring. Do you guys want a 10 minutes break before we start? Because it's going to be longer than this one. So do you want a break, or do you want to class dive in? Cool. All right. Discard.
Good day.
All right. So this is just a quick review. Again, water is 0. Anything above water is going to be lighter. Fat and air are going to be darker. Keep that in mind, right? Now, why do we use CT scans? All right, CT scans are very important in the onset of trauma. All right, so patient comes to you, a vehicle accident, fell from whatever, motorbike, well, trauma. CT is very important, so remember that. All right. Other than trauma, abdominal organs is very important. CT plays a big role in abdominal imaging, in the pulmonary imaging too, and the brain, and in angiography. Angiography is when you give dye inside the vessels, inside the blood, so that you can view the vasculature of organs. All right, this is angiography. So CT is used in trauma. Which lecture is this? This is the clinical application of CT. All right. So we use CT in the setting of trauma, abdominal imaging, pulmonary imaging, brain imaging, and vessels, so angiography, right? I need you guys to keep something in mind. if the doctor asks you about the first line imaging modality, CT is usually not your answer. If she asks about first line, CT is not your answer, like never, right? Your first line is either going to be an ultrasound or it's going to be no. An MRI is like the last thing you do. It's like, this is the, oh wait, PET is the last thing, PET scans, then MRIs, then CTs, and then your first line are usually X-rays and ultrasounds. Those two, X-rays and ultrasounds, are usually your first go-to when you say imaging modalities, right? But keep in mind, they play with the words in your questions, okay? So in MCQs, look out for first line management, right? Or next step management versus best diagnostic criteria or best diagnostic modality, because best is not first. First, you'll have X-ray and ultrasound, but your best modalities will probably be a CT or an MRI, right? Okay. Oh my God. Okay, again, CT is very important in trauma. Keep that in mind. Okay, so in CT, we don't usually have a lot of contraindications in CT, right? But keep a very important contraindication in your mind: pregnant women, all right? Pregnancy is an absolute contraindication for CT scans. You do not do a CT scan for a pregnant woman, full stop, right? Other contraindications is not for CT per se, it's for the IV contrast that we give with the CT, right? So for example, renal impairment, because the dye or the IV contrast is going to be filtered through your kidneys. So if you have renal impairment, it can lead to acute renal failure if you give IV contrast. So the patient have a low GFR or has any signs of decreased renal function, you do not give IV contrast, right? Also allergy to IV contrast. But if we're talking about purely CT scans, the only absolute contraindication to CT scans is pregnancy, right? Keep that in mind, because you're gonna get a clinical scenario and the patient who's gonna present with appendicitis, but she's a female and she's 11 weeks pregnant. You're gonna get clinical scenarios like this. And one of the choices is going to be CT. Do not choose CT. Don't, because it's absolutely wrong, right? So what do we use for pregnant ladies? What do we use if we can't use CT? We use ultrasound and we use MRI. You start with an ultrasound, perfect, Bushra. You can't find anything on your ultrasound, you move on to your MRI. No CT at all, right? Like, what's this window? Good, yes, this is a bone window. What is this window? Brain window, yes. It's also called a soft tissue window. Perfect. Brain, yes, exactly. It's soft tissue or brain window. Perfect. And those are the two windows we usually use in brain imaging for CT. We use the bone window for skull fractures, and we use the brain window or the soft tissue window for anything inside the brain parenchyma and the ventricles. You guys will probably know more about the anatomy of brain than me, because like I took this like 3 years ago. So you're gonna know this better than me because you just finished neuro. This is just cuts of the brain in different levels, all right? So here's the first one, all right? And the doctor doesn't want you to like identify the hypothalamus and the, no, all right? He just wants you to know the general landmarks of the brain, right? So in cut number A, it's probably like at the middle of the brain, I don't know, right? And she wants you to identify the white matter, the gray matter, and the ventricles, all right? So you need to identify the ventricles, which you can see right here. Those are the ventricles. And she wants you to identify the white and the gray matter. Now, what has more fat? The white matter or the gray matter? Which has more fat content? Exactly, the white matter. Perfect. And we said that fat appears darker or whiter than water. Exactly. Perfect. It appears darker. So your white matter is going to be darker than your gray matter because it has more fat. I hate how this keeps on switching alone. Oh my God. Okay. So that's basically it, right? Your white matter will appear darker than your gray matter because it has more fat. And in the brain, we all know that the white matter is inside and the gray matter is outside. And this switches in the spinal cord, right? But right now we're doing brain CT. So keep in mind that outside you have the gray matter and inside you have the white matter. And not because it's called white matter, it will be whiter. No, it will appear darker. Does it depend on T1 and T2 to compare which is darker? T1 and T2 are in MRI scans. They are not in CT scans. And my friend Harun is going to discuss this more with you guys, right? So yeah, not because it's called white matter, it will be white. No, white matter has more fat, so it will appear darker than the gray matter, right? Keep that in mind. She also wants you to identify the falx cerebri, all right? It's pretty clear here, right? And then in the second image, she goes a little bit inferiorly down to the level of the brainstem. So you need to identify the brainstem, right? And the ventricles, that's behind the brainstem, right? I don't know if that's, just know it. And then in the last one, yeah, this is the fourth ventricle. So so you have the brainstem and posteriorly, you will have the fourth ventricle. This is a very low cut of the head, all right? You can see I think this is the mastoid sinuses, if I'm not mistaken. These are the mastoid sinuses. And then you have here the cerebellar hemispheres, the cerebellum, all right, here. And you have the fourth ventricle. So she doesn't want you to go into details. You don't need to know where's the thalamus, the hypothalamus, the basal ganglia. No, you don't need to know all of this, right? You just need to know the basic landmarks: white matter, gray matter, your ventricles, and the falx cerebri, right? Just know those. Are we clear regarding the anatomical landmarks? If not, just ask whatever you want to ask. All right, cool. All right, so here she just wants you to identify the abnormality. By the way, if you have the lectures with the transcription, close it, okay? Because I know some of y'all do. It's just for your benefit. Yeah. You guys can see any abnormalities in B? Okay, I'll just answer this question. In B, you can see, yes, exactly. You have a very enlarged, there is no ischemia actually, but you have very enlarged ventricles. Like, look at the difference here, right? Very big ventricles, all right? And your sulci and your gyri are deeper and more prominent. You can see them, right? See, look right here. They're deeper and they're more prominent. So what happens here is that the brain undergoes atrophy. It just shrinks. And when does this happen? It happens with age, right? So just a patient who's 60-year-old is not going to have the same brain as a patient who's 20 years old, right? As you grow older, your brain shrinks, it atrophies. And when it does, your ventricles expand. Exactly, senile atrophy, perfect. Your ventricles expand, they dilate, and your gyri and sulci, they also Alzheimer's disease. Yes, perfect. But in Alzheimer's disease, that's not the only thing you'll see. In Alzheimer's disease, you're going to see myelin deposits, and they're going to be more prominent on MRIs. Alzheimer's disease won't only present with atrophy of the brain. It will have other findings, right? But in this case, it's only dilation of the ventricles and the sulci and gyri, and basically that's because of age, right? So yeah, keep that in mind. Okay, so the doctor, after the slides, immediately gives you cases. She starts giving you pathology, right? Guys, you need to understand that you can't come to, like, if the question is like, what's the best imaging modality? You can determine this just by, I don't know, a one-line clinical presentation. That's not going to work. You need to know clinical features of the patient. You need to know what pathology will present with what. Okay, you have to correlate it. You have to correlate your imaging modality to your clinical presentation. You can't just be like, oh, okay, he has this, let's do this. No, that's not how it works. For example, the pregnant lady, the best Imaging modality is CT scan, but because she's pregnant, you can't use that. See, you correlate your imaging modality to your clinical presentation. You can't just go on top, all right? So I made this table for you guys. This is a clinical presentation in brain pathology, right? So you have 3 different types of hemorrhage, right? And you have tumors and strokes, right? So if you guys go through this, you will easily identify or diagnose your patient solely based on your clinical presentation. And then you can decide what imaging modality you will choose, right? So in each one, I highlighted something that you need to remember, right? You have to remember. So in epidural hemorrhage, it's trauma, all right? And it's arterial bleed, okay? So epidural, arterial bleed. And we know arterial bleed is much more worse than a venous bleed because it's higher pressure, so more bleeding, right? So an epidural hemorrhage will probably present acutely. It's going to be instant, right? Because it's an artery that's bleeding, not a vein. So an epidural hemorrhage, you'll have an arterial bleed due to trauma, right? And the most common presenting symptom is headache, right? You'll have headache and you'll have ipsilateral mydriasis, okay? This is epidural hemorrhage. For the subdural hemorrhage, loss of consciousness, yes, exactly. LC. But loss of consciousness, you'll probably observe it in all brain pathology, right? So like you have to focus on specific signs, right? So headache with ipsilateral mydriasis, that's especially after trauma. So like if a patient comes to you after a car accident and there's headache and ipsilateral mydriasis, think of epidural hemorrhage, right? So for example, and then we can move on to subdural hemorrhage. Subdural hemorrhage is a venous bleed. It's not an arterial bleed. And when we say a venous bleed, the bleeding is slower than your arterial bleed. So it will take time for the patient to experience symptoms, right? Sometimes a patient can have a subdural hemorrhage for weeks and they won't know anything because the bleed is so slow, right? So let's say a patient comes to you with altered mental status. So the patient is dizzy or can't comprehend people talking to him or her, just they have altered mental status and they have headache and they mention a history of trauma 2 weeks ago. Okay, this is a trigger. This is a trigger sign. Okay, you need to identify this. So 2 weeks history of trauma, altered mental status, headache. You need to start picking up that this might be a subdural hemorrhage, right? Other stuff that you can see in subdural hemorrhage will be upper motor neuron signs. Can someone mention some upper motor neuron signs? You just finished neuro. Nothing? Damn. Okay. You'll have hyperreflexia, spastic paralysis. Perfect. Yes. Hyperreflexia, fasciculations. Yes. Hypertonia. Exactly. So upper motor neurons, altered mental status, headache, think subdural hemorrhage. A subarachnoid hemorrhage, this is the deeper. This is deeper. We just keep on going deeper, by the way. So it's epidural, then subdural, then subarachnoid. We just keep on going deeper into the brain, right? And this one is due to trauma again, but you need to. So there's something very specific to subarachnoid hemorrhage, and that's ruptured aneurysms. Specifically, wait, I forgot the name of the aneurysm. There's an aneurysm, Barry's aneurysm. Yes, Barry's aneurysm. Remember this, right? So Barry's aneurysm is very, very specific cause of subarachnoid hemorrhage, right? So remember that. And what can cause Barry's aneurysm to rupture? Hypertension, stress, cocaine, stuff like that, right? So remember, trauma and ruptured aneurysms are very common, are very specific causes for subarachnoid hemorrhage. And in subarachnoid hemorrhage, you have a very specific presentation. It's very, very specific, and it's called thunderclap headache. And I'm sure you guys heard about this. It's the worst headache a person can ever experience, all right? So if someone comes to you, history of trauma or history of a family member who died due to a brain bleed, all right? And they tell you I have a headache that I've never experienced before. This is the worst headache of my life. Subarachnoid hemorrhage, all right? Uh, okay, so those are the three types of hemorrhages that might happen. There are two others, so you don't need to know them. And then you have tumors and strokes. Tumors, the most common presentation for tumors, or not the most common, the most specific presentation for tumors would be seizures, all right? So patient, doesn't matter for the age, by the way, age doesn't matter in case of tumors, especially brain tumors, because there are a lot of tumors that can happen in children, in adults, in elderly, right? So it doesn't really matter. But the most common presentation or the most specific presentation for tumors will probably be seizures, right? So patient comes to you with seizures, you need to do a CT, right? Strokes, we have two types of strokes. We have hemorrhagic strokes and ischemic strokes, all right? And strokes are all over the place. You can get anything, right? Neurological deficits, so you can have a paraplegia, you can have loss of motor function, fine, or you can lose motor function. Patient might start stuttering. They can't see. Blindness. Anything you can think of can happen in strokes. You can have ptosis of the eyes, right? Can have anything really. And the most common type of strokes are ischemic strokes, not hemorrhagic strokes. All right. Hemorrhagic strokes will be the it's like 15%, I think, and ischemic is like 85. So yeah. All right. So types of brain hemorrhage. We discussed the epidural, the subdural, the subarachnoid, and the intracerebral. Intracerebral, you don't need to. I mean, you don't need to know it really. All right. All right. So we use CT in these cases, right? You do. Yes, you do use CT in these cases. Subarachnoid. Why is it subarachnoid, ya Ghada? Why do you think this is subarachnoid hemorrhage? Okay, yes. Yeah, that's good. That's good. But it's light. Okay, so it being light is indicative of hemorrhage, right? And it's indicative of hemorrhage. And seeing this light fluid inside the gyri and the sulci and this close to your ventricles, you think about subarachnoid, because subarachnoid, the subarachnoid space goes inside the sulci and the gyri. It goes inside. It goes inside those grooves, right? So the bleed is going to extend inside the brain, right? Not inside the tissue. It's not going to be inside the parenchyma of the brain, but it's going to be inside the sulci and the gyri. That's why it's going to extend inside. You can see it going inside. But in a subdural or an epidural hemorrhage, it's going to be on the outside, all right? Perfect. Whoever said subarachnoid, good job, all right? Okay, that's a good thought, Aya. All right. But intracerebral hemorrhage, the hemorrhage is going to be inside the borders of the brain, right? So you know there's sulci and gyri, right? If the bleed is inside them, it means it's outside the brain, all right? But if you find that the bleed is inside here, all right? For example, here, yeah, but it's surrounded by the layers of the brain, it means it's intracerebral, right? Because the borders covers it. But here, if you take a look, the bleed is outside. To be honest with you, you mean the sulci won't be involved? Yes. See, if it's because you have, okay, so you have the sulci, you have everything outside the sulci, and you have inside the sulci. What's inside the sulci? It's the brain parenchyma. What's outside the sulci? It's the CSF, right? So if your bleed is on the other side of the sulci or the gyri, right? It's subarachnoid. If it's on the inside, it's intracerebral. Well, to be honest with you, it's very hard to distinguish with them. I'm not gonna lie, I have a hard time distinguishing them too. But the good thing is, she never said anything about intracerebral hemorrhage, so you guys don't really need to focus on that. All right, that's a good thing, really. But yeah, you're right. It's kind of hard to distinguish between both. Okay, so brain CT, gentlemen. Okay, so you have a young gentleman with acute onset headache. What do you think is going on here? Subarachnoid hemorrhage. Yes, you're right. This Yes, it is subarachnoid, but let me tell you why it's subarachnoid. You can't see, this is not the same, this is not the same presentation, all right? You can't tell me that this looks like this, no way, all right? But why is this subarachnoid? There's ischemia. I actually can't see ischemia here, but you might be right, but I can't see it. Ischemia on a CT is very hard to detect. Acute ischemia on a CT is very hard to detect. So to detect ischemia on a CT scan, it has to be يعني شوية يعني if it's 30-minute ischemia, there's no way you're going to detect it on a CT scan. No way, right? You'll need an MRI for that. Rupture of an AV malformation. No, I actually don't know what caused this subarachnoid bleed, but one of the causes of subarachnoid bleed is AVM rupture. You're right, but I don't know what's the cause here. I don't think anybody does. All right. So if you guys take a look, is the sulci is light? Yes, the sulci is light. You're right. But if you take a look at this picture, for example, it's much more clear here, right? Like you can see the sulci are white. They're white sulci. So you know there's a bleed here. Here, if you can take a look right here, see this, it's very subtle. Like I hate the picture that was supplied, right? This is a bad picture. I don't like it. But there's another feature that will tell you that this is a subarachnoid bleed. Obliteration of the ventricles. So what happens is you're going to bleed inside, right? And then it goes into the sulci and the gyri. It's going to compress on the ventricles. So it can obliterate your ventricles. Not only it can completely close your ventricles, or it can narrow it down. You can't point out a normal looking ventricle here, can you? I can't. I can see a narrowed, maybe a narrowed ventricle right here, maybe, all right? But this is definitely not a normal looking ventricle, all right? So this is another thing you can notice in a subarachnoid bleed, right? This is a normal CT scan, all right? You can clearly see your ventricles, your sulci and your gyri are clear. There's no liquid fluid in them, no bleed. So this is a normal looking CT scan. I honestly hate those two pictures. I don't know why they got you those two specifically. That's why I added this one. It's much clearer. You can actually point it out. All right. So this is a subarachnoid bleed. All right. The subarachnoid hemorrhage, as you can see, the doctor pointed them out here and here, just like I did here. All right. Tamam. This is a subdural versus an epidural bleed. All right. And I know you guys took this in Euro, but revision is not bad. So let's revise it. In an epidural bleed, it's going to be a biconvex lesion, right? It's going to be like this, right? But in an epidural hemorrhage, it's going to be a crescent shape. It's going to be like this, all right? You guys got this? All right. So a crescent shape is epidural. A biconvex, a crescent shape is a oh my god, is a subdural, and an epidural is going to be biconvex. You guys know what a suture line is, right? So in an epidural hemorrhage, you can see that it's limited by your suture lines. So you won't see an epidural hemorrhage that goes throughout the brain, right? It's not, you'll never see something like this. It's not going to happen. This is not going to happen, right? Because your suture lines are going to limit the bleeds. But in a subdural hemorrhage, can you see this? It goes, it crosses the whole area of the brain, right? So it's just the suture lines will not limit the subdural hemorrhage, right? Hope this was clear. Honestly, this is like a free point. This is like one of the easiest questions you can get, all right? So make sure you don't confuse them, because I did, and I lost marks because of this. So just a subdural is a crescent shape. Yes, and I will, wait, let me edit this right now. So Better. Okay, wait, let me check the chat. B in subdural stands for blue banana. Oh, okay. This is very interesting. Yes, Bashar, this is really nice. All right. So B stands for blue banana, and this is literally what it looks like. It looks like a banana, right? Wait, it looks like a banana, all right? And B is blue, blue is Venus. Perfect, amazing, all right? So limited from what? It limits it from spreading throughout the whole length of the skull, all right? So for example, okay, wait, let me get the pen again. See, you will never see an epidural bleed that's gonna be like this. That's not gonna happen, right? Because you have a suture line here and a suture line here. And the suture lines are gonna limit this bleed. It's not gonna allow it to go like this, all right? But in a subdural bleed, the suture lines will not limit it, right? So you can see a bleeding that vasts across the whole length of the skull, like this, all right? And it's usually gonna be smaller, like it's gonna be thinner than an epidural bleed, because again, it's going to be a venous bleed, and a venous bleed is much slower than an arterial bleed, right? Okay, epidural, subdural, done. I hope everything is clear. If it's not clear, please ask questions, all right? Next. Cool. All right, what do you guys think is happening here? So an elderly patient awakened with right body weakness. Okay, cytotoxic edema. Interesting. Any other answers? It is a stroke. Yes, it is. This is ischemia, right? And this is probably took time. This is probably a 2-3 hour ischemia of the brain for it to appear this clear on a CT scan, like, right? So why did you say it's a cytotoxic edema? What's the difference? What's the other type of edema that you guys know about? Vasogenic, all right. And does anyone know what's the difference between vasogenic and cytotoxic? Like, can you distinguish them? Okay, I can tell you guys. So wait, I have a slide for it. Yes, this slide. Okay, this slide. Types of edema on CT, you have two types. You have cytogenic and you have, vasogenic and cytotoxic, all right? What happens in a cytotoxic edema is that your cells, they're affected, right? So they just, they explode. If you want to differentiate between cytotoxic and vasogenic, look at the white matter and the gray matter differentiation. If you can clearly differentiate between the white and the gray matter, right? You can differentiate between them, right? They're clear, then this is a vasogenic edema. If you can't differentiate between the white and the gray matter, then this is cytotoxic edema, all right? Now, which one is cytotoxic? This one, I'm gonna just label it as R and L. Which one is cytotoxic? Exactly, yes, cytotoxic is the one on the right, because you can't differentiate between the white and the gray matter. You can't tell me you can see the gray matter and the white. It's not possible. I can't see them, right? This is cytotoxic edema. But if you look on this side, right, you can clearly distinguish them. Look at this. See? Sulci, gyri, you can distinguish them. Here's the white matter, here's the gray matter, right? Clear. So this is vasogenic edema. All right, let's go back. So yes, this is an acute ischemic stroke, all right? And can someone tell me why does this appear darker than the remaining of the brain? Like, why is the brain lighter than the area of the ischemia? Not blood, but close. You're really close, but it's not blood. Fluids, yes. This is edema. We just said it. Edema is water, صح? And water is zero, right? Anything higher than zero is going to appear whiter than the water, صح? And you have the brain. The brain is tissue. It's made of cells, and cells appear lighter. They are tissue, right? They're going to appear lighter than water. So when you have ischemia, you have inflammation, Inflammation will lead to edema. And that's why ischemic strokes will appear darker than the remaining of the parenchyma of the brain, right? Just keep that in mind. Does anyone know which artery is affected here? Just, you don't need to know, just no one knows? Middle cerebral, yes, it's the MCA. Yeah, perfect. Okay. Middle-aged woman with few weeks of headache, nausea, and vomiting. What is this? Vasogenic edema. Okay. It is a tumor. Okay. Any other answers? Okay, tumor. Okay. No, any other answers? Remember, guys, subdural hemorrhage can appear weeks after the onset of trauma. And this has a few weeks of headache, nausea, and vomiting, which are characteristic of subdural hemorrhage. You are right, it is a tumor. But how can you differentiate between a tumor and bleed? How can you differentiate between inside the parenchyma? Okay, all right, but you can have bleed inside the parenchyma. So there is no history of trauma. You're right. It's like, let's say there was no history at all. Okay, I just gave you this photo. I just gave you this the CT scan. How can you differentiate between a bleed and a tumor? I'll let you know. Okay, so what you do is, yeah, circumscribed and the contrast. You guys are forgetting the contrast. All right. When you give a contrast in a bleed, the contrast is going to spread. It's going to go through, like, you're going to see it going like this and like this and like that. It's just going to be all over the place, right? Because it's bleeding, right? But in a tumor, the contrast is going to be taken up by the tumor and it's going to be confined to a specific area, right? Because a tumor is a highly vascular mass, right? So it's going to take up much more blood than the brain, but it's going to be in a specific place. It's going to be there, right? And as you can see right here, this is without a contrast. We gave contrast, and the dye or the contrast is confined within this area. All right. So this is a tumor. You're right. And notice, guys, how it's a middle-aged woman, right? So again, don't correlate age with tumors, especially in brain. All right. Children can get brain tumors. Okay. Yeah. Keep in mind contrast, right? Types of edema, we spoke about this. Like, do you guys have any questions about brain pathology?
This is
Anything about brain that you want to ask me about? Okay. Remember how we said CT is very important in trauma? The doctor is trying to demonstrate this in this CT. I remember that. Make sure what saying for previous picture about tumor. When we give more contrast, we see more fluid components. We see a lot of edema around it, limited by the white matter. Yeah, see, it's the same concept, so it's still limited, right? So you're right. You're perfectly right. It's going to be confined. It's going to be limited, and that's how you know it's a tumor. And someone said that, I think RAD said it. It's a vasogenic edema, right? And again, why is it vasogenic edema? Because you can differentiate the white and the gray matter, right? So the edema is right there. You can see it, right? You can see it right there. But you can still differentiate the gray and the white matter. So this is vasogenic. You're 100% right. Remember, vasogenic edema, you can differentiate the gray and the white matter, and it's usually due to tumors. All right. Cytotoxic edema, you cannot differentiate the white and the gray matter, and it's usually due to strokes or like ischemia. All right. Keep that in mind. So again, the doctor mentioned that CT is important in trauma, and she's trying to demonstrate this using this CT scan. So can someone tell me what's going on here? See, it's a fracture, okay, of the C spine, right? Because this is the neck. You can see the vertebra right here, You can even see the clavicle right here. See, this is the clavicle, right? So this is a C spine CT, all right? And on this view, you can see that the C spine is fractured right here. See, fractured here and here. See, these two pieces are dislodged. They're fractured. You have a C spine fracture right here. All right. That's basically it. Like there's nothing else to this except the C-spine fracture, right? So remember, CT is very, very, very important in trauma setting. Okay.
This is also.
All right. We're moving to chest now. Before we move to chest, do you guys have any questions regarding brain, CT, or brain anatomy, or brain pathology? Anything? Okay. Looks like we're good. Now we can move on to the chest pathology. What is this window? Lung window. Perfect. What is this window? This is not the yes. This is the mediastinal window. Yes, perfect. This is the mediastinal window because you can't see the lungs, but you can see everything else except the lungs. So you can see the heart, you can see the arteries, you can see the aorta, you can see everything, right? And what's this? What's this? Bone window. Yes, this is the bone window. You can't see anything except the bones. Mediastinal is soft tissue. Yes, mediastinal is the soft tissue window. Your lung window is not a soft tissue window. All right. Yeah, again, she just wants you to take a look. This is a soft tissue window, which is again the mediastinal window. This is the lung window. You can see the lungs, but you can't see anything else. And this is the lung window again, but in a different plane. This is the coronal plane. All right, again, another table for you guys. I really want you guys to go through the tables because I really want you to know the clinical presentations of different pathologies. It's very important. Hatta if it's not going to help you in the exam, later on, this is going to be very important for you. All right. So we're going to start by the aortic dissection. And when I say aortic dissection, you need to remember three things. Well, four things. Hypertension and Marfan syndrome are the two most common causes, right? Presentation, chest pain radiating to the back, right? This is the third thing. Chest pain radiating to the back and asymmetrical blood pressure. So you're going to measure the blood pressure on this arm. It's going to be 120/80, and you're going to measure the blood pressure on the other arm. It's going to be 140/90, right? So aortic dissection happens in people with hypertension and Marfan syndrome, and they will present with a tearing chest pain radiating to the back with asymmetrical blood pressure. Okay, this is aortic dissection. Pulmonary embolism, it's caused by emboli, so it could be blood clot, could be DVTs, could be air, could be fat, could be amniotic fluid, right? But overall, it's an emboli, right? Most common presentation is dyspnea. Remember dyspnea? And when it becomes severe, you'll have hypotension and you will have syncope. Patient will lose consciousness, right? An extra thing you can keep in mind for pulmonary embolism is leg swelling. So you have a swollen leg that's painful due to the deep vein thrombosis, right? Pneumonia, it's infectious. 99% it's due to an infection. And you need to keep an eye out for fever and dyspnea. Fever is very important because fever indicates infectious origin, right? Pulmonary fibrosis, remember smoking, and remember non-productive cough. Okay, so it's dry cough in a patient who's a smoker, pulmonary fibrosis. Okay, usually those patients are really old, but like it can present in younger patients. Okay, any questions regarding this table? All right, we'll move on. So, middle-aged woman with shortness of breath for a few hours. What's going on here? It's a pulmonary embolism. Okay. All right. What window is this window? Like, what is the window of the CT scan that I provided you with? Mediastinal window, perfect. And is the emboli on the right picture or on the left picture? It's on the right picture, perfect. Here's the emboli. Can you guys see it now? See? This is the embolism, right? This is a perfectly normal CT scan. This is a perfect pulmonary vasculature, empty lumen, amazing, right? But this one, mediastinal is also called soft tissue window. Yes, you're right, Bashar. Mediastinal is also called soft tissue window, right? So I hope the picture was clear, all right? Again, you need, because if the doctor is going to give you the CT scan without the clinical presentation, you're going to be so lost. Like if I give you this, you don't know where to look, right? But when I tell you that the patient has dyspnea or shortness of breath, you're going to start looking into relevant structures. So pulmonary vasculature, the lungs, you're going to look into stuff that actually matters. You're not going to waste time looking at the heart or the aorta or whatever, right? Just keep that in mind. This is a pulmonary embolism. Here is a perfectly normal and clear pulmonary vasculature. And here you can see a very big emboli, all right? Okay, so it's a middle-aged woman with shortness of breath and fever. What is this? Fibrosis. Fever, remember, fever is very, like it's a trigger, right? You need to keep it in your mind. Exactly, pneumonia. This is pneumonia, but this is the picture that the doctor supplied, right? And honestly, like, I don't know how are you expected to diagnose this, because this is not only pneumonia. This is empyema. This is pneumonia that led to empyema and a collapsed lung. Like this is a collapsed lung. And I don't know how are you going to diagnose something like this on your own in the exam, even with a clinical presentation. Like I don't know, Saha. All right. But this is definitely empyema. All right. This could be blood, just by knowing shortness of breath. How can I say if it is pulmonary embolism or pneumonia? Okay, so as I said, pneumonia, you have a very triggering word. You like this word is exactly RAD, fever, right? When I say fever, this immediately shifts your focus from pulmonary embolism to pneumonia, right? You still have to have a level of suspicion for pulmonary embolism. You have to have it, but like the probability that this is going to turn out to be pneumonia is much higher now, just for the mere fact that this patient has fever. All right, so keep that in mind. A patient with dyspnea and fever, think of pneumonia. A patient with can you point on the empyema? This whole thing is the empyema, the whitish thingy. This whole thing is the empyema. It's a very massive empyema, I honestly think. I don't know how to get that bad, right? But this is the empyema. And how do you differentiate between empyema and, let's say, a bleed? All right, let's say this is, how do you differentiate between this and pulmonary hemorrhage? In empyema, you have pus, all right, and pus has different types of cells, so it's not going to be homogenic. It's not going to be the same color, right? You're going to have spots of a little bit whiter, a little bit darker. You're going to have, it's not going to be uniform color, right? And that's what you can see here. Look at this. This piece here, it's whiter, and this one is darker, right? So this is empyema given the clinical presentation, right? Given that this patient has fever with an abnormal collection in the lung, this is an empyema, all right? Oh, there is an abscess too. Wow, all right. So there's an abscess here. This is honestly a horrible CT scan. But yeah, I don't know what to say. Damn. I know this wasn't the best CT scan. honestly, but like I couldn't find anything better because in pneumonia you don't use CT scans to diagnose pneumonia. You use X-rays. Like even the best option for pneumonia is X-ray. It's not CT. I don't know. Even a collapsed lung, you diagnose it with an X-ray, but I don't know what to say to be honest. But like, let's just move on. All right. So a middle-aged man with upper back pain and dizziness. What is going on here? Lung abscess because of thickened aorta. What's wrong with the heart, Clean? Yes, Emma. Yes, it is a dissection. It's not aortic stenosis. No. You can't see the aortic valves here, or any valves for that matter. Actually, this cut is above the heart, so you can't see the heart, right? You can actually here see the pulmonary vasculature right here, right? This is the descending aorta right here, and this is the ascending aorta right here. So this is not at the level of the heart, okay? So you can't see the valves, but you can see the aorta, all right? And if you take a look here, look at this. Look at this. Can you guys see this? This is a free flap inside the aorta. Diagnostic, خلاص. This is an aortic dissection, all right? What happens in aortic dissection is that you have the wall of the aorta, right? And it splits because the wall of the aorta has 3 layers, right? What happens is that one of those layers is just torn and blood starts going inside this layer, between the layers, giving you this, okay? So this, can you see this? This is one of the layers of the aorta, okay? So aortic dissection. Why did you say aortic dissection? Remember, upper back pain, right? You have an upper back pain with this. If you have upper back pain, you start thinking of, especially with dizziness, okay? Because like dizziness indicates a problem with the perfusion, all right? Or like blood, right? So you start looking at the vasculature, you start looking at the pulmonary vasculature, the aorta, the inferior vena cava, the superior vena cava. You start looking at problems with the vessels, right? And if you take a look here, you can see clear as day. You can see an aortic dissection, right? Was the aortic dissection clear? Perfect. Okay. So 55, male with shortness of breath for 6 months. 6 months, right? What could this be? Six months. 6 months. Yes, perfect. This is fibrosis, all right? Why can't this be pneumothorax? Because of the duration. A pneumothorax is a medical emergency, right? If you don't treat this immediately, patient will collapse and die. So it cannot be pneumothorax, right? This is the first thing. Second thing, it can't be an infection. And the lung isn't collapsed. And the lung isn't collapsed, you're right. There is no collapsed lung on this x-ray. That too, right? But just from the clinical, purely from the clinical scenario, there is no fever too, exactly. So it can, so there is very rare instances where you can get pneumonia without fever, right? But you're not gonna get it for 6 months either. Like you can get pneumonia, sure, but for 6 months, no, you can't, all right? So yeah, this is pulmonary fibrosis. And keep in mind, 55, patient is really old. Well, not really old, but like patient is old, all right? Okay, so this is a CT scan of the patient's chest, all right? What is this window? The A, what is the window of A? A window. And B, actually, they're the same window. Yes, this is the lung window. Perfect, perfect. This is the lung window. All right, and the one on the right is a perfectly normal lung, all right? It's a great lung, amazing lung, all right? And on the left, what can you see on the left? There's a very specific word that is associated with fibrosis. It's very characteristic, very pathognomic. tree, okay, close. Reticulations, amazing. Yes, but reticulations could be seen in other diseases too. There's something that's very, very, very specific. Remember the word honeycombing, okay? The word honeycombing, it's very, oh my God. You see this word, choose fibrosis without reading the question, without reading anything else. You see honeycombing, this is pulmonary fibrosis, okay? Now, what is honeycombing? It's literally, it's just, you know the honeycomb? Yeah. This is honeycomb, all right? And this is literally how it looks like. If you take a look here, wait. In this area, right? This is what we call honeycombing on right? Another thing that you can see is dilated bronchial tree. So peripherally, you should not see the bronchioles. You're not supposed to see them. But if you take a look here, you can see them. See, look at this. Wait, can I use the, okay. Can you see this? You're not supposed to see the bronchiole. This is a bronchiole. You're not supposed to see it. You're not supposed to see this one. You're not supposed to see this, all right? All of this is abnormal bronchioles, right? You're not supposed to see them. Why? They get dilated. Why do they get dilated? You have fibrosis. Fibrosis doesn't dilate anything, right? What happens is fibrosis pulls on stuff, right? So it pulls on the bronchioles, forcing them open. So you have fibrosis on this side and fibrosis on this side, and the bronchiole in the middle, and fibrosis leads to traction. It opens up the bronchioles. It forces them open. It dilates them, okay? So that's why you have bronchioles. You can see them. Actually, I have it here, right? So you have reticulations, like you guys said, right? And reticulations are like axis lines. So like, let me show you a better picture of axis lines. Can you see those white lines? Can you see this white line, this white line, this white line? See, you're not supposed to see this. Look at this line, right? They're few. You can see them, but they're few. But look here, they are all over the place, right? So those are reticulations. Honeycombing, as I showed you, they are on the periphery, all right? This is honeycombing. And bronchiectasis. Bronchiectasis is the traction of the bronchioles peripherally. So you can see them peripherally, all right? So three things you need to remember in fibrosis. Reticulations, bronchiectasis, and honeycombing, all right? Remember those three. If you remember those three, you can answer any questions you need. What was the reticulation? Reticulations are those white lines. Can you see this white line? Those white lines, those white lines, those are reticulations, all right? And this is the actual fibrosis. This is the fibrotic tissue, all right? The reticulations indicate the actual fibrotic tissue, the fibrosis, all right? And due to the fibrosis, they track the bronchioles, they force them open, all right? And you will see hollow black tubes. Those, can you see this? Can you see this? Can you see this? Those are abnormal, and that's bronchiectasis, all right? And honeycombing is cyst formation. There are cysts that are formed peripherally. Usually honeycombing is seen peripherally, and in severe diseases, it's all over the lungs. And this is honeycombing. You can see it right here. It looks like a honeycomb, I guess. I don't know. All right. So this is honeycombing, bronchiectasis, and reticulations. Remember those. Let me check the chest. Bronchiectasis. Thank you, Bashra. Bronchiectasis, dilation of the, yes, Bashra. Bronchiectasis is the dilation of the bronchioles because they get traction. They just get pulled apart. All right. Usually you don't see them peripherally, but because they are being pulled apart and dilated, you start seeing them. Is this clear? Is the fibrosis CT scan clear? Perfect. Cool.
Already know that.
Okay.
Another example of.
See, she threw this slide there. Like, I don't know, but like, it's splenic laceration leading to splenic hemorrhage, all right? And we said that tissue is going to, we said water is going to be dark, right? And then it's going to be like, it's in the middle, right? It's 0 pounds per units. And blood is going to be more, a little bit, but soft tissue is going to be much higher than blood, right? That's why this is the soft tissue, or this is the spleen, and this is the hemorrhage, because hemorrhage is going to appear darker than soft tissue, and water is going to appear even darker than the hemorrhage, right? And when do you suspect splenic laceration? In trauma, right? So patient presents to you with a left-sided pain, left-sided abdominal pain after trauma, right? You suspect splenic rupture or splenic laceration leading to splenic hemorrhage, right? She didn't really give any clinical features with this scan. She just put it there. So yeah, here's a context for you guys. Abdominal pain after trauma. You suspect laceration of any of the abdominal organs, specifically 2, actually 3, the liver, the kidney, and the spleen, all right? There's nothing really else to discuss in this slide. Any questions about this splenic laceration, or the lungs, or the chest, or anything? Okay.
Another example.
Okay, so here she focuses a little bit more on the clinical approach, all right? So you need to use the clinical question to form your diagnostic pathway, all right? So if it's a trauma patient, okay, let's say it's a trauma patient. Are you gonna use x-rays or are you gonna use CT scan? Okay, what if I say that this patient can't breathe or has difficulty breathing? Exactly, see how it changes? So not because the patient is a trauma patient, you would immediately use a CT scan, because the clinical features of the clinical scenario will change your approach, right? It's a trauma patient, but the patient can't breathe. You do an x-ray because you suspect a pneumothorax. But if the patient has an acute abdomen, what are you gonna do? CT scan? Exactly, exactly. You're gonna do an ultrasound. You're not gonna do a CT scan. Yeah? Let's say the patient is a trauma patient and patient is dizzy and has headache. What are you going to use? CT? No, Neil. You're going to use a CT. See? MRI is the last thing you use in acute patients, because a CT scan takes maximum 2 minutes, right? That's like when you're taking your time, right? 2 minutes for a CT scan. An MRI takes up to 30 minutes. If the patient is bleeding in his or her brain, you don't have 30 minutes. You need to do something about it, right? So you will never use an MRI in an acute setting, because MRI takes a lot of time and you don't have time in acute patients, all right? Let me read the check. MRI takes long, never understood when to use when. Okay, Shufi, Bushra. You never use MRI in acute settings, right? Let's get that clear. And you don't use CT scans in pregnant ladies. Those are the 2 concepts you need to get in your mind, right? Now, if the patient comes to you and the patient can't breathe, right? You don't have the time to take the patient from the emergency room to the radiology department, get him a CT scan, and then get him back to the emergency department, right? Because this patient has pneumothorax. And we discussed it before, the best imaging modality for a pneumothorax is a chest x-ray, right? So what to choose and when to choose it depends on the severity of the case, all right? Well, and I went through your exam. They don't usually ask about they don't usually ask, all right? And that's what we're discussing right now, because whether to choose X-ray or ultrasound or as your first line, you'll have to study each disease on its own, which is a lot of time wasted. So you don't do that, right? So yeah, I don't think they will ask about first line imaging modalities, but remember what's the best imaging modality. Again. Yeah, nothing. Okay, so we move on to cases now. So it's an 18-year-old male presents to the ER with abdominal pain. Temperature is 37.9, heart rate is 80, right lower quadrant tenderness. What is the appropriate radiological examination? What are you going to choose for this patient? Ultrasound, ultrasound, ultrasound. Okay. All right. This is your first line imaging modality, right? Ultrasound. You're right. I agree with you. Your first line imaging modality is ultrasound. But it's not asking about your first line, is it? It's asking about the appropriate radiological examination. And your diagnostic, well, first of all, what exactly? It's appendicitis. If you're suspecting appendicitis, your gold standard for diagnosing is a CT. All right. Play. Question. Is the CT with contrast or without contrast? Perfect. Yes, it's a CT with contrast. Any inflammatory condition, use contrast with it. Okay. So here is the CT scan. What can you guys see? What can you tell me? Inflammation indicating, like, how do you know there's exactly edema? Someone said edema, wait. Yes, Sama, edema. There's inflammation, but how do you know it's inflammation? It's due to the edema. You can see edema around the exactly, and it's big, it's enlarged. Perfect. Yes. And one more thing that's very specific in appendicitis. I don't know if she told you about this or not, but if you take a look here, can you see this? Those white lines? Can you see them? Those are fat strands. All right. And fat strands is very pathognomic for appendicitis, right? All of this is written in the notes. You can take a look at it, all right? So three things. You have edema, you have enlargement, and you have fat stranding. This is diagnostic for an acute appendicitis, okay? So this is acute appendicitis, perfect, done. Okay, case number 2, Dr. What is the edema? Okay, wait a second. Let me go back. All right. Actually, I can't use the pen. All right. This, if you look at this, you can clearly see the border of the appendix. All right. It's a line that's whiter, a little bit whiter than the surrounding. Can you see what? Can you see what's surrounding it? This white shadow. This is the edema. All right. Perfect. Cool. All right. Case number 2, 36, male. Present to the ER with a right lower quadrant abdominal pain radiating to the groin. Temperature is 36.3, heart rate is 80, CBC is normal, urine test shows microscopic hematuria. Microscopic hematuria means there are RBCs in the blood, right? What's the appropriate radiological examination? CT. Yes, Rada. Yes, yes, perfect. It is CT. CT with contrast or without contrast? With contrast. But what are you guys suspecting? What do you think there's what does this patient have? Kidney stone, yes. And a kidney stone is not an inflammatory condition, and it's not a vascular condition. A kidney stone is an obstructive condition, so you don't need contrast with it. All right. Also, keep in mind that if you suspect any pathology in the kidneys, don't use contrast. Right? Because remember, what is one of the contraindications for using IV contrast? Renal impairment. And if you suspect there's something wrong with the kidneys, do not use dye. Do not use IV contrast because you can make this patient go into acute renal failure. All right. So keep that in mind. It's not an inflammatory condition. You're not suspecting bleeding, right? Your differential diagnosis is a stone, right? So the best imaging modality is a CT scan without the contrast, right? Can everyone see the stone? Is it clear? Okay. Here's the stone. This is the stone here. Here's the stone here. All right. Sayuritic straw. All right, case number 3. A 28-year-old female to the ER with abdominal pain. Temperature is 37.9, heart rate is 80, right lower quadrant tenderness. What is the appropriate radiological examination? Guys, focus. Appropriate. Yes, Ghada, thank you. Thank you, Ghada. She could be pregnant. Do you guys know if she's pregnant or not? You don't. I never said she's not. Also, not everyone presents to you knowing if they're pregnant or not. Maybe she is pregnant, she doesn't know that, right? Always keep this in mind. Anyone who is in a childbearing age could be pregnant. She just might not know it. All right? Yeah, keep that in mind, right? She's 20 years old. She's in a childbearing age. She's a female, all right? So your most appropriate radiological examination, ultrasound is a good examination. I'm not going to argue. I'm not going to tell you no. It is a good exam. It is a good radiological choice. But the best is going to be an MRI. MRI is going to be, CT is contraindicated. Yes. Until you prove that she's not pregnant. Just do a beta HCG test or a pregnancy test, done. She's not pregnant, do a CT scan. All right. So ultrasound, as I said, it's a good choice. I'm not going to argue against it. But you do an MRI. MRI is the gold standard, or like the best imaging modality you can get. All right. Guys, don't do CT with contrast. Don't do CT with contrast. Okay. It is appendicitis again, but this time your clinical presentation is different, and that's why you change your modality. All right. Okay. Reading an MRI is going to be with Harun. I'm not going to spend time reading this. Just we'll deal with this with Harun, inshallah. All right. Case 4. Oh, okay. This case I made. The previous 3 cases were given by the doctor. I did this case, right? And you'll need to focus shwaya because it's a little bit tricky. So it's a 36-year-old male who's slim and tall, presents to the ER following a multi-vehicle accident with headache, several episodes of losing consciousness, and chest pain. Temperature is 37.2, heart rate is 120, blood pressure is 140/98. He has right mydriasis and absent right lung sounds. What is the best imaging modality? CT. Okay. Any other answers? CT. All right. Any other answers? Who said lucid interval? Yes, Aya. Yes. Perfect. Lucid interval is an epidural bleed. All right. Okay. So in this case, if you should choose one imaging modality, there's something called a pan CT scan. And a pan CT scan, from the name, it's a CT scan for the whole body because you have multiple presentations. All right. Now, I want you guys to give me, what is this patient having? Like, what do you think is going on with this patient? Nobody has an answer. Tension pneumothorax. Good. That's number 1. What else? Brainstem is affected. I wouldn't say brainstem, no, but yes, SEMA, perfect. Epidural hematoma or epidural hemorrhage. Amazing. What else? One more. Come on. Please tell me you got it. He is a slim and a tall patient. He is slim and he's tall. Come on, please, someone say it. Marfan's, thank you, Aya. Yes, patient has Marfan syndrome. Patient has hypertension. Patient has an aortic dissection. Huh? See? It's a weird case. I know. Sorry. I just had to like have a lot of diagnosis in one patient. I don't know. I thought it's cool. Anyways, patient is slim and tall, presenting after an accident. Okay, so slim and tall should trigger Marfan in your head. Okay, على طول. When the question gives you physical attributes of the patient, always consider something, because they're not just going to give you and tell you the patient is slim and tall for nothing, right? It has a clinical significance, right? So patient slim and tall, you suspect Marfan. Patient presented with a multi-vehicle accident, so there's history of trauma, right? Patient has headache and losing of consciousness, so you suspect something in the brain, right? Patient has chest pain and he has absent right lung sounds. You suspect pneumothorax. Patient has right mydriasis. Mydriasis, epidural bleed. Remember the table that I showed you guys? So yeah, basically this is the case, Yani. I don't know. Oh no. Okay, we lost power. My laptop died. Just give me a second. Pan CT in this case, all right? So you'll have a CT scan that scans the whole body, and it's much faster than doing a brain CT, than doing a chest X-ray, than doing an abdominal ultrasound. Just do a pan CT of the whole body, all right? And that's basically it. I think the case was the last case in the lecture, I believe. Like, do you guys have any questions? Like, if you have any questions, just go ahead. What does mydriasis tell us? It tells you that there's increased intracranial pressure, right? And when you have increased intracranial pressure, it's due to something compressing on the brain. And in this case, it's a trauma case. So you think of hemorrhage, right? So the blood is collecting, and it's compressing the brain, leading to an increased intracranial pressure. And one of the signs of increased intracranial pressure is mydriasis. You're welcome. Just let me. Oh my God, it's going to take time. Think 3 more questions. Wait. In the case of the 28-year-old female, we do CT first try. Okay, I forgot what the case is. Wait, I'm joining the call now. I'll show you. Okay. Okay, much better. Share the screen. Share the screen. Okay. Back to the lecture. You said the 28. You do CT first, right? She's 20 the female. See, that's the whole point. She's a female. That's why you don't do a CT scan. You do an ultrasound first. Yes, you do an ultrasound first. Then you move on to an MRI. That's what they did. They did an ultrasound right here, and then they moved on to the MRI. You're right, Bushra, yes. Right, so this is case 4. So what is this? No problem. What type of hemorrhage is this? Epidural, perfect. Because of what shape? What is this shape called? Biconvex, perfect. Cool. Okay, what's this? What's on the right? Wait, what's on the right? Aortic dissection, perfect. Right here and right here. Okay. And what's on the left? Perfect. Collapsed lung. Right there. See? This is the lung and this is collapsed. Right? What is this window? And what's this window? What's the right window? Soft tissue. Perfect. Perfect. Mediastinal, yes. Mediastinal is the soft tissue, yes. But guys, remember, when you say soft tissue window, it's a very vast, it's a very big window, all right? So try to be specific. So when you're in the chest, say mediastinal window, and if you're in the head, say the brain window, all right? Just keep it like this. You're not wrong. It is a soft tissue window. You're 100% right. But this is a very general term, right? So if you're in chest, mediastinal, in the brain, it's called brain. If you're in the abdomen, you have liver window, you have spleen window, you have stomach, you have a lot of windows, right? But you're not wrong. It is a soft tissue window. And on the left, it's the what window? Lung window. Perfect. Yes. 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 Perfect. Again. Yeah.
Okay, I'm going to stop here. That I went a little bit beyond time. I just wanted to make sure that you start to grasp most of the concepts about.
I thought someone was speaking to me. Oh my God. Okay. Anyways. Okay. Any question in the physics of CT or the clinical application of CT? Anything? Clear? Perfect. Okay. Very good. Very good. All right. I think it's appropriate to take a break now. You guys agree? You're welcome, Ghada. Perfect. Okay. It's 4:11 right now. How about we come back at 4:25? So basically, remember how in CT and in X-rays, the source of the rays is external, right? It's the tungsten in the X-ray tube. In nuclear imaging, you are the source of the rays. So what we do is we inject you with a radioactive isotope, right? And from within you, this radioactive isotope is going to emit gamma rays, and we detect those gamma rays. That's basically nuclear imaging in a nutshell, all right? So I don't know what she wants you to know from the slide, honestly. It's just nothing useful about it, okay? So let's move on to the next one. All right, I added this lecture. So a PET radio, so we give you a radio tracer, all right? As I said, it's injected into you, either injected or ingested or inhaled. It could be inhaled too, all right? And this compound is going to emit gamma rays, all right? So each tracer is going to have the radioactive molecule in it, and it's going to have the organic molecule in it, right? Why do we need the organic molecule, right? Because if you give me the the radioactive molecule alone, it's not tissue specific, right? So when you try to detect it inside my body, you're going to find it throughout my body. It's just going to go everywhere, right? So what we do is we give a biological agent or a biological ligand or an organic ligand that is specific to a certain tissue, right? So for example, tumors, they uptake glucose a lot. They love glucose, right? So they have preferential uptake for glucose. So what we do is we get the organic molecule that's glucose, and then we attach to it a radioactive molecule, right? So when we ingest this, the radioactive molecule is going to be detected inside the tumor only. Why? Because the tumor will uptake glucose. Wait a second. So as we said, with no problem. So as we said, we have a tracer, and part of it is radioactive, and part of it is organic. And I gave the example of a tumor, which uptakes glucose a lot. So what we do is we attach a radioactive molecule to the glucose so that it's only detected inside the tumor. Is this part clear for everyone? Okay, and there's like other examples. Like for example, the thyroid tissue is going to reuptake iodine. So what we do is we get iodine and we attach a radioactive molecule to it. So it's only the thyroid. And all right, so this is just an example. And attaching a radioactive molecule to a glucose molecule or any organic ligand is called labeling. So what you do is, so technically you are labeling the radioisotope using a biochemical molecule. All right, the process is called labeling, and you can get the radioisotope inside your body using an IV injection, so into your veins out of the way, or inhalation or ingestion. You can just swallow it. So yeah.
So what are and
All right. So wait a second. All right. So here she just wants you to know two things, right? An isotope has a similar number of atomic numbers. Okay, so your number of protons is the same, because if you change the proton number, you change the molecule, right? Like, what's the difference between oxygen and hydrogen, right? It's the number. I mean, that's a bad example, but the point is, when you change the proton number, you change the element. So an isotope will have the same number of protons, but what will differ is the number of neutrons. So, for example, wait, I have. All right. So fluorine has normally the stable fluorine is 9 protons and 10 neutrons. All right. The isotope of fluorine has 9 protons, so protons don't change, but it has 9 neutrons. All right. So that's what you get. And an isotope is unstable, all right? And that's what you want. You want an unstable molecule inside you. Why? Because a stable molecule is not going to emit gamma rays, but an unstable molecule is going to emit gamma rays, and that's what we detect, all right? And I'm going to explain now how we do that. Yeah, that's what she wants you to know from this slide.
historically,
right? Okay, this is again history and like who won the Nobel Prize. I don't know. Just go through it if you want. Then you have the, okay, so an isotope is very unstable. It undergoes a process called decay, right? Called decay. And in a decay, the ultimate goal of an isotope undergoing a decay is to become stable, because an isotope is unstable, right? So after decay, what happens is you will end up with a stable isotope, right? And radiation and a particle, all right? And radiation in this case is gamma particle or gamma radiation, and the particles is something called a positron, right? I'm going to explain to you what a positron is in a bit, okay?
And this is why we have already.
Okay, I'm going to explain this in a bit. Wait, you don't need to know. Okay, so this slide explains to you how isotopes undergo decay, all right? And an isotope will either undergo decay using positive beta rays or negative beta rays, all right? You don't really need to know what does that mean. You just need to know that you have 2 types, beta positive or beta negative, right? And it's beta negative when you have low number of neutrons, and it's beta positive if you have high number of neutrons. So if the normal, for example, is 10 neutrons and you have 12 neutrons in the isotope, it's going to undergo decay using positive beta decay. If the normal is 10 neutrons, but the isotope has 8 neutrons, it's going to undergo decay using beta negative decay. Are we clear till now? Damn, we all slept, huh? Okay.
In the medical field.
Okay, so those are some radioactive compounds we use.
The first one is technetium or technetium, whatever you want to call it, really, and it's diagnostic. You have what are the three components that it will decay to? Okay, so it can decay. After decaying, the isotope will become a stable isotope. So that's the first thing. Okay, originally it's unstable. That's why it undergoes decay. So it will end up being a stable isotope. It's also going to end up emitting gamma rays, and it might or might not give off a molecule or a particle. And this particle is called a positron. Okay, and I'm going to explain to you what a positron is in a bit. All right, so technetium is actually diagnostic. It's only used for diagnosis. And then you have the iodine 131, and iodine 131 is diagnostic and therapeutic, and it's used in the thyroid studies. All right. Yeah, basically those are the two that you need to focus on, really. All right.
In the mid.
Didn't you just say unstable molecules will emit gamma rays? Yes, they would. All right. So if you have an unstable isotope, all right, it's gonna decay, and when it decays, it will become three things: a stable isotope, and it becomes stable because it gets rid of the unstable rays or the unstable energy. And the unstable energy is the gamma rays. See, so if it becomes stable by decay, how will it emit? That's the point. When it decays, it will emit those three at the same time. Exactly. So when it becomes stable, it stops emitting anything because it's stable. It doesn't need to emit. What is the difference between beta negative and beta positive? You don't need to know that. It's a lot of details for you guys, and it's confusing. It's very, very confusing. So just know that okay, so let's say that the normal molecule has 10 neutrons. Okay, if the isotope of this molecule has 12 neutrons, so it has a higher number of neutrons, it will undergo a beta positive decay. Okay, but if it has a lower number of neutrons, so let's say 8 neutrons, it's going to undergo a beta negative decay. Okay, you don't need to know what does that mean. You just need to know that. Okay. Okay, here she's trying to tell you that X-ray, the source is outside, all right, and then the X-rays will come from the outside, hit your body, and interact with your body, and then give you the image. All right, that's X-rays and CT, by the way. And then you have gamma rays, but in this case, the gamma rays are coming from within you. All right, you are the source of the rays, not something else. So you are the source of the rays, and this rays will go to a gamma camera or a gamma detector, and this will give you an image. Basically, that's what this slide is trying to tell you. Okay, so she starts with giving you the VQ scan, or ventilation perfusion scan. All right. So what happens in a ventilation perfusion scan is that you are given an isotope, all right, and this isotope will assess both the function of your lungs by evaluating the ventilation of the lungs, and it will also assess the perfusion, how much blood is going to your lungs. And the most important use of a VQ scan is in pulmonary embolism. Remember how we said that you use CT angio in CT pulmonary angiography in pulmonary embolism. This is your gold standard, right? CT angio. But what if the patient is pregnant? If the patient is pregnant, you can't use ultrasound on the chest, right? So what you do is you do a ventilation perfusion scan. So if you get a question in your exam that says this patient might have pulmonary embolism, but she's pregnant, right? What are you going to do? You're not going to choose CT scan. You're going to choose a VQ scan, a ventilation perfusion scan, right? So in this case, the lungs have a preferential uptake for albumin. And that's why we tag our radioisotope with albumin, right? Albumin is a type of protein in the blood, right? Okay, so she wants you to know what's the difference between a PET scan and a SPECT scan. All right. So let me tell you what's the difference between PET and SPECT. All right, let's start with the physics of a PET scan. I'm sorry about this. Okay, this is not going to work. So let me try to explain it to you. All right. Let's take the molecule fluorine, right? And I can't really illustrate this, so please focus with me. Let's say we have the atom fluorine, right? And fluorine has 9 protons and 10 neutrons. This is the normal one, right? And the isotope has 9 protons and 9 neutrons. So you lose 1 neutron. That's why it's an isotope, right? And this is an unstable isotope, all right? So what will happen to the unstable isotope? We just said it will undergo what? Decay. Perfect. Yes, it will undergo decay. And when fluorine undergoes decay, it loses a proton, right? It doesn't lose a neutron. No, it loses a proton. And remember what I said, when you lose a proton, you change the element. So it's no longer fluorine. And what element has 8 protons? Oxygen, right? So fluorine will undergo decay and it will become oxygen, right? It will have 8 protons because it lost 1 proton, right? And it will have 8 neutrons. Okay, so what will exactly become a stable isotope? Perfect, which is oxygen, right? And this process, because you can't just switch from an element to another element without expecting anything to happen, like you're changing molecular functions here, right? So what will happen is when 1 proton is lost, yes, you lost a neutron. So originally, fluorine is 9 protons, right, and 10 neutrons. This is the normal fluorine, which we don't care about, right? We care about the isotope of fluorine. The isotope of fluorine is 9 protons and 9 neutrons. You lose 1 neutron. Okay, it's still fluorine because you did not choose the number. You did not change the number of protons. It's still fluorine, but now it's an isotope of fluorine, all right? And it's 9 protons and 9 neutrons. Now, this is very unstable. That will undergo decay and it will change to oxygen. And it will change to oxygen because 1 proton, I forgot to mention this part, this 1 proton is not going to just disappear. No, it's going to switch to a neutron. You guys, wait. So it decays, all right? So you lost 1 proton. Now you have 8 protons, and that's oxygen. What will happen to the number of neutrons? It will lose 1. You will lose 1 neutron. So it's going to be 8 protons and 9. Wait. Oh my God. I'm sorry. Wait a second. This is confusing. Okay. The isotope is 18. I don't know if you guys can see it. It's so bad. I wish I can draw or something, but like it's really bad. See, point is, you're gonna lose 1 proton, and that's why it's gonna change to oxygen, right? And when you lose 1 proton, this proton is gonna go and it will become a neutron. Okay, you're not gonna lose it, right? It's just gonna switch back to a neutron. Okay. So the molecular structure will change to oxygen, right? But now you'll have 8 protons and 8 protons and 10 neutrons. Yes, Bushra. 8 protons and 10 neutrons. Okay, this is the oxygen that we'll get. This is what's stable now, right? So the unstable fluorine will become stable oxygen when it has 8 protons and 10 neutrons. Okay. In the process of losing 1 proton to become a neutron, you lose energy. And this is the unstable energy that the fluorine is trying to get rid of. And it gets rid of this energy by emitting what? What do we detect? Gamma rays. Yes, perfect. So when you lose the proton to a neutron, you lose energy, and this energy is gamma rays. So it's not an oxygen nor fluorine. No, it is oxygen now. شوفي. If your number of protons is 8, that's oxygen. Okay? If it's 9, it's fluorine. Now we had fluorine, but it was unstable fluorine. It had 9 protons. So what you did is the fluorine underwent decay by losing 1 proton and transforming or converting to oxygen, which is a much stable or more stable element. And in this process, it just emitted. So it becomes an oxygen isotope. Yes, it does. A much more stable isotope. Okay? Yes, it's a stable isotope of oxygen. All right? This happens all the time, or according to what you're using. This happens all the time. By all the time, you mean when we inject the radioactive compound in our bodies. Yes, this happens when you inject it, because all of those isotopes are not naturally occurring. Those are artificial isotopes. We make them for the purpose of using them in our bodies for PET scans, right? So yes, they happen all the time. Is this clear? Okay. By the way, naturally occurring isotopes, but they're very rare and they're very unstable, like uranium. Uranium is an isotope technically, and it's naturally occurring, right? But we don't come close to that because it's very, very unstable. So what we do is we create our own isotopes that is not as destructive as uranium, you know? So we make cute stuff like technetium and fluorine, stuff like that, you know? Stuff that's not gonna kill us, basically. All right, so that's the, okay, so what happens is, now that you have emitted gamma rays, right? So this is how a SPECT scan works, okay? Not the PET scan, this is a SPECT scan. A SPECT scan, easy, خلاص, you have a radioactive decay, emitting gamma rays, you detect the gamma ray, done. That's the what? The SPECT, right? That's SPECT, okay? Now back to PET scans, all right? In PET scans, it's the same process, all right? But instead of emitting gamma rays immediately, what happens is you will emit a positron. And a positron is a molecule that has the exact opposite charge of an electron, okay? And it's abbreviated as E+. Wait, do I have a picture that explains this?
These?
I thought I did. Okay, so if you guys look here, this is a positron, okay? And a positron is a molecule or a particle that has the exact opposite charge of an electron, right? So it will get, after the decay, right? A positron will be emitted, right? And when a positron is emitted from the atom, it's gonna travel, right? It's gonna go somewhere. And if it hits an electron, you will get 2 gamma rays that are exactly in the opposite directions. I think a picture would be so much better to explain this. Just give me a second. There. Oh, yes. Yes, thank God. Okay. So if you guys take a look here, all right, this is the positron, okay? خلاص, it's emitted from the nucleus now. And this is the positron, all right? It will just keep on going until it hits an electron, all right? And when it hits an electron, both the positron and the electron will be destroyed. They're just gonna disappear, right? And when that happens, you're gonna get 2 gamma rays. And those 2 gamma rays are gonna go in the exact opposite direction. Can you see this? One go this direction and the other will go this direction. It's exactly opposite direction, 180 degrees, all right? It's a straight line. And those two gamma rays are then detected inside the machine. Can you guys see this? So this will be detected. And this ray is much closer to the detector than this ray, صح? So this ray will reach the detector faster than this one. And that's how the computer can figure out where is this originating from, by calculating how fast did the ray reach the detector. Does that make sense? Okay. Do you guys have any questions? You're lost. Okay. All right. You have, okay, forget about SPECT. Okay, forget about SPECT. Let's focus on PET scans. Okay, because those are the most important ones. Those are the better quality ones. All right. All right. So it's the same as SPECT, but with positron. Yes, 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 you're right. So it's the same, right? But instead of getting one gamma ray, which happens in SPECT you get only one gamma ray, remember? Here you get two gamma rays, you don't get one. And you get two by the positron. So a positron is going to be emitted from the nucleus, right? Because it's decaying. And when an isotope is very unstable, it starts decaying, it releases either gamma rays or positrons, right? In this case, you release, and this depends on the radioactive molecule that you give, right? So is it technetium? Is it fluorine? Is it gadolinium? What is it? It depends on the molecule, whether it releases positron, whether it decays using positron decay or gamma ray decay, right? So in this case, the radionuclear isotope that you use decays by emitting positrons, right? And when a positron is emitted, remember, positron has an exactly opposite charge of an electron. So positron is positively charged and an electron is negatively charged, and they have the exact opposite charges, right? So when they hit each other, when a positron is emitted from the radioactive isotope that you gave the patient, and it hits an electron, both the positron and the electron are going to be annihilated. They're just going to disappear, right? And when this happens, you will get two gamma rays that are in the exact opposite directions of equal energy. So if you take a look here, the positron hit the electron, right? This happened. What will happen is both of them will disappear, but you will get two gamma rays, both of which are in the exact opposite direction of each other, and both of which equal in energy, all right? And what happens is the patient is surrounded by detectors, by gamma ray detectors, right? And what happens is we just detect the gamma rays. And that's it. Does this make more sense now? I can repeat again, Adi. It's fine. I can repeat again if you guys want. All right. By the way, guys, you're gonna take this again with the doctor, so don't feel like you're supposed to come out of this 100% like understanding everything, because you're gonna take it with the doctor, and it's gonna be, I think it's gonna be clearer when you take it with her. I hope. All right. So that's basically it for the PET scans, right? Now comparing SPECT, wait. You mentioned something about how fast a ray is detected. Yes, okay. Okay. All right, wait a second. Okay, so take a look on this, right? The atom, the electron that is, okay, so your body is filled with atoms, huh? We are made out of atoms. So it hits an electron of your own body. Okay. All right. One point, does all atoms contain positrons? No. Not all atoms contain positrons. Only the radioactive molecules that we know emit positron will emit positron, right? It has to be radioactive. It's something that we make. It's artificial radioactive isotope. Okay, so not all atoms can release positrons, right? You have to make them unstable enough for them to release positrons. Okay. So regarding the distance thing, All right. Let's say that the gamma rays will originate on the right side of the patient. All right. Or the left side of the patient. Sorry, this is the left side of the patient. All right. The gamma, we said there are two gamma rays, right, on the exact opposite direction. This one is going to reach the detector faster than this one. All right. And this fact is going to tell the computer that the source of the rays is on the left side of the patient, because the left ray reached me faster than the right ray. Did you get it? All right. All right. And that's basically really it, you know, setting any. All right, so SPECT versus PET. All right, so PET is the superior scan, but SPECT is the easier scan. It's the whole idea of X-rays and CT scans. You know, X-rays is the more accessible one. It's the easier one. It's the widespread one. But CT scans are the better one. So they're the more superior scans. Same exact thing with SPECT and PET. SPECT is like the X-rays of the nuclear medicine. PET is like the CT scans of nuclear medicine. So PET gives you 3D acquisitions, real 3D scans. This is good about PET, and its sensitivity is very high, right? But SPECT, it gives you a 2D image that can be reconstructed into a 3D image. All right, and this will decrease the sensitivity of your scan, because reconstructing a 2D image is solely based on how powerful your computer is, right? So, and computers can do mistakes, right? But a PET scan will give you a real 3D scan. SPECT scan will give you a reconstructed 3D scan. All right, but it's better because it's faster, it's cheaper, it's more accessible. It's readily available, and it's used in everything, really. All right. So that's basically the difference between SPECT and PET scans, right? There's something cool called a PET CT scan, and because a PET scan assesses the function of organs, all right, or masses. It assesses the functionality, but it doesn't. But the localization of the defect is very bad. All right. So if you take a look at this is a PET scan, all right? If you take a look at it, you can see that there's function, there's something happening here. There's metabolically active lesion, right? But you can't exactly tell me where that thing is, right? You can't tell me, is it invading the spinal, is it invading the vertebral column or not? Is it invading the coastal ribs or not? You can't tell me that. But when you add CT scan to it, see, it becomes much clearer. So let me show you a better PET CTs. Honestly, I'm obsessed with PET CTs. They're so nice. Here's a PET CT scan. See, this is the PET CT. This is a CT, and this is a PET scan, and it basically just incorporates both of them into one scan. So you can see the anatomical details plus the functional details, just in one scan, right? They're very expensive, by the way. So that's a PET CT, really, and we just explained it. So we're done with the physics. A planar scan is basically a SPECT scan that's 2D, right? So a 2D scan is called planar. A reconstructed 3D is called SPECT. This is a planar because it's 2D, and this is a SPECT because you can see it from multiple views. You can see it from multiple areas. So posterior, anterior, left anterior oblique, right anterior oblique, right posterior oblique, left posterior oblique. So you can see it from different views, and that's why it's a reconstructed 3D. So this is SPECT. This is a planar scan, and this is a PET scan. Planar is the origin of SPECT. Planar is the basics of the basics. So yes, it is the origin of SPECT. All right. It's like evolving. They're just evolving. You have planar, then SPECT, then PET, then PET CT, then PET MRI. Keeps on going. All right. Okay. So case number 1, a 68-year-old female known to have breast cancer. 3 years ago, presents with pain in the left hip. what would you guys choose for this patient? A PET scan? Okay, you can choose a PET scan, but why? What do you think she has? Yeah, that's a very good thought. That's a very, very good thought. Yes. You can start with an X-ray, all right? You can start with an X-ray because, again, bones, all right? And you can see here, because keep in mind that she's old. She's 68 years old. So you should have a high level of suspicion for hip fractures because it's very common in these patients that they get hip fractures, all right? So you start with an X-ray, but ultimately, due to the history of breast cancer that she has, you should have a high level of suspicion for metastasis too. And that's what you do. Can we do CT? CT for bones is a bad idea, generally. CT for bones is a bad idea. If you want to do something for bones, you do MRI. Can we do CT on bone, right? You can see metastasis on bone, right? Yes, you can. Yes, you can. You can see a lytic lesion. You can see that something is eating the bone up, right? But you can't tell if this is a tumor or not. You can't tell if this is metastasis or not. Like, look at this. You can see that it's being eaten up. Can you guys see it? Wait.
To add.
And there. Can you guys see this? The bone is getting eaten up. Something is eating up this bone, but you can't tell. Is it a tumor or like what is causing this? You don't know, right? So what you do is you do a PET scan, and that's what you get. This is what you get. Can you see those focal areas of uptake, right? Now, in bones, the organic material that we use is bisphosphonate. Okay, we use bisphosphonate as the organic material, and we use technetium as the radioactive molecule. So your bone scan is a technetium 99 scan. Can we explain why did we choose PET? Because you're suspecting metastasis, and metastasis is any tumor, right? So you're suspecting a tumor, and you can't tell from the X-ray here. Wait, from this X-ray, you can't tell if this is metastasis or it's just it could be an infection. Something is eating up this bone. It could be something, anything really. So you want to know, is this metabolically active or not? Because if it's metabolically active, this can confirm your diagnosis of metastasis. The whole black is metastasis. Yes.
And indeed,
So you take a look here. There's metastasis in the iliac fossa here, right here. The whole pelvis is eaten up. The spine right here. Some of the costal, the ribs, scapula. It's all over the place, right? And she has in the femur and the tibia. She has metastasis. This is metastasis. Okay. So a bone scan is used when you suspect bone pathology or bone cancer, especially metastasis. All right. So what we use is bisphosphonate, and we tag it with technetium 99. Okay. I don't know, by the way, if you need to remember that a bone scan is a technetium 99 scan bound to bisphosphonates or not, but I would say know them, especially they're not a lot. So just keep them in mind. All right.
And
again, bone metastasis again. Guys, can someone tell me why is it dark here? Why do you guys think it's dark here? Okay, this is the bladder, but what does that mean? It's not metal. No, it's not metal. It's dark here because remember, the kidneys excrete the dye. The kidneys excrete the radioactive label, right? So at some point you will see high uptake here because it's in the kidneys, and right now you can see it right here because it's in the bladder, because that's how you excrete it. All right.
on the left-hand side, okay.
All right. An 8-year-old boy brought by his mother due to fatigue and loss of appetite. The boy has complained of repeated attacks of urine infections. Okay. Slightly febrile, otherwise normal vital signs. Urine test shows slightly increased WBCs. Renal function is normal. what is the appropriate radiological examination? What are you going to do to this patient? Why SPECT? He's 8 years old, right? And he has infections. Thank you, Sema. Yes. Yes, you are going to do an ultrasound, okay? Guys, remember, nuclear imaging is the use is very limited. You don't use PET scans a lot or SPECT scans a lot, all right? So when something like this comes to you, the most appropriate radiological examination is going to be ultrasound, because that's how you view the urogenetic system. You do an ultrasound, and that's, as you can see right here, right? It's basically just an infection because children are, yes, exactly. And this is another reason why you don't give PET scans and for children. They're still growing. You're giving them PET scans only for tumors. No, PET scans are not only for tumors. PET scans are for tumors. PET scans for cardiac function, for renal function, for pharmaceutical. Sometimes pharmaceutical companies would use them to see where the drugs get deposited. So let's say they have aspirin, for example, they will tag their aspirin with a radioactive isotope, and they will just check where does this drug go in the body. You know, it has a lot of functions, right? But it's always the last ditch radiological imaging you use. So this kid has a UTI. He has chronic UTI. So he has multiple recurrent UTIs, leading to scarring, right? It led to scarring of the kidneys. And when you have scarring of the kidneys, you want to assess the renal function. And you assess the renal function by doing a SPECT. So who said SPECT? RAD, صح. Yes, RAD. We do a SPECT, right? And it's called a renal scan. Okay, the first one was a bone scan. It's bisphosphonate tagged with technetium-99. In this, just name you raise your hand if you want to say something. Go ahead. All right, so the bone scan is bisphosphonate tagged with 99 technetium. A renal scan is technetium bound to dimer-captosuccinic acid. All right. I don't know if you need to remember this. I'm just saying. All right. So a renal scan is technetium-99 bound to dimer-captosuccinic acid. Right. So this will be used to assess the renal function. And as you can see, guys, look at this. For me, on like now, this looks normal, right? But over time, you can see defects here. You can see filling defects. And you can see that this kidney is lighter than this kidney. All right. This indicates scarring, and it indicates decrease in the function of the kidneys. I'm so confused. When do we use PET versus SPECT? We use the here because scarring. I really worry about function. When we use SPECT, I'm confused. Okay. When do you use SPECT and when do you use PET depends on the molecule you're using. All right. So this one is a SPECT. Okay. It does. There is no. Because like for example in a bone scan like this one, right? It has to be a PET scan because you don't have an alternative. Okay. Like you can't do a SPECT scan because there is no molecule that will bind to bones and will give you a SPECT scan. You get me? It all comes down to the molecule used.
Even though.
Okay. So again, yes, you use the SPECT scan in this case because you are concerned with the renal function, so you want to assess it, and that's how you do it. Right? You can assess it using other blood tests like creatinine and whatever, but they're not 100% accurate. All right, so creatinine clearance is not the best way to assess the renal function. All right.
Even though this case.
All right, so a 27-year-old female with shortness of breath. She's 11 weeks pregnant. Physical examination, you're welcome, Tom. Physical examination including lower extremities was normal. The lab includes D-dimers is normal. The ER doctor is suspecting pulmonary embolism. What is the appropriate radiological examination? Do not disappoint me, Ghada. No, no, no. She's 11 weeks pregnant, guys. All right, let's get this out of the way. She's 11 weeks pregnant, so you don't do CT, right? And we don't use ultrasound on the chest because you have bones, all right? And bones will obstruct the view of ultrasound. So you don't use ultrasound on the chest. You don't use ultrasound on your head. You don't use it on your brain, all right? And you don't use an MRI, no, because this is a pulmonary embolism, and you don't have time to do an MRI. Please, someone say VQ scan. Someone say VQ scan. Oh, come on, guys. Yes, use a VQ scan. All right.
This is
A VQ scan, a ventilation perfusion scan. All right. And remember what we said? Albumin. There's preferential reuptake of the lungs to albumin. That's why we label technetium 99 to albumin. Okay. And the good thing about VQ scan, right now you're concerned about the perfusion. Okay. So it does assess your perfusion, but also assesses your ventilation. So it assesses the function of the lungs, not only the blood supply. And if you take a look here, you have a filling defect. It's called a filling defect. All right. So blood is not reaching this area of the lungs, indicating a pulmonary embolism or something obstructing the pulmonary vasculature. All right. Was this clear? Perfect. Cool. All right. Okay, 35-year-old female with neck swelling. Examination revealed hard swelling of the thyroid gland. Thyroid gland. The laboratory tests are normal. The physician suspected thyroid nodule and ordered an ultrasound. Aspiration confirmed the diagnosis of thyroid cancer. All right, patient has thyroid cancer. What is the role of nuclear medicine in this case? Okay, before you answer this question, what isotope do we use in this case? Iodine, perfect. Yes, we use iodine. And iodine in this case, is it diagnostic or is it therapeutic? Both. It's diagnostic and therapeutic. Depending on what? When does iodine become therapeutic? When you increase the dose, right? So if you give a low dose of iodine, it's diagnostic. Perfectly. Yes, the concentration of the iodine. So if you give a lot of iodine, radioactive iodine, it ablates the thyroid, and it's called radioactive ablation of the thyroid tissue, right? And we do this all the time in Graves' disease and in thyroid cancer. You ablate the thyroid tissue using a high dose radioactive iodine, all right? If it's a low dose radioactive iodine, it becomes diagnostic. It does not destroy the tissue of the thyroid, all right? Treatment of advanced metastatic thyroid cancer, detection of recurrency. Yep. All right.
This case highlight, this is a 56-year-old.
Okay. Sure, guys, you're gonna, because honestly, like the remaining are just like, wait a second. Okay, so you have 2 more cases, actually 3 more cases, all right? I think it's better to wait for the lecture with the doctor for the rest of the cases, all right? And inshallah, if this gave you a better overview of what to expect when the doctor gives you the lecture, inshallah, it's going to be easier for you guys. I think I'll conclude here, all right? And I'll leave the rest of the cases for the doctor to talk about. Do you have any questions in CT scans, either physics or clinical applications or PET scans? I would love to answer your questions right now. You're welcome, guys. You're welcome. Thank you. Yeah, I think I'm done. Okay, and wait a second, let me just type in the chat. Why did it go direct messaging? Everyone. Okay. Paste. There you go. Okay. All right. This is my phone and my email in case you want to ask any questions. I think I saw questions. Wait. Can you please repeat the VQ scan? Okay. So a VQ scan is a nuclear scan that you use to assess the ventilation and the perfusion of the lungs. Okay. And we commonly use the VQ scan in cases of pulmonary embolism, specifically in patients who cannot undergo CT angio. All right. And those patients are most probably pregnant women. All right. So what happened is we tag albumin to technetium 99, and we make the patient either inhale it or IV, or we give it through IV, and we detect it. All right. And in this case, you can see that there's a filling defect right here. If you can take a look here, the lungs is not perfused completely. So the dye or the radioactive isotope is not reaching all the way to the lungs. All right. Meaning there's an obstruction. All right. And since this is the perfusion part, it means the blood is not going there, not the air. Air is going perfectly. See, look at this. Air is spreading throughout the lung perfectly. But in the perfusion part, the blood is not reaching to the periphery of the lungs, meaning there's an obstruction or a pulmonary embolism. So if you get a case of pulmonary embolism in a pregnant lady, your test is VQ scan, not CT angio. All right. I think we're done. All right. I sent you my email. I sent you my phone number. If you have any questions, guys, please feel free to email me or text me. All right. You're welcome. Yalla. Good luck, guys. I think Harun is going to take over now. He's going to teach you the rest.
MRI, which is, I would say, the heaviest and slightly more technical and challenging. So we're going to start with MRIs. First, we'll talk about the physics behind MRIs, then we'll talk about the basics of MRIs, and then we'll go to the clinical cases. Yeah. So what I'm trying to do, can you guys see my screen? Okay. How do I open presenters view? And can I still see your guys' chat or not? Okay, anyway, let's start. Bismillah. Okay, so talking about MRIs, MRIs are basically stands for magnetic resonance imaging. So how do I start? Okay, so first we're going to break down the physics parts into three distinct topics. The first one is going to be magnetization. The second one is going to be this NMR thing. And the third one is going to be how an MRI machine works, okay? So first, let's talk about protons. So protons, usually they stand for hydrogen ions. In the body is composed mostly of water. So it's good for us. We can use these to help us detect images, right? So the body has a lot of hydrogen ions because it has a lot of, well, not hydrogen ions, hydrogen atoms because it has a lot of water molecules. And basically we use this in MRIs, okay? So, okay, so over here it says that any atom which has an odd number of protons exhibits a net momentum, okay? What does a net momentum mean? It means that it has a spin on it, okay? So if you see this picture is trying to show you that this is constantly spinning and the axis is pointing upwards, okay? So usually in the body, they're arranged in different directions all over. And this cancels out the net axis in the body, okay? So this is just usual protons or hydrogen atoms in their original state, okay? Now, okay, so proton spin. Okay, so these spins are basically influenced by their internal and external environment. Internal environment, it means that, so for example, water is H2O, so it's bound to one hydrogen atom is bound to one oxygen atom, right? So that bond influences the spin on this because now it's a larger particle, so it'll spin a bit slower as compared to if it was hydrogen alone, right? The environment, so if there's different types of tissues, and obviously there's not only water, there's different types of, there's fat, there's proteins, different types of molecules outside, which also interact with this and basically influence the spinning characteristic, okay? So far, so good. Okay, so now, usually they cancel out, we talked about this, and they generate magnetic fields. Okay, so when this atom is spinning around, right, it generates an, or when this ion, I should say, this ion is spinning around, it generates a magnetic field, okay? So all of these magnetic fields are generated in different directions, they canceled out. Now, this is a basic principle in physics that if you have alternating magnetic fields, they induce electric currents, right? So this basically tells us about the basic principle of physics. This has nothing to do with anything over here right now, okay? Now, what's magnetization? Magnetization of these atoms means that they all align up, okay? So if you introduce a magnetic field from outside and it's strong enough to influence these tiny magnets, okay, they align, okay? So either they can align parallel to this or in the opposite direction, which is known as anti-parallel, okay? And once these align, they generate a net effect, right? So if all of these are aligned in direction, that means that the net effect upwards is going to be large, net downwards, okay? So once there is a net effect, we say that these are magnetized. That's basically it. Okay, so this mentions spins are aligned along the z-plane, okay? So the z-plane, we're going to take this as the z-plane, longitudinally as the z-plane, okay? This will become more relevant later on. Okay, so are at low energy state. So this statement over here means that the spins which are aligned along the z-plane, so z-plane we're taking as upwards, okay? Why are we taking it as upwards? Because it's just for convention. People always use this to make our lives easier, okay? So if the longitudinal or z-plane is pointing upwards, when we magnetize this, atoms arrange, you know, randomly, either upwards or downwards. When I say arrange, I mean their spins realign, okay? So they start spinning in one direction. So either they were spinning clockwise or anti-clockwise, and they were like in different directions. Now they're spinning like in one uniform direction, okay? Now, it says over here that these that line along the z-plane are at low energy, okay? So the ones that are pointing upwards are at a lower energy, and the ones that are pointing downwards are at a higher energy. Make sense? So far? Okay, great. So this was basically magnetization, okay? So we're done with magnetization, and now we're moving on to, okay, so this is basically an MRI machine. So as you figured out by now, it uses magnets. So we can't have like real magnets over there. So we use, yes, we'll get to this. We'll get to this in a second. Okay, so basically these are magnets and they're aligned in different directions, and these directions basically apply different magnetic field, okay? So this X coil applies it in this direction, the magnetic field, this applies it in this direction, and this Z coil applies it in this direction, okay? So basically there are different directions, and some are used to generate magnetic fields and some are used to receive the fields. So over here it says that the ones which are closer are basically used for receiving, and the one which is further away is basically used for generating the magnetic sequence, okay? So now we're done with the basics of this. Now we're going to, and this is where your question will be answered, okay? So basically, you know how we said that they align and they align along the z-axis? So this is the z-axis, okay? Now there's a second tendency of these protons to spin around this axis, right? So they're not spinning like, how do I explain this? Can you see this? Oh my God, can you see this? So they're not spinning like this directly, they're spinning like this. Does it make sense or not? I'm sorry, this is a horrible explanation, right? So basically they're spinning at an angle, okay? And this angle that they form is basically due to the introduction of this external field. And this frequency at which they're spinning is known as the Larmor frequency. Okay, and this action of spinning at an angle is known as precession. Okay, so these are spinning, they're aligned, their momentum is aligned along the z-axis because of the external field, which is known as B0, which we mentioned over here. So B0 is the magnetic field. It causes them to, their longitudinal axis to align. However, there is a second axis, which is known as, which is this deviated axis. And this deviation is known as, this ability of deviation is known as precession. And the rate at which it's spinning on this is known as Larmor frequency. Okay. And this frequency is influenced by the external magnetic field, which is the basic external magnetic field, B0, that we applied to magnetize all the protons and align them in one direction, or in two different directions. Okay, makes sense so far? I need to reply before I move on. I need to know you guys are following. Okay, let's see if these have better pictures. Okay, these don't. Let's see if I can find a better image. Because this is a really important concept that I want you guys to understand. Okay, so I read somewhere that they would like to think of, okay, so they would like to think of this as a, what do you call it? A top, you know, those things that spin around, the kids' games, Beyblade things that spin around at an angle. Think of this as one of those, okay? So it's spinning around. The net momentum is on the z-axis, which is the longitudinal axis, but it's spinning around in this not so vertical direction. Does this make sense? Okay, perfect. External, so the external will affect the angle and frequency. The external will affect the angle and the frequency. Yes, exactly. Yeah, the external magnetic field will affect the angle and frequency. Okay. So far, we haven't applied any pulses, anything else. We're just talking about the basic magnetic field that we're using to align everything, and then we're also talking about the basic magnetic field, which introduces this Larmor frequency. Okay. Where do I place this? Over here. Okay, so is this clear until now? Okay, now we are going to move on to my slides because the rest of the text is really confusing until you have some background, okay? Okay. So first of all, the hydrogen atom, it's spinning around randomly. So these were Mucklet's slides and I modified them, okay? So credits to him. Okay, so protons in the body, they're usually spinning around in different random directions. Once you have a basic BO pulse, which is the basic magnetic field that's introduced, they either align in parallel or anti-parallel directions. So this is them in different directions, randomly spinning, and then these are aligned in up or down, okay? This is not 100% accurate because as we said, they have a tilt to them, okay? This image is not 100% accurate, but it gives you the bigger picture, okay? So the ones that are arranged anti-parallel are going downwards and the ones which are arranged parallel are going upwards, okay? Now, the second thing that I should tell you over here is that the ones which are arranged anti-parallel have a higher energy, okay? And the ones which are placed parallel have a lower energy. So whenever we magnetize something, usually the ones which are arranged parallel or the ones which are arranged at with a lower energy are more in number, okay? So this is why the net effect is going to be upwards, okay? Just some of the basics, okay? So now spins, wobble, or precess about the axis of the BO field. So it depends on the field, the axis depends on the field, so as to describe a cone. And the spinning is called as precession. And then the rate of the spinning of the magnetic moment is known as the Larmor frequency. Make sense so far? Okay, so this was the basics, okay? This was magnetization, that's it. Now this, we go into NMR, okay? So what happens with NMR is that you take a pulse. A pulse means that you introduce another frequency, another radio frequency. Okay, so yeah, this is radio frequency, okay? So we introduce this radio frequency just for a second or a few milliseconds, okay? That's what a pulse is. And this basically collides with these spinning atoms. And what happens is these spinning atoms, the energy is transferred to them. Now for the energy to be transferred to them, they should be equal to the Larmor frequency. That means that you have to be really specific in the pulse. If the pulse is different, then it won't be affecting these, okay? That's number one. Number two is once this energy is transferred to these, they start to move in a different direction. So they start becoming more horizontally aligned, okay? So remember how they were spinning with respect to a longitudinal axis? Now they become more transverse, okay? And since they're gaining more energy, they're becoming more transverse. You know, remember how we said over here that the ones which are higher frequency are higher energy are lower down. So what's happening over here is these ones are gently turning their directions downwards, okay? Not all the way down, just a bit downwards, okay? So what happens is they change direction and they gain energy, okay? So this exchange of energy is known as resonance, and it's done at a specific frequency, which has to be equal to the frequency of the Larmor frequency. And then, yeah, okay. So that's basically what's happening, okay? Until now, we just gave it energy, okay? And they got excited. Now, once we stop giving this energy, they go back to their original position, right? So these are going now back to their energy, their original position, and they're giving off the excess energy they obtained because they were unstable in the higher energy state, and now they're going back to their original state, which was alignment due to the original magnetic field, right? So the original magnetic field is already there. We just introduced a pulse. Pulse caused the energy to increase. They became unstable. This changed direction. Now they're releasing this energy. Now, once they release this energy, this is obviously known as relaxation. And once they release this energy, they relax at different rates, okay? We detect this rate or this relaxation, or we detect more specifically, we detect this energy which is given off when they relax at different rates. We use, you know, scanners or detectors to detect these, and that's basically what we use to differentiate tissues. So you know how we said that there's different types of tissues? So we have white matter, we have CSF, we have gray matter, we have water, and all of these, they have different sorts of interactions. So the rates of relaxations are different. Does it make sense so far? All of this? Yeah, I'll repeat. Yeah, okay, let's recap one more time. So we had these basic alignments, okay? So we applied a field. They were aligned either parallel or anti-parallel to this. And they were not only aligned to this, they were also spinning at an angle due to this magnetic field, okay? This was known as precession. Now, these were already spinning, like, they were directly aligned. Now we gave them energy. They got enough energy to oppose the electric field or the magnetic field. So they started shifting, okay? They were excited. Now, once we took away the pulse, okay, they're no longer getting this energy. So now what's happening is they're going to relax. So they gained energy, and once they're relaxed, they're releasing this energy, excess energy that they basically gained. Now, this rate of relaxation is different. And basically, we're going to detect this different rate of relaxation for different tissues to be able to distinguish between different molecules and different substances in the human body. Does this make sense so far? Or do you want me to repeat? Or is there anything you don't understand in this particular thing? Okay, so anti-parallel also get this pulse, but they're not really affected because they're already at a higher energy. This pulse does not disrupt them, okay? And secondly, one more tiny detail. So this pulse is going to only move them 90 degrees, okay? It's not moving them all the way down, okay? So these don't really get affected over here, okay? Now, if you understand this is basically NMR, or this principle is used in NMR, and this is the basis of MRIs, okay? If you understand this, you understand 90% of this lecture, okay? Now, the other 10% is going to be a lot more detailed and a bit more difficult, okay? But it's just 10%. If you understand the basics, you're good, okay? So let's start again. So these spins, which was the basic spins, are influenced by the contrast, okay? Okay, so then we say receptors of the signal. Okay, so the receptors of the signal have to match the radio frequency of the target to around resonance. So basically, they're basically saying the same thing. So the radio frequency has to match the frequency of the targets already, which is going to be the Lara frequency, okay? Okay, so over here, they're saying that instead of applying a single frequency, they apply a range of frequencies. They apply a range of frequencies because you have the hydrogen atoms in different, slightly different environments. So they'll have slightly different Larmor frequencies, and they will respond at slightly different frequencies, okay? So basically, they apply a gradient and so that the ones they want, the target molecules, are all of them are affected, okay? Make sense so far? Okay. Do I explain this right now? Okay, fine. So we have different types of materials, okay? So diamagnets, what means is if they're introduced to a magnetic field, they do not become magnetized, okay? They do realign and everything, but they themselves don't become magnetized, okay? So this is most tissues. And then some tissues, if you introduce a magnetic field, they themselves get magnetized and generate their own magnetic field. No, actually these do get magnetized, sorry, I take that back. Obviously they do get magnetized, but they generate a magnetic field which is very, very weak, okay? This is why, okay, it's really weak compared to the other materials. Let's get that straight as well. Let's use proper terminology so you're not confused later on, okay? So, but then we have paramagnetic stuff, which is basically oxygen and gadolinium. This gets magnetized and it lasts a little while longer, but once you take away the pulse, this gets demagnetized, okay? Then we have something known as ferromagnetic material, and this is the important stuff over here, okay? So actually, yeah, I'll explain to you why these are important over here as well. Ferromagnetic material, it gets magnetized and then it stays magnetized for some time, okay? So again, this gets magnetized, really, really low magnetization, which is most tissues. Over here, paramagnetic get magnetized, but these are not that strong, and these get magnetized and then they stay there for a long time, okay? You'll have to excuse me for a second. Someone's calling me. Just give me 2 seconds, sorry. Damn it, where was I? Okay. You guys back? Sorry. Please tell me you guys are back, or you guys were still here. Okay, so basically the practical application of this process is basically gadolinium is used as a contrast. Okay, so you know how we said it's paramagnetic. So once it's introduced to magnetic fields, it will generate a magnetic field which will be strong enough to be detected on the scanner. Okay, so this is why gadolinium is used as a contrast material. Okay, it lights up and we can see it. Next we have ferromagnetic. So ferromagnetic. So this material, iron and oxygen, is is used in something, or hemoglobin to be precise. Hemoglobin is used in something called as functional MRIs, or functional magnetic resonance imaging, where we detect the amount of brain flow to certain objects. It's mainly used in research, not really in for diagnostic purposes, but that's the use of this. Okay, not really too important to make sure. One point to make sure was we apply magnetic field 2 times. Okay, so you apply a basic magnetic field and it's always there throughout the working of the machine. We apply this basic magnetic field to align all of these in one direction, or like at least, you know, in one direction. They could be facing different ways, but it's one direction, right? And then this pulse is applied and this pulse is taken away, but the initial magnetic field is already there. Okay. Okay. So then we have, okay, is this clear? I think over here you just need to memorize. Okay, so this is diamagnetic. It's used in most tissues, or this is most tissues. Paramagnetic is oxygen and gadolinium, and ferromagnetic is this. Okay, they might ask MCQs about this, but not really important for, you know, understanding the process of MRIs. Okay, so sequential simultaneous interactions with spin cause them to resonate in a proportional way to their spatial, temporal, and tissue specific characteristics. Okay, so over here, spatial means as they're organized in the space. Temporal also means something like this. Okay, yeah, temporal has more something to do with time, so, you know, it depends on the time. And then you have tissue specific characteristics. So as we said, due to the different interactions of different objects, they have different characteristics. The process by which we signal from NMR and then generate images. Okay, so basically NMR is the technology that's used, or the basic principle, and generating images off of it is basically MRIs. Cool. Okay, now B0 is the, now we're going to talk about how the image is formed, and this is a bunch of steps. So I'm going to go into a bit more detail than what you're required to know, because that will make understanding a lot easier. But the questions of MRI physics are going to be really simple in the exam, but, like, you know, if I go into more detail, it'll be easier for you to just understand. You don't have to basically memorize the information, the extra information I'm giving you. Whatever is in the slides is more than enough. Okay, so B0 is basically the basic magnetic field, and then we have this excitation, which is the pulse that we send out. Then we have different ways of data collection and reconstruction. So basically we want to apply filters to it to be able to detect what we are seeing more clearly. And then there's something known as Fourier transformation and image reconstruction. I'm guessing this is what the computer uses. I'm honestly not sure, but just know that the computer uses something like known as Fourier transformation. Okay. Okay. So over here, she asks you who is faster, and then she's like, you can't determine because they need to have one start line, you know, one beginning of the one line where they'll begin the race thing. So basically what she's trying to tell you is that we use B0 to get rid of, you know, the random spins of everything and just align them in one way, so that when we detect the images, we know that it's not due to their original random motions. Random movements. Oh my God. Okay, so RF pulse is applied, near full magnetization, and then relaxation. So we talked about this, and then the signal collected, or RAD, is during the relaxation phase. Okay. Okay, so encoding. Now this sounds really difficult. Okay, it just means that they are taking slices of the tissue, okay? So basically you have the whole body, right? And you want one specific area. So remember how in CT scans we had slices? I'm sure Mafla talked about slices in CT, and you have to be able to know where you are exactly in CT. It's the same thing for MRIs. So when you, for example, you just want to see a particular location in the brain, you will have a slice, okay? You'll select a slice, and that's basically what you're going to be using. And you can also make it more precise. For example, brain is like, relatively large, and then you want to go into like one particular portion of the brain, and then you want to go and be able to distinguish between the specific atoms and molecules in that place, okay? So that's basically what encoding is. So they talk about 3 different things, okay? So one is slice selection. Slice selection is basically the thing I told you about. So there's one plane which they choose, and they want you to have they want to detect all the molecules in that area, or all the hydrogen molecules in that particular plane, right? And then we have something known as phase encoding and frequency encoding. Now I want you to think of these as filters, okay? So phase encoding, for example, is going to be a horizontal, vertical filter, and frequency encoding is going to be a horizontal filter, okay? So basically, if you have this one slice is going to be like a cuboid or a rectangle. Can I show it to you in some way? Okay, random examples right off the bat of my head, but here you go. So you have this Rubik's Cube, right? So you want this one slice, okay? Or you want image of this one slice. So consider all of this as one big chunk, which you want to detect. So this is going to be your slice selection. And then phase encoding basically means that somehow you apply a filter so that you're able to detect the different molecules or the differences vertically, okay? So you apply something that messes with the phases along this axis so that you're able to differentiate between the molecules in that space, in that slice, okay? And then the frequency encoding is going to be the horizontal, okay? I'm just using horizontal and vertical examples. Does this make sense? I know this was really horribly explained, but I want you to get the bigger picture. So you have this one slice, and then basically, okay, let's go all the way back. So you have this one slice, okay? You want, now we're not talking about the impulse, the base frequency that was sent, that base pulse is gone. It's gone already. Now you're receiving stuff from there, okay? So you choose a slice, okay? You want to detect images from this one slice, and then you want to be able to detect the differences vertically and horizontally, so that you're able to know exactly where each specific point is in that one slice, okay? So these basically work as filters. Does that make sense so far? Yeah, so you choose a slice, basically you choose a chunk, and then you compare the things inside it. Yeah, so basically you apply a change to their phases. You don't need to know what that are, but basically they start spinning in a slightly different out of sync, they're slightly out of sync, and their frequency, so the rate at which they're spinning is also a bit modified along the planes so that the machine is able to detect it. Does this make sense, theoretically at least? So this is basically what it is, right? So you have this one slice that you want to take, which is applied in this direction, okay? And they apply a gradient to it. Why do they apply a gradient to it? Okay, again, remember how we said that they want to, remember how we said that we want them to be able to differentiate between the different types of hydrogen atoms, because they're going to be in different, they're going to have slightly different Lamar frequencies. Remember that part? So that's where we apply a gradient to them, okay? So that we're able to detect all the slight differences that we want, okay? So basically they apply a gradient over here, and then they apply a gradient over here, and so this is basically phase encoding. So it's basically a gradient to be able to differentiate what's going on. And over here, again, it's a gradient to be able to differentiate what's going on, okay? So basically what I'm trying to say is we have this basic, from the start, we had this one basic electromagnetic field that we applied, okay? That was there, that was B0. Everything was aligned accordingly. Then we set pulses to it. Then these pulses cause them to get excited, the molecules, and then relax. Once these protons relax, they released energy, right? Or they release signals, right? These signals were known as NMR signals, okay? And once these signals were reaching us, we wanted to be able to detect the differences between them, right? So we applied different sorts of gradients to them. The slice basically showed us, okay, so this is what we're going to send the impulses along. So this was basically during the part where we're sending the impulse, and this is basically when we're receiving it. Does that make sense so far? This is all you need to understand from this, the theoretical part. Okay. Okay, so it says over here, let's hope these are correct. Okay, so it says over here that you have to add spatial data to the signal to allocate a position to the different signals. Okay, so basically the computer is using this, all of these filters, to give itself more data to be able to detect exactly where in the spatial field, where in the space, each molecule is giving its frequency. Yeah, basically. So it's really confusing because there's actually two different types of things that are being used. One is the slice selection, right? Which also has its own gradient. And then we have these two, which have their own gradients. These two gradients help the computer detect what's going on. This gradient also helps the computer detect what's going on, but this is comparable to the pulse, to the radiation, radiation pulse or radiation frequency. So you see this point over here, the white point over here, this is the RF that they actually wanted. And all of this is just a gradient because they want to be able to detect the head, only image in the head, okay? Does that make it easier to understand? Yeah, so they want to detect the brain, so they're going to apply this whole range of gradient. So this part is the only one where they want the signal to go. I think another way to make it easier to understand is these are magnetic fields, right? So they can't really take one beam and just focus that beam. Okay, you're going to shoot straight through. That's why they need to apply this whole gradient. So the object of interest is just this R frequency. I think that makes it easier for you to understand or comprehend why we have a gradient over here. And then these are just for the computer to be able to detect them easily. Make sense? Oh, thank God. Okay, so basically it's actually a lot more complicated than I made it to be, but this is basically what's happening, okay? Now, okay, now let's go over here first. Okay, so this is the pulse that we're applying, okay? This is the slice selection, okay? This is the frequency, and this is the spatial thing. What's it called? Phase encoding and frequency encoding, okay? This is phase encoding, this is frequency encoding. And this is the signal that we are detecting, okay? Now, as you can see, first they apply this one phase, and at the same time, they have this, they have the slice selection, so you know that it's focused to one place. And then as time passes, they apply this field to the returning frequency, right? So they apply this field and then they apply this field. So basically this modifies the relaxation. Okay, so the one that's returning is known as the NMR signal. Okay, so the returning one, I'm going to call it NMR signal to make it easier for me and for you to understand. So basically, they're applying these filters to be able to make it easier for the computer to detect the signal, which is going to be detected over here. Okay, this whole process makes sense until now, right? We have a basic pulse, which causes excitation. We have to control this basic pulse so that we are detecting a specific tissue. And then once this pulse is gone, from now on, we're expecting a signal to return. So when we're expecting a signal to return, we apply these filters to make it easier for the computer to, interpret whatever the signal is going to be. At this moment in time, we get the signal, okay? This signal that we get, we can also call it an echo, okay? Now, over here, it tells us that we have a spin echo pulse sequence. So we have two major sequences that we can use to be able to detect an image, okay? So basically, we have a spin echo, which is spin echo pulse sequence, and then we have a gradient echo, okay? So these are the two major categories that we have. No, it's not going to be there. If it's still there, they'll still be excited. Once we turn it off, that's the only time that they can relax, because then they'll have to give off their signal, right? No. You keep the BO. BO stays there because you want them to come back to their original position. You don't want them to go randomly, come back to original position and then just go randomly all the way. BO is always going to be on. Okay, so please let me know if I answered your question or not. Okay, so we have the excitation pulse, which causes them to go. Yeah, the pulse is just like, it's there and then it's gone, we just apply it for like a few milliseconds, applied it for this many milliseconds. So this is time, so we applied it for this many milliseconds and then it went away. Halas, it's gone. Okay, so then so basically when we apply this pulse, it causes them to go at a higher energy status, and it causes them, then once the pulse is gone, it causes them to relax. And when these are relaxed, there's a signal which is read out, okay? Now, forget about this for a second. We'll get to this in a second, okay? Then it says between the excitation pulse and signal readout is the time that we call TE, which basically means the time from this RF to the time here. This time is known as TE, okay? Time of echo. Let's just call it time of echo. I'm not sure of the exact name, but let's just say time till echo, okay? That's TE. So this is explained, right? This line is explained. Now, over here, it says that we apply another impulse of 180 degrees to refocus them, okay? So basically, this means that we applied one pulse, okay? These got excited and were relaxing, okay? Then we apply another pulse of 180 degrees to refocus them, okay? Why do we need to refocus them? Because in the later slides, I'm not going into the details at all because you don't need them, but in later slides over here, it says something known as field inhomogeneity, okay? This is something that exists in the BO, the original thing that we applied. It's not really homogeneous. There's some variations, slight differences in that. So once they are relaxing, the effect is going to be because of two things. One is going to be their natural relaxation, and the second one is going to be because of the BO. There's slight differences in the BO, so that may cause some of them to be, some of the molecules to be, slightly affect their relaxation times. So there's two variables over there. So what we want to do is get rid of that variable that due to the BO. That's why we're going to refocus them. Does this part make sense to you? So basically, there's the field, the BO that we're applying is not 100% homogeneous. Yeah, sure. I know. It's really annoying to understand. It's just a tiny point that you don't really need to know, but it helps you understand why there's this one pulse, okay? So we applied this one basic pulse, okay? It caused them to get excited. No, before that. We applied a BO. BO stays there all the time. It causes all of the cues to align along the longitudinal axis, okay? Now, we caused these particles to excite due to the RF, or the pulse, basic pulse excitation pulse that we sent. So these molecules, instead of being aligned like this, they got excited and they became horizontally aligned, or they just lost their axis, okay? Now, once they lost their axis, they're going to relax. Now, the relaxation depends on two things. One is the natural relaxation of that particular hydrogen atom because of its specific environment. So this could be in CSF, this could be in the bone, this could be in water itself. So that specific environment, the difference that we want to be able to detect, that's the first thing that causes the relaxation, that affects the relaxation time, okay? Then the second thing that affects the relaxation time is that previous BO that we applied, because that BO was not 100% similar throughout. It had some slight variations to it. That's why when it's relaxing, what happens is it's relaxing due to different times, okay, depending on these two factors. So what we do is we apply a second pulse and it causes it to realign. When it causes it to realign, the original problem of BO is resolved, okay? So now when it's going to relax, it's only going to relax because of its original characteristic. Does that make sense? So relaxation time depends on two things. One is the characteristic of that particular hydrogen atom, the thing that we want. The second one is due to that BO, which is not turned off throughout, it's there, and it's also causing an effect in the relaxation time. So we want to get rid of that effect, and that's why we are going to apply a 180-degree pulse. Does it make sense so far? Okay, it's confusing to understand, but it's a really tiny point that is probably never going to be asked. I'm pretty sure the doctor forgot about this by now, okay? But it's really annoying and confusing, okay? So over here, what they're doing is they're applying the refocusing multiple times, okay? I don't know why they're doing this, but they're applying the refocusing multiple times. So the point is that this refocusing does not really, how do I say this? So this refocusing, the only reason they're refocusing is to get rid of the field inhomogeneity, okay? Does it make sense so far? Everything we talked about since the start, magnetization, NMR, this imaging that is done, this whole process. Okay, everything is clear so far? Can we move on to a bit more details? Okay, so now we have reached T1 and T2, okay? So this is probably important, and I'll tell you what exactly is important. So all of the next slides until here is going to be about T1 and T2, okay? Okay, where is that one link that I had, which makes life so much easier? Let me try to find the link, sorry. I promise it'll make life easier. I know I put it somewhere. There we go. You guys can see my screen, right? When I shift between PowerPoint slides. Please tell me you can. Oh, thank God. Okay. So this is basically the source that I used to understand what was happening, right? And it's really detailed. You don't need to know that much detail, honestly. Okay, first I have to explain to you what's going on. Okay, so you remember this original thing over here? you know how we said it gets aligned according to the longitudinal axis? So you know how usually when we're putting anything on a graph, we can align them according to the X, Y, Z planes, right? So all three of them are perpendicular to each other. So we're going to consider this longitudinal plane. We're going to consider it as Z plane, okay? Then we have X and Y, they're going to be horizontal. So they're going to be in this plane. One of them is going to be this way, one of them is going to be this way. Doesn't matter. This one is called longitudinal, this one is called transverse, okay? When we apply a 90 degrees pulse, okay, the excitation pulse that we want, what's going to happen is that this one, or every atom is going to move, it's going to move more transversely. So it's the transverse component is going to increase and the vertical component is going to reduce because it's going to start moving this way. And then it starts moving back, okay? So the transverse component is going to increase once you have excitation and the vertical component gets reduced. And then as it's increasing, the longitudinal component increases again and the transverse is reduced during relaxation. I'll show you this so it makes it easier to understand. Okay, so basically this is showing you relaxation, okay? So it's already excited. So it's transverse, okay? Now it is slowly going to start to increase in the longitudinal axis. And now it's excited again, okay? It's excited again, and now it is relaxing. Does this make sense to you? Does this part make sense? Okay, perfect. If this is clear, then the rest of it should be a piece of cake. Okay, so you see what this is? This is the actual, actually, let's go to this one. This one is easier to understand. So, okay, so this is the longitudinal signal, okay? So what happens during relaxation is the longitudinal signal, we're considering, okay, T1 is basically the longitudinal recovery time, or it's the longitudinal, how do I say this? It's the longitudinal signal that these guys receive, okay? So T1 is going to be the longitudinal signal, okay? So so excitation is done, this is relaxation phase, okay? Or recovery phase. So during recovery, what's going to happen is the longitudinal component is slowly increasing until it goes back to its original position, which was increasing. Make sense so far? Then this is the transverse. T2 is the transverse component. So something was excited. That means the transverse component was the greatest, okay? So it was horizontal like this. Transverse component was 100%. Then it slowly started to go back to its relaxed position. So this component started to decrease, which was T2. Does this make sense? Just the graphical interpretation of these. Okay. Now, this was T1, this was T2. Now we're still talking about the graphs, okay? We still don't talk about the different images that we see, okay? Okay, now let's go to the slides again. So we have T1 relaxation, which shows you basically the longitudinal axis, so it's basically increasing. And then it shows you, T2 shows you the relaxation of the, T2 represents the transverse axis, so it's gradually reducing, okay? Now this graph makes sense, forget about this, okay? Not important. So basically what happens is, different tissues have different rates of relaxation, you know, as we discussed previously. So they have different rates of relaxation, and these can be detected in two different ways. So one is along the longitudinal axis, which is basically T1, and the other one is along the transverse axis, which is T2. And basically these tell us two different things, okay? Now, how do I make you understand this part? Okay, so let's say we have a T1 image, okay? We call it T2 weighted image, okay? In a T1 image, and this you need to know, this is important. So in a T1 image, you are going to see fluid as black, okay? You're going to see fluid as black, and you are going to see fat as white, okay? Forget about this for now. Why do you see this? Okay, wait. I should have said something else earlier. Okay. Sorry. I should explain to you what. Okay, so basically TR, what is TR? TR basically means the time between two pulses. So you see this 90-degree pulse was given, and then another 90-degree pulse was given. This is known as TR, okay? And then there is something known as TE. Now remember what was TE? One impulse, and then when it's received. So if you see here, this is when the impulse is received. So 90-degree pulse was generated. Then when did we get the echo? We got it at this second over here. Then when was the second pulse sent again? It was sent over here. So TR is basically difference between two pulses. TE is difference between one pulse and detection of the NMR signal. Does TR and TE make sense? How can we have signals before relaxation can happen? Oh, that is a really good question. I'll tell you in a bit. In T2, while it is horizontal plane, oh, okay. Very, very important. I have to tell you something really, really important. Whatever I told you about T1 and T2 was about this graph, okay? It's about this graph. This graph is different from this graph, okay? What I told you over here was just to understand why it's increasing and why it's reducing, okay? This graph over here tells you about TE, it tells you about TR, so it's telling you about different components. Why am I saying this graph is different? Because in this graph specifically, how do I explain this? Okay, so basically this graph is telling you what they see on the machine or how the machine is working. What I mean to say is that this graph, okay, so basically in the machine, we can change the TR and TE times, okay, in the machine settings. Basically, that's what I'm trying to tell you. So TR basically means the time between pulses. So you can differentiate, so you can alter the time between pulses, right? So you can alter the time between pulses, and then you can also alter the time between when pulses are received. Machine does this, you don't need to know how, okay? When we say T2 weighted image, it does not mean this graph. It means this graph. Why? Because in this graph, the TR and TE that they chose are going to be really, really short, okay? This graph does not tell you TR and TE because it only tells you the relaxation time. TR and TE is not mentioned, right? This was just for understanding why one graph is going up, one graph is going down. This graph is now, I'm explaining T1 image, okay? In T1 image, we're taking a short TR and a short TE. How are we doing this? Machine is doing this. We don't care. What we care is how we are detecting the image that we see. Okay, so if you see over here, remember how we said in T1, it's supposed to be along the horizontal axis? It should be increasing. Okay, wait, what are your questions? How might signal happen? Because we can change TE. Okay. In T2, while it is horizontal, have not recovered yet. Okay, what else? Both are affected by relaxation time. Yes. Okay. So basically what's happening is when we change TR and TE, we are going to be. Is there that over here? Okay. So basically, for example, we want to detect T1 at this specific region. Okay. If we want to detect, or let's say we're detecting this T1 weighted image at this particular time, can I draw? I want to explain to you this one concept that will make your life a lot easier. And then you, hopefully you won't get confused. Okay, so we want to detect something at this, or let's say at this location exactly. Or let's go with this line. Oh my God, this is too much. Okay, let's go with one line. Okay, we want to detect T1 at this specific interval, okay? What's going to happen is, wait. Let me explain this and then you can ask your question. So basically what's happening over here is we want to detect T1 in this specific point in time, okay? What this means is when we are detecting the signals at this specific moment, we are going to detect a higher fat, signal as compared to fluid. So this higher fat signal is going to appear bright. Remember how we said in T1 image, we see fat as bright and we see fluid as dark? Because T1 was along the longitudinal axis. So if we shorten the TR and the TE, I shorten the TR over here. So we will detect it at this specific moment, which will cause a higher signal over here and a lower signal over here. If we reduce the TE, over here we have reduced the TE. So once we reduce the TE over here, we see fat at a higher signal of fat is returned and a lower signal of fluid is returned. So what? We see this as white because it's coming back. We see this as fluid because nothing is coming back. Does this part make sense of this graph? And then we will move on to your questions. Just this explanation, does that make sense? Okay, don't worry. We'll finish this topic and then we'll give you a break for prayer, okay? It's fine, perfectly fine, don't worry. So we have different relaxation times. Accordingly, we have different TR, TE. And accordingly, we choose T1 or T2 to see the, okay. Firstly, we detect T1 and T2 at the same time, simultaneously, okay? T1 image is different from these graphs, okay? This is graph for T1 relaxation. T1 image or T2 weighted image is completely different. In both of the images, we will have both of these graphs, okay? This graph, for some reason to confuse everyone, is also known as a T1 graph. But in T1 image, we see both of these, okay? So it makes sense, right? Because it's going to relax, it's going to be excited, and then it's going to relax slowly. So this slow relaxation can be seen as two different stuff. We can see either as its longitudinal axis or as its transverse axis, which shows you why we have two different graphs. These two different graphs are taking place at the same time. When we say we are taking T1 image, it means that we are taking this one snapshot when we are reducing the TR and reducing the TE. So for this graph, we reduced the TR and we got an image that showed us that fat was bright. And at the same time, we are taking or let's make it like this. At the same time, we are taking we can't do it at the same time because these graphs are not on the same scale, okay? So when we reduce TE, we are detecting or how about this? This one snapshot that I'm talking about, this one moment that we want to detect, it's going to be this over here and this over here, because these graphs, their scales are not the same, okay? That's why over here, if you see, there's a difference, okay? But if we reduce it, it makes it easier to understand. Does this make sense to you, this concept that why we see something as bright, why we see something as dark? And this one concept that both of these are happening at the same time. When we see a T1 image, it's short TR, short TE, okay? It's not one graph only. It's both graphs at the same time. Does this make sense to you? I should have approached it in a different way. If it doesn't, we'll try again. We'll try again in a different way. So let me know. Okay. So signal is coming through the detector throughout. TE is when we want to detect it. When we reduce the TE, that means that when we detect it, oh my God, unstable internet connection. Can you guys hear me? Is my voice clear? No. We see it at one specific time. When we see it at one specific time, since the TE is short, and if you enlarge the TE, it's going to be over here, right? If you enlarge the TE, that would mean that it would change, right? You won't see fat as bright, okay? So the idea is we want to see fat as bright. That's why we're going to reduce the TE so that once we can still detect the TE when we have this much signal. Signal is coming throughout. Remember this, I get very confused. Okay, wait. Clear all drawings. Okay, let me explain something else to you. I hope that'll make sense. Remember this graph? This nice, lovely graph that we talked about? This is done. We're not talking about this anymore, okay? Because as you can see, the pulse was sent, and now we can either detect it, we can either detect it here, we can either detect it here, okay? We can change this TE according to what we want, okay? So this graph is not related to this graph. This graph is only for understanding the spin echo timeline of the sequence of events that happens in an MRI machine. Over here now, we're talking about the image that we see. So basically, we can change the TR that we see because they're relaxing continuously. You see, these once pulse was generated here, the TE is after this because it's now relaxing. So we can have the TE here, or here, or here, or here. It depends on us now. The signal is already coming. You know, we can detect it whenever we want. The only difference is the time that we choose to detect that one signal at one time, it will show us different intensities of signal of the different components. And this is basically what we are going to be using to be able to differentiate between the different tissues. Does this make sense to you? Okay, thank God. Okay, so I should have told you earlier, this is a completely different graph. Sorry about that, my bad. Okay, so now we have a T1 image. Now to recap everything that we talked about so far, and then I'll give you a break. And then once we come back, we will talk about T2, okay? So just to recap what we talked about so far. Firstly, we talked about this one component. So when we have excitation, causes excitation, reduces the or increases the transverse axis or the transverse component, and it reduces the longitudinal components in excitation. Then you have relaxation. Relaxation can be detected in two different ways. What are the two different ways of detecting relaxation? One is to detect it along the longitudinal axis, which we call T1 to make you guys confused, okay? So when we detect it along the longitudinal axis, it's slowly going to be increase. Now this same increase, the horizontal component is decreasing, and that's why we see it as this. Both of these are happening at the same time. So these are happening at the same time. Now we want to detect the image of these relaxations, okay? So this relaxation basically tells us, so basically once we want to detect an image, we try to isolate one point in time, okay? So when we want to isolate one point in time, it could vary, okay? We could increase TR and we could, increase TE, and that would become something completely different. But now we're talking about T1 image, T1 weighted image. When we want T1 weighted image, what do we want? We want a sequence in which we see the fluid as completely dark, and we want a sequence in which we see the fat as bright. How do we do that? We change the TE and TR. So once we make the TR shorter and we make the TE shorter, when we detect something, like for example, over here, we made the TR shorter, we would see a higher intensity of the signal of fat coming back as compared to the fluid. So this will appear as white as compared to the fluid, which would appear as black, okay? And then once we reduce the TE and we're looking at this component over here, we see fat as bright over here because they're decreasing at different rates, and we see fluid as dark. because we have decreased the TE. If we increased it, we would see them as different colors, but we don't want that because we're talking about T1 over here. When we go to T2, we will change this some more. We'll edit this and this some more, and we'll see them as different colors. Do you get what we're doing? We're just using the rate of decay or the rate of recovery of the different, let's say, the different axes of the same hydrogen molecule. We're just looking at it in two different directions, and we're using those two different dimensions, I should say, to be able to display something as dark or as bright. Because at the end of the day, we want to be able to differentiate the different tissues. We don't care how they're done, but we want a difference in them. Does this make sense? T1, T2 axes, and then T1 weighted image. Does this make sense? Do you have any questions about this or anything that we talked about until now? If you don't, we will take a break for 10 minutes. You guys can pray, have something to eat for 10 minutes, and then we'll come back at exactly 6:45. I'll give you 12 minutes. 2 minutes for questions. Yalla. Any questions so far? This is going to be really relevant for the people who are going to watch the recordings because I'm repeating myself. Well, I'm repeating myself, or I'm gradually making myself more clear. I think my explanations are also becoming clearer once I repeat it in different direction, like different way. Anyway, they'll have to listen to the whole thing to get a better understanding. Okay, so we're going to take a break for 10 minutes. I'm glad all of you. Yeah, okay, sure. So, so TR is basically the distance between two different impulses. So once we send one impulse, we can wait. It depends on us when we're sending the second impulse, right? No, it's perfectly fine. Don't worry about it at all. We sent one impulse, okay? Now, it depends on us when we want to send the second impulse, right? The 90 degrees excitation impulse, right? Now, it depends on us when we want to send this. So we can either increase the time between the two impulses that are sent or decrease the time. This time between the two impulses is known as the TR. Then you have something known as TE. What is TE? It's the time between once the pulse is sent and once we choose to detect it, you know? So we can say, okay, so for example, I sent an impulse at 0 seconds, and now I want to detect the signal, which is coming continuously. I want to detect it at exactly 2.5 seconds. You know, so that's going to be TE because that's when I will receive that echo or I will detect the echo. Okay? Okay, cool. So I can also change it. So I can be like, okay, so I sent it at 0 seconds, and now I want to detect the image that was sent. I want to detect that echo at, for example, 4 seconds, you know? So it depends on me when I want to detect it. The difference will be that the rate of decay will be different for the different substances. And that's what's going to be a differentiating factor between the different bright, dark colors of different tissues. Okay, cool, makes sense? Perfect. Let's see you after the break. Enjoy. Okay, by the way, all of this details that I'm mentioning, the questions are going to be really simple in the exam, so don't worry about this. This is just so that you understand and doesn't really bother you for the rest of your lives, why we have all of these different stuff. Okay? I'll try to tell you what are important for the exam right after like 5 minutes, I guess, once we finish this topic. Okay, so Oh, by the way, if you want me to increase the size of this or something, anything's wrong, please let me know, because I'm not necessarily paying so much attention to all of the other stuff. Okay, so we talked about T1. In T1, this thing that you should know this, and you should be able to tell on the image as well. So T1 image has black fluid. We see fluid over here, it's black, okay? And other tissues or fats specifically appears white. So apparently this is a vessel, it has fat, I'm hoping, I guess. It appears to be white, okay? And that's how you'll be able to tell you. So if they bring you a random image, just check for the fluid areas or areas you know are supposed to contain fluid, and see if they have, are they black or white, okay? That's the easiest way to tell them apart, okay? Now, I'll get to this annoying part later, okay? Don't worry about it. I'm skipping this intentionally because I want to finish the physics part first. Okay. So now we talked about T1 and T2 graphs. Again, these graphs are just to confuse you. Both of these happen at the same time. Okay, I'll tell you why they call it T1 as well, okay? So T1, basically you see this, apparently T1 is the time at which 63% of the molecules or 63% of the signal off the longitudinal axis is basically received. And T2 is the time at which 37% of the transverse axis magnetization is received. Okay, that's why they call it T1, T2. It's just extra information, has nothing to do with you guys. I'm just telling you why they're trying to, like, why it's called T1, T2, okay? They just named it like that and then, you know, it stuck. It has something to do with the half-life, if you guys know what that is. Not important over here. Okay, now let's talk about T2. So T2 image, the reason I went to those graphs is because, again, I want to tell you, this is different. Both of these happen at the same time. When we're talking about a T2 weighted image, what we want is to have a longer TR and longer TE. Why do we want longer TR, longer TE? Because we want to see fluid as white, okay? So in T2, what happens is pretty much the reverse. So fluid appears to be white and fat appears to be gray or black or dense or less dense, okay? Sorry, less dense. So over here, fluid is white. If you compare this image, over here, fluid is black, okay? So basically you're looking at the exact same thing, but they appear to be different colors, right? And why do we need two different sequences? Because it helps us distinguish like different, you know, tissues. Some pathologies appear brighter over here, some appear dark over here. So it's good to have two different things to be able to, you know, see something if it's not clear, you know? And we'll get to those details later on. But now let's talk about the physics. So we have longer TR, longer TE. So T1 weighted image was shorter TR, shorter TE. This is longer TR, longer TE. Easy to understand? It's going to be the complete opposite. That was shorter, this is longer. Over there, fluid appeared to be dark. Over here, fluid appears to be bright, okay? So again, if we take one particular snapshot in time, so let's say we're taking one snapshot over here. So if we're taking a snapshot over here or over here, the fat is already bright. Oh, what? Why am I confusing myself? Oh, okay, never mind. So, sorry. So if let's take this one for example first. So if we have increased TE, we're going to be detecting at a later stage. So when we're detecting it at a later stage, fluid is going to be brighter over here and it's going to be darker over here. Now, why does this not make sense? TR is long. Okay, I'm guessing. This is my guess now, but this is most probably correct. You see how when we increase TR, the signal, maximum signal is already received. I think that's why the fat will appear to be dark. I think that's why fat will appear to be dark. I hope my logic is correct. Fat appears to be gray or darker. That doesn't make sense. I know they take longer TE for this reason. Like they want to be able to detect fluid better, but the fat part I'm not sure of. I'll think about it and go back to this. For this makes sense, right? So once you're using the T2 graph, I guess that makes sense. If you're using the T2 graph, the fluid will appear here. But they modify both TR and TE, okay? So for example, this, they're going to white matter and gray matter. Okay. Okay, we'll talk about this in a bit, but over here, let's see. So if we have a shorter T, if we have a longer TR over here, CSF appears to be white, CSF is fluid, so it will appear white. This makes sense. I'm honestly not sure why this happened. I just thought of it right now. We'll get back to this. Anyway, so fluid appears to be brighter since it is, if you look at the T2 image or T2 graph, well, I'm using the T2 graph. Well, if you look at the T2 graph, if longer TE, this makes sense. We have more signal over here and less signal over here, right? So this will appear brighter as compared to this. This makes sense? Okay. Yeah, so this graph, if they increase T2, my explanation would be, sorry, if they increase TR, my explanation right now, I'm not sure if this is true or not, would be that since they received the signal already, so now they'll be detecting this, you know, this will appear brighter, but I'm not sure exactly. But anyway. Also, yeah, okay, we'll just leave that. There's another thing, but we're not going to that because I don't know how elementary it is. Okay, so basically, fluid appears to be brighter over here, and then fat appears to be darker over here. Okay, T1, T2 is done. Okay, now gradient sequence, and then we're done with the physics parts. So, so gradient echo, the only thing you need to know is that there's two major ways in which we use MRIs, okay? One is known as spin echo, which was basically T1 and T2, and then they have something known as gradient echo. So you know how there's different variants, right? There's going to be flare, there's going to be stir, there's going to be diffusion weighted, blah, 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 blah. So all of those different ones, including T1 and T2, can be categorized into two main mechanisms or two main sequences of generating these images, okay? So spin has T1 and T2. Gradient has other stuff which we don't care about, okay? The only reason she mentioned this, I think, was for the sake of completion, you know, okay, she covered the topic properly, okay? So the differences in this particular thing that you need to know is that remember how we used a 90 degrees pulse sequence over here? So it flips it all the way like this and then back. Over here, they don't use that, okay? Over here, they don't use that. So they use 30 degrees. So it turns to 30 degrees or 60 degrees, somewhere in between, and then it goes back. It doesn't go all the way down, okay? And basically what that does is obviously it's going to give you a different components of this, which will have different tissues appearing in different colors. The details we don't need to know about, okay? Apparently it's used, okay, so what's the advantage? It's going to be faster because they're not going to go all the way down. They go down and up, you know, so it's going to be faster, you know, but less signal is detected than spin echo. That makes sense because if it went all the way, then you would have more, you had more excitation, so you'll have more NMR signal coming back to you, okay? That makes sense. It's used for cardiac imaging. Okay, cool. It's used for cardiac imaging. Memorize, move on. No 180 degree refocusing. Remember how we talked about refocusing previously in spin? How they have to refocus it because you don't want the field inhomogeneity to play to play a role in the detection. Over here it does, okay? that's why we mentioned it over there, because now this is more susceptible to field inhomogeneity. Now, why is this important? It's going to be important later on, but I'll go back to this because it'll help you in linking the process. So remember how we said that if there's a ferromagnetic material, it will retain its own magnetic field, and that magnetic field is kind of strong. So it can be used to detect something later on. So if we have different materials, some of them may be more accurate, or some of them may be seen differently if there is, if field inhomogeneity is not corrected. So for example, we can probably see something like iron or hemoglobin more, not more accurately, but there'll be more distortion, so that will appear on the image. So it'll be clearer or more distinct. Let's say it'll be more distinct, you know? So sometimes for some things, like for example, cardiac imaging, we depend on this ferromagnetic property to be able to make something more prominent for us when imaging, okay? That's it. All you need to know about this. So no refocusing, faster, but less signal detected, and cardiac imaging. Okay, why? Since we don't know refocusing, it's more susceptible to field inhomogeneity, which can be helpful to us in some situations. For example, cardiac imaging. Make sense? Cool, move on. Okay, so now we talked about all of the physics parts. Now we're done with the physics parts, alhamdulillah. If you have any questions until now, please ask. In the meantime, see the thing I told you about, not important. Let me see if I can find the explanation. These are not for you, don't worry. It's just bothering me, that's what I want to know. Anyway, don't worry about this graph. Forget. Okay, so now let's talk about some of the advantages of MRI and some of the basics of MRI. Okay, so now we're moving on to what normal tissue appears like and what, you know, different sequences appear like. So now we're studying normal anatomy. Okay, so some of the advantages of MRI. It doesn't use ionizing radiation, so it could be used on children and pregnant women because those are especially susceptible to ionizing radiation. Okay, so it's safer. Advantage. Second advantage, multiple planes. So it could be a plane in multiple planes because we have so many different types of slices and everything. So it's good. It's not like the X-ray. Okay. Superior tissue contrast. So basically, you can see soft tissue better, and that's why compared to CT, so we use to see soft tissue structures. What are like? For example, the ligaments in the bones, ligaments, tendons, cartilage to some degree. We can see in CT, but it's a lot more clear over here. Then the brain. In CT, we can't really distinguish between a lot of differences in the brain, but MRI is a lot more accurate. So there's brain, there is joints, and then there is stuff like, you know, the soft tissue like kidneys and liver and stuff like that in case that we cannot use CT, okay? Oh, okay, functional MRI, you don't need to know this, but it can help you with the brain activity and when combined with PET. So PET, remember, PET is with CT, okay? But you also have something PET MRI, and that's like really, really accurate or something, but we don't really use it because it's way too expensive, okay? But it can be used in some situations, okay? So then you have MRI scans. Obviously, they're more expensive. They take a lot longer. So CT scans, you can finish in like 5-10 minutes. These, they take around half an hour, 45 minutes. Longer to perform, not safe. Okay, so really, really important. Metal implants and foreign bodies. Remember how they're magnets? Remember how they're really strong magnets? If you have implants, they can literally, for example, metal implants, they can literally rip them out of your skin and cause the person to die. You literally rip them out. You know, so the magnets are strong enough to lift cars. So imagine what a pacemaker would happen to a pacemaker, you know. So heart valves, if someone had previous heart valves, they can have, you know, even staplers after the heart valve, something, you know, anything that is magnetic. Tattoos especially. Okay, so this is really important because especially, so some ink used in tattoos can be magnetic or can have some of iron or something dissolved in it that is magnetic, okay? And what happens is if someone has a tattoo and it has a magnetic component to it or a metallic component to it, if it gets magnetized, that skin is coming off, you know, so it's horrible. You need to be really careful about this. It's not really, yeah, just keep that in mind, okay? It's really important. Okay, next thing, when you're looking at an image in an MRI, always you need to know which plane you're in. Really important. So this is sagittal, this is coronal, and this is transverse. I think you know this by now. Then the most important thing is to know your location. So in the exam, obviously you're not going to have different sections, but when you're looking at a real MRI, you need to be able to tell where you are in the head, you know, and so it's really important. Okay, so now we have T1 weighted images, right? So now this part is important because they can ask you stuff like this. This is like basic MCQ stuff. So fluid again appears to be dark. So T1 images, we call them anatomical images. Why? Because it's usually used to study anatomy, can be used to study pathology, but usually for normal structures, just to see a normal structure for research, whatever, usually we use T1. In T1, fluid appears black. Fluid is what? CSF and in orbits. Okay, fine, but you can't really tell orbits. Fine, CSF. Okay, how do you check CSF? You check for the lateral ventricles. I'm sure you're done with neuro, so you remember somewhat neuro, lateral ventricles, supposed to have CSF. CSF. Oh, thank God you're done with neuro. You cannot believe how happy I am you guys are done with neuro. Okay, so fat appears to be white. Now, again, there's two types of tissue in the brain, right? There is the gray matter and then there is the white matter. So then, I have to ask you, gray matter in the brain, is it inside towards the center or towards the periphery? Yes, cortex. Thank you, neuro people. So basically, gray matter is going to be outside. And since it's at anatomical, gray matter appears to be gray. So it appears to be darker than the white matter, which has more fat, so it appears brighter. Make sense? Cool. Gray matter, darker outside, because this is normal anatomy. So if you're confused and you forget what's going on, always look at the fluid. If you can look at the fluid and you know there's no contrast or anything, you know that the fluid is black, yeah, then you can also check out the gray matter for further clarification, okay? Just remember anatomical. Now let's go to T2. So T2, fluid is going to be the exact opposite. So fluid is going to be white. This is a bad image. I'm sorry, but I couldn't find a better image, honestly. So this is the lateral ventricle, which is white. Sad excuse for white, but whatever. Now this is gray matter, which appears to be brighter, and this is white matter, which appears to be darker. So just remember, it's used to detect pathologies, and it is the opposite. So what I did was I just remembered T1 and everything about T1 because it was easier to remember, and then I would just work it out in my mind during the exam, you know? So again, this appears dark, this appears to be bright, okay? Same thing exactly. Okay, so in clinical practice, usually if you get a sequence and they don't tell you what it is, most likely it is T2, okay? Why? Because usually we are trying to detect abnormalities, okay? This is done, clear, everything is clear. We're not going to this, okay. So this is basically fancy stuff. This is sagittal section, this is coronal axial section, sorry. Don't need to know, okay. Now we're going on to the actual slides. Okay, basics of MRI, we're done. Common applications, we'll cover those. Okay, advantages, we talked about this, high resolution, so you can actually tell the difference between cancers, tumors, soft tissues, blah, blah, blah. Okay, limitation is also cost. So cost is a problem. Second is access. So access can mean two things. Access can mean that only tertiary centers or only centers which have a lot of money or they're really advanced, they have MRIs. Usual small clinics won't have MRIs. Secondly, it's really expensive. And thirdly, remember how you have to stay there for a long time? So some patients which are unstable or they're moving around a lot, they won't, even if they're staying in an MRI, we won't be able to get a clear image because they keep on moving, you know? It takes around 30 to 45 minutes, which is like a long time. So that's what access means, okay? So now we move on to cases. Wait, before we move on to cases, there was one thing I skipped. It was this. So remember how we said that fluid appears to be dark? When we apply a contrast, contrast appears to be white in T1 image, okay? So usually whenever they apply a contrast, it's going to be a T1 image. And this can be confusing because they can have a T2 image with contrast and that would appear to be dark. And if they don't give you anything, then you're still confused because now you don't know if the fluid is because of the fluid being black or it's contrast inserted if they didn't give you information, you know? So this can be really confusing. So what do? The first thing you have to keep in mind is if they didn't tell you anything, it's probably T2. The second thing is if there is a contrast, if it's mentioned that there's a contrast, it's probably T1. The third thing is if you don't trust them in the exam, what you do is you look at the gray matter. Again, hopefully the gray matter and white matter is clear enough for you to be able to distinguish. So if the gray matter appears to be grayer or darker, it means T1. White matter appears to be whiter, it means T2, okay? So this is the only caveat between them. Okay, usually they would, like in the exam, they should tell you, honestly, they should tell you it's with contrast, you know, okay, class T1. If they say in contrast and you look at a place and it doesn't appear to be white, a place that's usually supposed to have contrast, you know, normal fluid places. Would they show us that in other parts of the body? They can, hopefully they don't. I hope they don't, honestly. Okay, so for example, this is another part of the body, right? Honestly, they should mention if it's any other part of the body. Because over here, there's no way you can tell otherwise. This could be contrast or this could be just T2. They should always mention that there's contrast. See, this isn't a problem in real life because in real life, they always mention it on the screen or on the monitor on the side somewhere. This is T1, this is T2, this is with contrast, this is without contrast, you know? I think if they show you any other part of the body, they will mention it. Because if they don't, honestly, it's not fair. You guys probably can appeal that, okay? So over here, again, if we see a T1 image without contrast, T2 without contrast. Fluid appears to be dark, gray matter appears to be dark as well, opposite over here, okay? Okay, now we're going on to the clinical scenarios. This should hopefully be a lot faster. So, a 67-year-old male comes to you and presents with sudden weakness, right side part of the body. What do you suspect? Okay, so one thing I have to tell you before we move on. Yeah, okay, so one thing I have to tell you before we move on. Whenever we have a clinical scenario, I'm sure Mahmoud mentioned this, the first thing you think of is differentials. What do differentials mean? Differential means the possible pathologies or possible problems I think can happen in this case. So you always have a list of differentials in your mind. Once you have a list of differentials, then you think about which imaging modality is most appropriate. Over here, it's stroke. Okay, now you guys are done with stroke. So yeah, it's most probably stroke. It could be something else like tumor. It could be something else, you know. But since it is sudden onset, it's most probably a stroke. I agree with you guys 100%. Okay, second thing regarding clinical scenarios. I'm sure Mahmoud mentioned this, but I'm just recapping. 3 things that you guys need to take care of. One is the patient's age. Second is the gender. And third is it sudden or is it chronic? Okay, those are the 3 things which will really, really help you out in every clinical scenario. Okay, not only this, in COM, in whatever else you have. Okay, so 67-year-old, we know he's an old guy, probably got a stroke. Males are more likely to get a stroke, and sudden weakness. Okay, perfect. Sudden, it's probably a stroke. Now, whenever you get a stroke, what's the first imaging that you do? Come on, you guys did neuro. CT, perfect. Why do you use CT? Okay, CT is faster, but there's a more important reason why you want to do a CT. It's faster, I agree. No, you want to know if it's an ischemic stroke or it is a hemorrhagic stroke. Why do we want to do that? Because the treatment for ischemic stroke is going to be thrombolysis. If you have, yes, exactly. Thank you, Labiba. Please tell me I said pronounced it correctly. Yes, you are right. So if it is a hemorrhagic stroke, yes, and we do thrombolysis, it will cause diffuse bleeding, and then we'd have huge problem in our hands. Okay, so then we do this. Now, another thing about CT. Okay, so now we did the CT, and now we know that okay, it's an ischemic stroke. Now, why do we want to do an MRI? Any ideas? We want to do an MRI after this. Why do we want to do this? Plus, we know it's ischemic. Why do we not want to know if it is? Why do we want to do an MRI? So basically, yes, you're right, but it also depends upon the timing. So I think I wrote this in the presenter's view, or someone had. Basically, what happens is a CT scan can only detect changes after 6 hours. Okay, so if a person comes to you and it's before 6 hours, and you want to detect ischemic changes, you want to do an MRI, because an MRI can tell the difference after 30 minutes. Okay, I don't know where I wrote this, but basically an MRI can tell you like what happened at an earlier time. You don't have to wait until 6 hours until there's more damage for CT to be able to detect something. Okay, so that's why we do MRI. Second thing is MRI is more clear, so we know exactly the areas which are affected. Okay, so over here it says this is an ischemic stroke. At least 6 hours, loss of edema and swelling. Okay, so why is there edema and swelling? Because there is infarction. Infarction causes edema and swelling. Okay, so over here it says sulci are slit and gyri are broad. Okay, so over here it's telling you that, remember this sulci that were supposed to be inside? They're really small, and the gyri, they're expanded. That means that there is edema overall as well. Okay, but especially over here. Okay, over here you can't even detect the sulci. It's a bad image. I'm sorry. It's a bad image. No more TPA. Okay, fine. Said. I think it would be easier if I just. Can you guys see? Okay, thank you. Thank God. Okay, so now we have T2. We talked about T2. So in T2, what do we see? We see fluid as white. So remember how we said it's used for pathologies? Now we know why it's used for pathologies. Over here, there's going to be edema, okay? And since there's going to be edema, there's going to be more fluid over here. Since there's going to be more fluid over here, it'll appear bright, and we know exactly the areas which are affected faster than we can detect in a CT and more accurately, okay? Secondly, now we see the CSF, okay? Now, the second thing is, even if we detect this, someone might say that this could be blood flow, increased blood flow to this area, okay? How do you know that this is not increased blood flow? How do you know that this is not CSF, which is, something that leaked in here? How do you know it's not a hemorrhage that's leaking in here, okay? For example, we didn't do a CT earlier. How do we know this is possible? So what we do is something known as flare. Now, you don't need to know the physics behind this, thank God. But what you need to know about flare is that it suppresses CSF, okay, and it suppresses any free-flowing liquid inside, like just free-flowing liquid. Wow. Okay, free-flowing liquid. So basically, it suppresses it. It appears to be darker. So when we suppress the free-flowing liquid, the CSF in this case, this is still bright. Now we know this is edema. Okay, so basically, we're saying flare, and it sounds completely different, but literally, the radiologist, he's seeing the image right now. He clicks one button. He suppresses the CSF, it's called flare, and he's able to see what's going on, it makes it clear. So it's literally like 2-second process for like in real life, okay? What does it say here? Flare shows edema, and then it says infarct is seen here, cytotoxic edema is seen here, okay? Makes sense so far? Yeah, basically, that's what flare does. Yeah, let's go with that. Okay, now we have a T2 weighted image. Okay, now we have a tumor. Okay, so over here she didn't mention the scenario, but let's say it's a breast cancer woman and she has a metastasis to the head. Okay, so we had a metastasis to the brain. What do we use to check metastasis? We can't use CT because CT is not accurate enough. What do we use? MRI, okay? So we use something known as an MRI, and then we use T2 because we want to detect pathological cases. And now we're not sure if what this is, you know, this could be a mass, this could be something else, you know, it could be AV malformation, it could be an infarct, okay? We're not sure if this is an old infarct or not. So what we do is we give it contrast. And since we're giving it contrast, we're going to be checking T1. And once we're checking contrast, we know that the tumor will take up the contrast, right? Since the tumor will take up contrast, it'll appear to be bright. Sorry, this is moving on so on because of the recording earlier. Anyway, so this is T1. So if we could see CSF, we should have been able to see it as dark. However, the contrast should appear to be bright. Remember? Make sense? Because this took up the contrast. Okay, forget this. This is not here, okay? This is talking about diffusion weighted imaging. It's not here. Forget about this. Okay, case number 2. Case number 1 clear. We have an ischemic stroke. So first, in case of a stroke, first thing we do for is CT. Why do we CT? We want to rule out hemorrhagic stroke. After we rule it out, we want to check if the exact area, or we want to see if it was a hyperacute stroke or really quickly, you know? So we use MRI. MRI, we want to detect the exact area of edema, so we suppress CSF. So we use FLAIR. Okay, the thing I told you about free-flowing liquid, I'm not sure how accurate that is precisely. So let's go with CSF, because the only time you're going to see FLAIR is going to be in the brain, okay? Or you guys at least are going to see in the brain. So let's just say CSF is suppressed by FLAIR. Don't take it as any free-flowing liquid, because that's more towards the diffusion-weighted imaging, okay? It's not mentioned here, so I kind of didn't mention it, okay? Anyway, now let's go to the second case. So a 27-year-old male with seizures, you know, they tell you the diagnosis, thank God. Now, what is the appropriate radiological modality? You're going to either go for CT or MRI of the brain. You're going to go with an MRI of the brain, because let's say this is not an acute attack, you know, you just want to find out what's wrong with him. So you go over here. Now you do an MRI. Again, this is T2, so CSF appears to be bright. CSF is in the periphery as well, remember? Actually, this could be CSF, this could be gray matter as well. It would also appear bright. Anyway, it's going to be bright, okay? Yeah, so they're suspecting either a tumor or something, okay? Now, yeah, so they're suspecting a tumor which is causing the seizures, okay? So again, for detecting tumors, you go for this. And a T2 weighted image will show you that there is something that appears to be different than the white matter, surrounding white matter, and you know, it's showing you an opacity, or it's showing you a bright lesion over here, okay? So this is a tumor, okay? Now over here, this is not really a tumor, this is a cavernoma. Do you guys know what cavernomas are? So basically cavernomas are blood vessels which are just dilated, and there's an abnormality in there, and blood is staying over there, and that's affecting the overlying tissue because of mass effect, which is basically causing these seizures over here, okay? So when they want to detect cavernomas, they're going to use gradient echo. Now remember what I told you about gradient echo? We're only going to see in certain situations. So what happens over here is, remember how I said gradient echo? It is more, the images are more prominent if there is a ferromagnetic material. So a ferromagnetic material is going to be hemosiderin, okay? So hemosiderin is going to be causing more distortion of the image over here. This is why we can see something distorted over here. So you see why GE is sometimes useful, because we couldn't tell the difference between a tumor and a cavernoma with just T2 alone. How do we rule out the image? We ruled out the image because we did CT earlier. We're never going to go for an MRI earlier. It takes more time. The patient can't have anything. Okay, so why do we see hemosiderin? Basically, it's iron degradation, or yeah, white blood cells, which remember the pathophysiology. It's basically what do we call it? Hemoglobin, and then macrophages end up clearing it at the end. Okay. Case 1 and 2 are clear. Can we move on? First case was stroke. Stroke, always do CT, then go for MRI. MRI, you can have flare to suppress CSF, and then you can have GE to look for cavernomas. Okay. Now, case number 3, 55-year-old female. Can we move this out so that you try to think? So 55-year-old female presents with knee pain for 6 months. Okay. Swelling of the right knee. What do you think? So the first thing you want to see is what flare? No. First, you're going to tell me which imaging modality you're going to use. Completely different case. We're moving back again. The first thing we think of is imaging modality. So we have a 55-year-old, so we know she's kind of old. It's a female. Okay, she's a female. Great. She has knee pain. Okay, and then it's for 6 months. If it's 6 months old, we can guess it's probably not a fracture. Agreed? Yes. We would go for X-ray. Why would you go for X-ray? Because we think there is a problem with the joints. You know, something in the joints. We also go for an X-ray because it's faster. So if there is a problem in the joints, if there was an infection in the joints, if there was a swelling around the joint, like it says over here, it could be due to infectious processes. It could be due to, you know, just exudate somewhere. It could be due to some other problem. So we go for an X-ray first, okay? So we go for an X-ray. What do we find out? We find she has osteoarthritis. Now, what does osteoarthritis mean? It means that due to old age and degradation of the collagen, or of the what was the terminology? Of the cartilage. Yeah. So due to degradation of the cartilage, there appears to be, like, you know, due to all the wear and tear, there's going to be a thinning of the cartilage, which means that the bones are going to be closer together, and that means that you are going to see an image like this. So basically what you see is irregular joint space. You see other findings which you don't need to know about this because you'll take it next year in MSK, and you will hate your life then. So this is done, okay? This is the case. So again, whenever you have a case of the joints, the first thing you're going to do is always going to be X-rays. Okay, you don't need to do an MRI over here because, yes. Okay, you don't need to do an MRI over here because you already saw the bone and the cartilage, which appears to be super clear on the X-ray. You can do a CT, okay? You can do an MRI. You don't need to, but you can do an MRI to see the finer details, to see. Do you guys know what staging is? So staging basically means to see how the disease process is, how far she is along, you know? So they can use an MRI for this. Usually in case of osteoarthritis, you don't need to, okay? So now we're moving on to the next case, which is 25-year-old male, presents with knee pain for 2 weeks. Okay, now what do you think is the problem? So first give me a list of differentials. List of differentials. What do you think can be the problem? He's appearing with knee pain. Yeah, it could be a trauma, right? So the first thing you'd go for is X-ray, right? However, honestly, I would go for an X-ray. The only reason I think, I'm not sure, I think she's not going for an X-ray is because if it was a fracture, then it would be like he would be in a lot of pain. He would be like crying his eyes out, you know, and it would be really acute. He wouldn't come after 2 weeks. He would come immediately. So we would go for a fracture. In this case, since he's coming after 2 weeks, we can think, okay, it's not that sudden. It's probably a problem with ligaments, tendons, something, especially since it's a football injury. You know how you twist legs over there and stuff. It's probably a problem with the tendons or the ligaments. There's no, another really important point that they mentioned here, there's no swelling around the joint. If there's swelling around the joint, we'd go for X-ray because it could be an infection and we want to rule out infection, okay? So over here, it could be a soft tissue imaging. Yes, we'll do an MRI. Yes, if we saw a mass. No, again, for joints, mass is different because how are we going to see a mass on a joint? We're going to see swelling. And whenever we see a swelling in the joint and it's painful, the first thing we think of is effusion or infection over there or something like that. So whenever there's swelling, we would probably go for an X-ray just for quick diagnosis. Yes, Okay, another thing, if we saw a mass in the bone itself, we would go for CT. Yes, over here it's probably tender damage, ligament injury, or cartilage problem. Okay, so over here, if we see this, how much of anatomy of the knee do you guys remember? Remember how we have the tibia? Sorry. We have the femur, we have the patella, then we have the anterior cruciate ligament, posterior cruciate ligament, which appears as an X on an MRI. So if you see this we know it's T2. So T2 means that, you know, it's going to have fluid is going to appear to be bright. Over here we can see edema or fluid appearing to be bright. So we're guessing, okay, so this is where the problem lies. Normal tendon would appear to be darker because it doesn't have a lot of fat in it, right? So normal tendon is going to appear darker. We see a lot of fluid around it. We see that it has edema. So this is most probably something wrong with the ACL, which is the anterior cruciate ligament. Make sense? Okay, so now they mentioned a T2 image over here. And then they also mentioned stir. So what is stir? Stir basically means that it suppresses the fat, okay? So it's T2 with fat suppressed. Why is this important? Because we could say that, oh, well, now it appears. So we could say that it is due to normal fat, which we see in the joint, right? So we suppress it. And once we suppress it, we know that it's due to edema only. The brightness is due to edema only. So this is what it normally appears like. If you see there's no white around this, you know, and it's not as swollen. If you see there's a swelling here, there's no swelling here. Make sense? So what did we learn about ACL tears? There's going to be edema. There's going to be brightness around the origin. And then if we want to be 100% sure, we want to get rid of the fats in the surrounding whole joint. So we do a stir. Stir is basically T2 with fat suppressed. Suppression means it'll appear dark. So it won't be annoying us and confusing us, so we can pay attention to the other stuff. Yes, flare is CSF suppressed, stir is fat suppressed. Perfect. Okay. Can we move on? Okay. So now we have case number 5, 18-year-old male. Okay, again, get rid of this. 18-year-old male. Okay, so 18-year-old, relatively young. Comes to the ER. ER, we know it's probably a lot of pain. It's an emergency. We have abdominal pain. Okay, so abdominal pain, what do you think of? You think of all of these things, right? You can think of appendicitis, you can think of gastroenteritis, you can think of IBD, forget about it. It's an inflammatory bowel disease. You don't need to know the details. But basically, it could be a problem with the stomach, it could be a problem with the appendix, it could be a problem with the intestine, something, you know? So what is the first imaging modality that you would use? Okay, let's say it's appendicitis. What's the first imaging modality you would use? Okay, cool. Thank you for saying ultrasound. So the best imaging modality for, okay, so it says right lower quadrant tenderness, so we're going to go with appendicitis, right? That's what we're going to think of. Most likely it's appendicitis. We know appendicitis is an emergency situation because it can spread and it can cause a lot of inflammation and stuff like that, okay? So we'll use a CT because it is clearer. We won't use an ultrasound because if the patient is obese, then an ultrasound will not be able to see from the ultrasound. Remember how ultrasound depends on the patient being obese or not? This is why we won't use an ultrasound. We could use it as first. I agree with you, but a CT is also as fast, you know? So we go with CT. The second reason we go for CT is because, so the first reason we go for CT is because it's more accurate. The second reason we go for CT is because ultrasound is not really required because our first problem is appendicitis. And even if we use an ultrasound, it won't be clear enough. So what's the point of going for something that's not clear enough in an acute setting, okay? That's why we don't use ultrasound, but Again, this patient is male, okay? So there's no way this guy's pregnant, and he's 18-year-old, so no way he's a child. That's another reason we're not going for ultrasound. If it came that it was a female around 18 years old, I'd be like, okay, she could have an ectopic pregnancy. I'm not sure. So we'll go with an ultrasound first, okay? But in this case, we're thinking it's most likely appendicitis. So we're going to go with a CT, okay? So we have appendicitis. Okay, so these are our differentials, okay? You have to know a little about them. So all of these differentials will be covered as we go along. So I'll tell you about them. So let me tell you about CT, something about CT. Sorry, about appendicitis. So appendicitis, classic sign is going to be sudden abdominal pain, right lower quadrant pain, is going to be nausea, there's going to be vomiting. Patient is going to have a lot of pain. If you touch the patient is going to like not let you touch him, okay? If he's not letting you touch him, that's known as guarding. Because he feels a lot of pain, his abdominal muscles stiffen up, he won't let you touch them, okay? The reason why I'm telling you this information is because they may bring it to you in a scenario and then you would know it's appendicitis, okay? So, inflamed appendix. Okay, so what are your findings in the CT? So we look at the right side. This is right. We know there's an R over here. We look at the right side. We see diffuse swelling over here. We see something that's kind of muddy around it. So we know it's probably edema over here, right? The wall is thickened. So you have specific findings over here, like yeah, okay, so the appendix itself is thickened. It's more than 6 millimeters. Obviously, you can't tell over here, but that's, you know, just some extra information for you. There's going to be edema around it, okay? The rest of the stuff, not important, not important. Okay, see over here, it tells you. So if there's an abdominal ultrasound, when would you use it? If there is a children, or if it's a pregnant woman, or if it's a female in childbearing age, you know? She might be pregnant, she might not know she's pregnant, okay? So if it's a female in childbearing age, or if it is a child, or if it's a pregnant woman, you know she's pregnant, you'll probably go with ultrasound first, okay? The findings can be inconclusive, and that's why we're going for CT. Okay, I have a question for you guys. Is this CT with contrast or is it without contrast? It's CT with contrast. How can you tell? You see these two over here? This is probably, okay. First of all, what's this? This is probably, I hope this is the vertebra. And this is probably the aorta right in front of it, and this is probably the inferior vena cava. Okay, it's with contrast because the aorta appears to be bright. Aorta is going to be the thing that has the IV contrast, right? Contrast goes into the blood, it goes to the aorta, and it goes into the vena cava. So this is a CT. This is a CT. That is why the bone is appearing to be bright. This is a CT with contrast. That's why we can see bright aorta and vena cava, or inferior vena cava. How do I know which one is aorta? Which one is vena cava? Aorta has a lot of muscle tissue. That's why it's going to be thinner. IVC can be expanded because it's thin and has a larger lumen. Yes. Thank you. You guys are going along. You guys are smart, mashallah. Okay, so gastroenteritis, IBD, forget about it. Okay, so now this is just some hints for you to be able to know which imaging modality to use. One, okay? So if you have right upper quadrant pain, what do you suspect? Right upper quadrant pain. So right upper quadrant pain. What do you have? You have the liver, you have the gallbladder. What do you suspect? You suspect, yes, stone in the liver, gallbladder, inflammation, something over there. So what do you go with? Ultrasound, because that's easiest, that's the best imaging modality over there, okay? So this is kind of like a recap of all the clinical scenarios you guys have, okay? Then you have right lower quadrant pain or or left lower quadrant pain. So if you have right lower quadrant pain, what do you think of? Acute appendicitis. What do you go for? CT abdomen with IV contrast, okay? If you have right upper quadrant or left upper quadrant pain, it's probably something to do with the spleen or something, okay? Okay, Michel's, yes, it could be a Michel's diverticulum. I agree. It could be a Michel's diverticulum. It could be something to do with the spleen. It could be something to do with the pancreas. Pancreas also reaches over there. It could be something to do with the bowels. Whatever, we'll do CT with contrast to see the bowels more clearly, okay? We don't care about the specific differential diagnosis. Okay. Then we have pelvic pain. Okay, so if we have a pelvic pain, we'll talk about these now. But I put these here because these are kind of important to know, okay? This, not so much. I'm not sure if they'll bring you lower quadrant pain, but these three, for sure, you should know them, okay? Okay, so if we have a kidney stone, what's the first imaging modality you would go for? You would go for CT without contrast, okay? No, you would not go for ultrasound. If it's a stone in the ureter, you would go for a CT without contrast, okay? If there is a stone in the kidney, then you would go for ultrasound. Okay, sorry for confusing you. Again, if there is a problem with the kidney, you think there is hydronephrosis, you would go for abdominal ultrasound. Okay, let's say the first thing you'll go for is abdominal ultrasound. If they ask you what is the best imaging modality to detect a stone in the ureter, you would say CT abdomen, okay? Let's say you'll go with ultrasound earlier, because at least you'll be able to see the hydronephrosis, okay? Then let's say you have an acute pancreatitis, what would you go for? Again, you would go for an ultrasound abdomen because actually I'll have to look up more into this, but most probably you'll go for an ultrasound abdomen because it's going to be something like right upper quadrant pain, right? Oh, why do we go for ultrasound abdomen? This is clinical. Okay, anyway, in both of these, the imaging modality that is diagnostic is going to be CT without contrast over here, with contrast over here. Ultrasound abdomen, I think most probably you're going to go for this because you want to rule out other situations. And the other situations are going to be acute abdomen, which I'll tell you about in a bit, okay? So remember how I told you, okay, now I'm going to tell you something about acute abdomen. Acute abdomen basically means that you have someone with sudden abdominal pain and you have tenderness, you have garden, okay? You can't touch it. If you touch it, it'll be rigid, okay? Person is not letting you touch it. Whenever you have acute abdomen, you will have 3 or 4 differentials in your mind. One of those differentials is going to be appendicitis. If it's a female, another differential is going to be ectopic pregnancy. Another differential is going to be acute pancreatitis, okay? Whenever you have an acute abdomen and it's not lower abdominal, what's it called? Right lower quadrant tenderness, it's just in the abdomen generalized. It's not limited to the right lower quadrant. You're not sure what it is. The first thing you're going to do is ultrasound, okay? So I think this one is for the ultrasound. But in either case, the imaging modality of choice, the best imaging modality is going to be CT with IV contrast, CT abdomen without IV contrast, okay? Can we move on to this case? I'm sorry, I had to cover like acute abdomen and other tiny details. I think they're important for you because they can bring you like weird scenarios in the exam. So you should have at least, somewhat an idea of the differentials you can think in the exam about. Okay, so if it's right lower quadrant tenderness, okay, most probably it's appendicitis. Okay, most probably I'm going to go for this and stuff, That's why I'm telling you all of this. Okay, case number 6, 28-year-old female. Okay, the reason why we don't do contrast in case of a ureter stone. Yeah, okay, sorry, let me answer the question first. Yeah, most probably, I didn't read the question yet. Yeah, okay, so one, there could be renal impairment, you're absolutely right. And giving contrast to renal impairment people means that you are inciting a lot of trouble. The second thing is, some stones can be made of calcium. So on a CT, they would appear to be bright. So if you give a contrast, let's say they didn't have a renal impairment. If you give a contrast, that would mean the whole ureter will appear to be bright. That means that the stone that you would otherwise have seen may not be visible anymore because you turned everything else white around it. Okay. So those are the two reasons why we don't use contrast with the uteric stones. Okay, so we have a 20-year-old female now we know, 28-year-old childbearing age, abdominal pain, right lower quadrant tenderness. So now you have, again, number of differentials. It could be ectopic pregnancy, it could be appendicitis. The reason why we're going for ultrasound now is because we want to rule out ectopic pregnancy, which can be ruled out way better. I think it can only be ruled out with an ultrasound. Yeah, from what I know, it can't be ruled out by a CT, okay? And secondly, she may be pregnant. So we don't want to image harm the child. Thirdly, even if it's appendicitis, at least we'll know somewhat that it's an appendicitis, you know, but we'll be ruling out ectopic pregnancy, which is a greater emergency in this case, okay? So if not pregnant, maybe appendicitis, then we can do a CT without contrast, with the IV contrast later. Once we're done with the abdominal ultrasound, once we confirm she is not pregnant. If she is pregnant, then we'll go for MRI, okay? How do you know if she is pregnant or not? You do a pregnancy test. Simple as that, okay? Why is this moving on its own? Sorry. Okay, so it could be appendicitis, it could be a pregnancy, complicated pregnancy she just doesn't know, it could be ectopic pregnancy. So that's why we do an ultrasound. If we know she's pregnant, then we won't do a CT with contrast, we would do an MRI. Okay, so over here, in an MRI, we can tell that this is pregnancy. You know, so she's pregnant. This is basically the ureter, this is the bladder. This is the appendix. We see thickening around the appendix, so it's inflamed appendix, so it's actually appendicitis. But we did an ultrasound earlier to rule out ectopic pregnancy. Now, how do we know if it's T1 or T2? First of all, it should say, and secondly, we see fluid over here. This is the bladder. If we see fluid in the bladder, what does that show us? That means it's T2. Okay, makes sense? Oh, and also this is a coronal image, so it's like this. So you can see the femur over here, you can see the bowel over here. I should have explained that earlier. Make sense? Okay, case number 7. So we have a 67-year-old female patient presents to the clinic with abdominal pain and swelling. What is the appropriate imaging modality? So now over here, I'll tell you the differential because you probably don't know. Do you know the differential? Okay, so it's a female 68-year-old. Most likely she's not pregnant, but it's a female who is 68-year-old with abdominal pain and swelling. So when we see that there is swelling, okay, over here I'm telling you, no, I can't tell you this, actually, it could be an acute case. We don't know if it's acute or chronic, okay? We just know there's abdominal pain and there is swelling, okay? So over here, the differentials that these guys have, if it's a chronic case, if she comes after like 6 weeks, complaining of 6 weeks of swelling or something, 6 weeks of abdominal pain, this could be an ovarian tumor, which is causing problems, okay? So it could be a tumor in the ovary, it could be a tumor in the colon, it could be a tumor anywhere, okay? Most probably, since she is a female and she is old age, and she has abdominal pain and swelling on top of it, most probably this is an ovarian tumor, okay? Now, ovarian tumors, you cannot detect by CT, so you won't do a CT. You can detect by an MRI, you can detect by ultrasound. So you go first with ultrasound because it's cheap, easy, fast, okay? So there you have it. Ultrasound, cheap, easy, fast, it's good. It could be any other soft tissue problem, so we go with this, okay? So now we see a tumor. So this is an ultrasound, if you guys remember ultrasound. We see that this is the ovary. We see that there is a tumor over here because it's irregular, it's, you know, not solid throughout, there's a difference in homogeneity, okay? And then once they did the Doppler ultrasound, they found that there is blood flow around this. So they know that there is edema over here, or they know that more than edema, they know that there was angiogenesis over here because the tumor wants increased blood supply. Okay, that's why we know that this is a tumor. Okay, so we did an ultrasound, we know it's a tumor, we don't need to go all the way to MRI. However, we can go all the way to MRI to give us better imaging. So if we go to an MRI, now we see this, okay? So again, this is a sagittal view. Now, which one is T1, which one is T2? Actually, I don't know, I can't really tell contrast or not. See, that's why I had to do this. So basically, this was without contrast. This was fluid. If there is fluid, we know that this is supposed to be T2. Over here, they gave IV contrast and they suppressed the fluid. Yeah, they give IV contrast and basically, oh my God, sorry. Okay, so they gave IV contrast. If you give IV contrast, you're going to go with T1, okay? Since they went with T1, fluid appears to be darker. Normal fluid appears to be darker. However, we can see this increased thing over here, which is basically the tumor, which is taking up the contrast. So why does the ovary appear to be darker here? Why is the contrast not going over here? Because these are normal blood vessels. Like normal blood vessels are supplying the ovary, and you basically don't have an increased blood supply over here. However, the blood supply to the tumor itself will take up the contrast. Okay. So over here, what does it tell you? Oh, okay, some orientation for you guys. Sorry, I didn't mention this earlier. This is probably the bladder, okay, because it's like triangle shaped. Behind the bladder, we have the uterus because she's a female. This is probably the pubic symphysis, if you guys know. This is most probably the ovary, which is expanded due to the edema and everything. Enlarged ovary. Okay, cool. Does this make sense so far? Oh, we're done. Cool, we're done. Does this make sense so far? Okay, there's one more thing I want to tell you in this scenario, okay? Okay, the reason why I'm covering these scenarios is because we had one lecture known as common emergencies, blah, blah, blah. And we had a lot of confusing scenarios, which were one-line scenarios. We had no clue what they were talking about. To us, it was all acute abdomen, appendicitis, whatever, ectopic pregnancy, something like this. It was one-line scenario and we could not tell the difference. We didn't know this extra information. So I'm giving you this extra information in case they do the same thing with you guys. And when we appealed or something, they were like, this is general information, you should know this. In case they bring something for you guys like this, if you have this tiny bits of information, you're able to work it out, okay? Now, one more scenario that I want to tell you. If it's a female, okay? Either old age, let's say she's old age, okay? And she presents to you with same scenario, swelling, abdominal pain, nausea, vomiting. But it's acute. This one is chronic. If it's an acute setting, okay? She could have something known as ovarian torsion. Have you heard about ovarian torsion? Okay, I'll tell you about this. So ovarian torsion, basically it means it's another acute emergency. So you have the ovary and you have the blood supply of the ovary, okay? Sometimes what can happen is this blood supply of the ovary is in a ligament. You don't need to know what ligament it is. But sometimes this ovary can twist. Once it twists, this blood supply is no longer there. The blood supply is impeded. It's an acute emergency. It's going to appear the same way. There's going to be probably an elderly female. It twists most probably because of the tumor. The tumor, I don't know, messed up the weight or something. It caused it to twist, okay? So it's going to be an old female, acute trauma, like acute setting. She's coming to you, really abdominal pain. The first thing, what are you going to do? You're going to do an ultrasound. Why? You're going to be able to see the tumor, first of all. Secondly, even if there's no tumor, it just twisted on its own. When you do a Doppler, you'll be able to see decreased blood supply. So you're going to do ultrasound. The reason why I said all of this is basically if a female comes to you, elderly female, abdominal pain and swelling, it could be acute, chronic, it could be acute. The first thing you're probably going to do is an ultrasound. That's the reason for the whole story that I just told you about torsion, okay? Okay, so far is all of MRI clear. We're done with MRI. If you have any confusion, anything you're not sure about, now is the time to ask anything at all. Clinical scenarios, physics, normal T1, T2 appearance. So even if she's not in a childbearing age, so if she's in a childbearing age, the first thing you would go for is going to be a ultrasound. Why are you going for an ultrasound? Because she might be pregnant. That's why you're going for ultrasound, right? If she's not a childbearing age, and let's say she's an older woman, okay, who's 68, which is not usually a childbearing age. Over here, why are you going for this firstly? Because in the scenario, they give you a scenario something like this. If they said the scenario was lower right quadrant tenderness, which is really specific to appendicitis, I would probably go for a CT first. But in this scenario, where there is swelling, there is nausea, vomiting, abdominal pain, generalized abdominal pain, or abdominal pain like not localized to the lower right quadrant, I would still go with this because torsion or what's his face? Torsion or tumor or malignancy of the ovaries is going to be more likely, and you cannot really rule that out by an ultrasound. By a CT. So you'd go for this first. Okay, that's the rationale behind this. Okay, when you do an ultrasound and you saw a tumor, why don't we do a PET? Okay, that is an amazing question. And the answer to that is, we saw a tumor. Okay, then after that, what do? We do something known as staging, because we want to know how far along this tumor is. For that, we can do a PET, okay? We can do we can do CT of the whole body. We can do MRI of the whole body, okay? Usually for staging, we can do these three. The reason why they didn't go into details of this is because it depends on the type of cancer, okay? Some cancers show up better, their metastasis and stuff show up better with PET. Some cancers show up better with this. In case of an ovarian cancer, you have to do a CT or MRI of the whole body. So it's going to be chest, abdomen, and pelvis, because it could be anywhere, okay? But they won't, there's no way they will ever ask you this about ovarian cancer in this course. There is no way they will ask you this about the staging of ovarian cancer, because firstly, they're going to ask you, they're mostly going to focus, if it's an ovarian cancer, it's mostly going to be like just the diagnosis, how are you going to diagnose it? The second reason is because in ovarian cancer, it's actually a lot more complicated than just CT abdomen, chest, abdomen, and pelvis, because they also have to open up the body, and they also have to, like, take biopsies from different locations of the body, and they also have to do a lot of other stuff, which is way too advanced for like even us fourth years. We studied this, but the doctor was like, I'm just telling you, it's way too advanced for you. So it's cancer specific, okay? But we do have to do some sort of staging after diagnosis. Does that answer your question? Okay, perfect. So now what do you want? Do you want to have a break, or do you want to go through and finish the next two lectures really, really quickly? Up to you guys. So we're done with the most difficult part. The rest of the part should not take long at all. The rest of it is going to be common malignancies, and then there's going to be interventional radiology. That's it. You are done with the most difficult parts. Congratulations. Do you have any questions over here? Anything that's not clear until now? Sure. Let's take a 10 minutes break. When we come back, since we're already doing clinical stuff, let's finish the cancer lecture. And then we'll talk about the last lecture, which is just going to be really quick, okay? So I'll see you guys after 10 minutes. Enjoy. We will start at 8:07. Okay. So this lecture is going to be about common malignancies. Okay. Over here, they just focus on 3 main malignancies, or I think 4, and they focus a lot on screening. Okay, wait, sorry. Before we go to this, I had to tell you. Okay, what is important for the exam? I forgot to tell you this part. So in this lecture, so this NMR sequence, it's important. They may ask you about a weird, I don't know, this equation, just memorize it, I guess. I'm not sure how they'll be able to ask you this, but just memorize it. Memorize this for MCQs. See, the problem is most of the exam is just going to be, at least the physics part is just going to be pure memorization. So just know which ones are paramagnetic. They're probably going to ask about gadolinium because we know it can be used as a contrast. Probably want to ask about this. Over here, they're probably going to ask about hemoglobin or hemosiderin or something like that. That's probably it. T1, T2, the only thing I think that they will ask you, encoding, no way they'll ask you. T1, T2, I think the only thing that they can ask you is going to be, okay, so what has short TR, what has short TE, what has long TR or prolonged TR, prolonged TE. They can ask you this. They can definitely ask you, okay, so for example, T1 fluid appears to be black, white, gray, whatever, you know, T2 fluid appears to be, they can ask that. That's literally it. I don't think they'll ask you anything more than that. So you don't have to worry about anything that wasn't 100% clear, except if obviously you want to know for yourself, which I highly encourage if you're studying a bit more before the exam, not like last second. Over here, these are important. They may ask you about an advantage or disadvantage. These clinical scenarios, you're probably not going to get the exact same one, but these are generally important. Yeah, that's about it. Okay. I told you about the clinical scenarios. It's mostly going to be like just, okay, so what's the next imaging modality you would use? Or they would ask, okay, what's the best imaging modality in this case? That's probably it. They won't go into more than that. Okay. Okay. So this lecture, the main focus is going to be screening, and then you have diagnosis of some common malignancies. These last two points are just like cake icing on top. Okay. So this is important. So when do we usually screen for malignancies, or which malignancies do we screen for? Okay. So screening, if for those who don't know what screening is basically a process in which you try to detect a cancer or any disease before you can actually see symptoms of that. And screening depends, like it's done on healthy people. So you want to do it to a large number of people to be able to isolate some particular diseases, okay? So if you're going to be doing this on a large number of healthy people, you know, it could be a particular category. For example, breast cancer screening could be done on women ages, a particular age, you know. Why do we do this? Why don't we do it for like every disease, first of all? And why do we do it for specific diseases? So these are the reasons for that, okay? So a disease, we only do it for diseases which are highly prevalent in the society. So we don't want to do it for some disease which is really uncommon, because it will, you know, the cost is going to be a lot versus the benefit. So for example, you have, I don't even know what example to give, a really isolated case of pheochromocytoma, you know, like there's not going to be any screening for that because it's really rare. I don't know how rare that is. I just made that up. Anyway, so diseases that have high prevalence, so they're common, and then they have non-adjustable risk factors or non-adjustable. So known risk factors, because that will, so you know which population exactly to screen. For example, breast cancer is going to most probably take place in women who are of childbearing age, because we know that one of the risk factors is going to be estrogen. Okay, so we know a risk factor. That's why we're not doing it for women who are from 0 to like 14 years old. You know, this is how it helps us out. Okay, so diseases are curable. So even if you know about an incurable disease, even if you detect it early, what's the point if you can't treat it, right? So it should be treatable. It should be curable. Prognosis is very unfavorable in the advanced stage. Okay, and is known to improve in earlier staging. So you want to detect a disease that you know if you detect early, it will make a huge difference to the life of the patient versus if you detect at later stages where it's like impossible to treat, you know? So the diseases that are screened for are usually something that will give us the most benefits with the least cost, okay? To the healthcare institution or to the healthcare society in general, okay? And they need to be, the screening tests need to have high sensitivity, okay? So what does high sensitivity mean? It means that if this is detected as positive, the chance of you having it is a lot. For example, if breast cancer is screened to be positive, oh my God, I forgot the false negative, false positives. Yes, it's true positives. Yes, I agree. But in simpler terms, it means that if it is highly sensitive, the likelihood of false negatives is less, okay? That's what it means, basically. So if you detect like a mass or something on a mammogram, which is for breast cancer, which we'll just talk about, if we detect something, you know, it could be something else. It could not be a breast cancer mass, okay? It's not specific to it. Specificity means that it's just going to be breast cancer. It could be something else, but the it's more likely not to be a false negative. That means that you will not let's see what that means. That means that it will not be, or should I say false positive? False negative is true. And the chances of false positives are less, I would say. So if it's true, then the chances of it not being breast cancer are really low. Easiest way I can word it. I think it's called false negatives. So the number of false negatives are, oh my God, false positives are really low. Yes, I mean false positive. It's embarrassing how it took me so long to remember what it was, but yeah, false positive, okay? So the likelihood of you missing out on the disease is really low. Let's say it like that, okay? Sorry about that. Okay, so screening tests. So we're going to talk about breast cancer screening, lung cancer screening, colon cancer screening. Why are we not talking about osteosarcoma? It's probably not that common. And even if it is common, we probably won't be able to do much about it. I'm not sure if this is the case or not, but it just doesn't fall into these categories, okay? So just remember these three, we do screening, and you will remember it because we're going to discuss in details, okay? So firstly, we have breast cancer, okay? And also, I think in third year, we're going to have COM again with Dr. Barat, in which she's going to, like, you know, have you memorize the guidelines for the screening again. Good thing is that you don't have to memorize it now, okay? So basically, mammography, we do it for women who are, I think, above 30, if I remember correctly, or for 21, I forgot. Anyway, it's usually childbearing age until the age of 50, okay? So that's the usual age range that we do for women, okay? We do a mammography. Why is it above 30? We'll talk about it, okay? Usually the target material, okay, so sorry. What's mammography? It is basically an X-ray scan of the breast, okay? Remember how we said X-rays can only detect bones really clearly? What do we use? We use a lower kilovoltage. If we use a lower kilovoltage, that means that there'll be a better contrast resolution. If you use a low kV. If you use a lower K edge or lower KV, there's going to be a better contrast resolution, as there's going to be more characteristic radiation. We use this target material because that's the target material. I think this is important. You need to memorize this because that's the one that gives you the characteristic radiation of a lower energy, which is basically what you need for good tissue contrast, because these are not that dense tissue, so you don't need that high of kV, that high of characteristic radiation. I hope that makes sense to you. I'm sure Makhlad covered it really well, but this is just a recap of that, okay? And then focal spot is less than 1 millimeter. What does that do? That helps with the spatial resolution. So focal spot is going to be like tiny focus beams, which are going to help you locate it onto the space, so you know exactly where they are, because we want fine details over here. We're using a less energy to be able to contrast between the materials better. Okay. Filtration material is used the same thing as the target material. Okay, cool. I don't know why they mentioned it, but whatever. Memorize. Okay. Okay, so this is basically, now you need to be able to tell what, the first thing you need to be able to tell is what planes these are, okay? So this is craniocaudal, which means craniocaudal is like this, okay? This is medial lateral oblique, which basically means it's along the pectoral muscles, okay? The reason why it's along the pectoral muscle is because you want to be able to detect the axilla, which is basically the armpit, because as I'm sure you will know soon, the breast cancer, the first place it spreads to is going to be the axillary lymph nodes. So you also want to get that in the mammogram because you're screening, and technically if there's a problem, you'll be able to detect, oh, okay, so there's a problem over here in the axilla as well. Make sense? Logic makes sense? So far, so good. Okay, secondly, okay, so what are the abnormal findings that we can find? Okay, so the abnormal findings that we can find is going to be okay, let's switch to make your lives easier. You guys didn't tell me if the screen was too small, so I just didn't change it. I'm sorry. Okay, so the abnormal findings that you can see. What's we want? Okay, so the abnormal findings again that we can see is probably going to be stuff like a speculated mass, or it's going to be microcalcifications. So as you know, calcium, X-rays can block calcium. Calcium blocks X-rays, sorry, and it appears to be bright. So we can see microcalcifications, which is a sign of a cancer, which is just about to begin. Okay, so it's early stage of cancer. Spiraculated mass. Mass means that there's something over there. Spiraculated means that it has it's star shaped. So it has like edges, rough edges, which are like you know, sun rays coming out of this mass. It's not regular. It's not smooth. Okay, spiraculated mass or speculated mass. Speculated, yeah, whatever. It's speculated mass usually. Speculated means it has a lot of speculations, almost the same thing. So these are basically some of the signs that you can see in the mammogram. Now, why do we not use an ultrasound, and why are we using a mammogram for screening? Okay, this is a really valid question because you know ultrasound is less harmful than mammograms. So the reason for this is mammograms are better at detecting spiraculated masses and microcalcifications. Okay, this is the reason why we usually use mammograms. Sometimes we can use ultrasounds in cases that a person has really dense breast. What does that mean? So breast is made up of usually fat tissue. In case the fat tissue is dense, the mammogram is not able to differentiate between a really between a mass or a cancer or tumor and fatty tissue, because it'll appear to be brighter as well, right? More density will block more X-rays, it'll appear to be brighter, right? So if there's dense breast, then we prefer to use ultrasound. Where is this usually the case? Females less than 30 years of age, okay? That's why the screening for mammography is greater than 30 years of age, okay? Just using logic to help you able to connect these. You don't have to memorize the ages, whatever. Okay, and then you also use ultrasound in case that there is a cystic component. So you know how X-rays are good at detecting masses and spiraculations. They're not really good if there's a fluid-filled cavity. Cyst is a fluid-filled cavity, so you do an ultrasound. And lastly, microcalcifications. Again, microcalcifications in younger women, okay? Or it could complement this. But what complement means is, for example, you do a screening. Screening tool does not mean diagnosis. So whenever you have a clinical case, or whenever you have a case in general, screening, first you have to screen. If you screen something and you detect an abnormality, that means that this person has to come to the clinic. Now you have to diagnose that person. So for diagnosing that person, now you need to do something else, So to confirm your diagnosis that this is cancer, you also use an ultrasound, okay? But it can't be used as a screening tool for everybody in the population. Does that make sense so far? Okay, so ultrasound, we're basically using the different things that we can see as a cyst. So if it is a cyst, now I am going to be asking you guys, if we see a cyst, we know it's a fluid-filled cavity. So what do we see behind it? Pre-midterm lecture. Thank you. Yes, please tell me you guys didn't read it off of here and you actually remember it. So yes, it's going to be posterior enhancement, so you know that this is a cystic component, okay? Now, if there is a mass, now how do we know it's a mass? It's going to be not anechoic, it's going to be either isoechoic, remember, same density as surroundings, or hypoechoic or hyperechoic, okay? But it's definitely not going to be like fluid filled, okay? That's one thing. The second thing is you're going to look at the surroundings. So if the surroundings appear to be smooth, it's most probably benign lesion. If it appears to be spiraculated or speculated, rough edges, difference not anechoic, difference between this, solid tissue presence, all of that, it's most probably breast cancer, okay? Make sense? Okay, so in this case that we're going with, firstly, we had a woman who we were screening for breast cancer. So we did a mammogram, okay? Then we found some things that seemed to be suspicious. So we brought her to the clinic and we were like, okay, we need to diagnose you. And once we diagnosed her using an ultrasound because it presented all of these more details. And then we diagnosed her with breast cancer, okay? Now we can also use an MRI to breast in certain situations. I'm not sure what type of cancer this is or not, okay? Anyway, we don't use it for screening unless it's really, really specific. Certain populations, a person has BRCA gene, BRCA1, BRCA2, they have positive family history, their mother and sister and aunt had, breast cancer in the past, all of that. This is already a high risk individual, fine, we can maybe use an MRI. Whenever they ask you, they're going to ask about the general population. They're not going to mention MRI, okay? They're not going to mention ultrasound for screening, okay? Make sense? Then we're done with breast cancer. Any questions about breast cancer? We can also use an ultrasound. One thing I forgot to mention. You can also use an ultrasound to take biopsy. What does biopsy mean? It means to take a part of a tissue to be able to send it to pathology lab so that they check it in the pathology lab and tell you exactly what type of cancer or what type of lesion this is, benign, malignant, whatever, So what they can do is when they're taking a biopsy, they can use ultrasound imaging to guide them to directly where the mass or the problem is, okay? So ultrasound can be used for diagnosis. It can be used for taking biopsies. MRI can be used for screening, diagnosis, blah, 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 but it's very limited to really certain populations. They will never ask you about this. Normal screening is by mammogram for the general population. Anything you want to know about breast cancer in details other than this? What last point? Again, I kind of forgot what I told you. Okay. So now we're moving on to lung cancer. So lung cancer, what do we use for screening? CT, memorize. Why CT? It's just the most accurate. For screening, so again, this is for the general population. This is not for diagnosis. Why are we not using X-rays? I think most probably because X-rays are, yeah, exactly. So findings in X-ray, you can't really find them if the patient is asymptomatic. Remember how in screening, it's a healthy individual? X-ray findings are usually only visible if the person has, like, the disease has progressed to a state where the person is coughing, there's blood in his cough, the person is losing weight, night sweats, fever, all of that. So this, when you're screening, it's going to be asymptomatic. Okay. Now screening age, oh wow, the broad screening age, you'll have to memorize this. So screening age is usually people who are older than 55 years old, lesser than 75 years old. Usually people who are smokers or have quit within the past 15 years. Okay, what does it say? So 55 to 80 years, history of smoking greater than 15 years, or who is currently smoking or suffered in the past 15, okay? So all of these people are the people who are screened, basically. They don't have symptoms, okay? Okay, now why do we use a low dose? I think makes sense. It's CT. CT will have more ionizing radiation. We're just screening. We're doing it on a large scale. We're doing it for the general population. We want less harmful effects, okay? And whenever you're doing screening, so it's going to be yearly, right? Or it depends on the type of screening. But in this case, I'm guessing it's yearly. Please tell me it's yearly. Okay, whenever you screen, I don't care about the time. It's probably yearly. But whenever you screen, you always have to, like, if you find an abnormal finding, always go back to the scan that you took earlier for the screening earlier and compare it, okay? So when you compare both of these, you see that, oh, okay, so there's this new mass over here that wasn't there before. Now you know, okay, so this is probably abnormal. We need to work it up. If you find an abnormal reading, now what will happen? Now this person is outside the normal screening population because now we think he's high risk or he has some problems. So now we bring him to the clinic and we work him up. Workup means that we diagnose him, blah, 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 everything, So we go for, okay, so now we want to diagnose him. So what do? We do a biopsy. For biopsy, CT also helps us because CT shows us exactly what the problem is. So we do a CT guided biopsy exactly to the place where we want to, So if this makes sense to you, this is literally the previous image over here. This needle is being inserted through the lateral chest wall, through the intercostal space, between the ribs, and then they go all the way to the lungs, and then they take the biopsy, okay? So transthoracic needle biopsy. So this is also where CTs are used for. So we talked about two things, biopsy and screening for CT until now, okay? Now we're done with the screening for CT and for lung cancer, okay? Now we're talking about a clinical case. So 62-year-old smoker, 62, he's old. Most probably a male, okay? Smoker, okay, we know he's high risk for cancer. Then we have cough and shortness of breath. So we know that this person no, this is CT. For lung cancer, it's going to be CT. Ultrasound is going to be for breast, okay? Okay, so we know this person is symptomatic. Now we're working up. So we're past the screening phase, okay? So when we do, so now since we know the person is symptomatic, the first thing that we can do is chest X-ray because symptomatic person, and most probably this guy did not come for a screening, so we don't know if he had any findings. Otherwise we would have been able to detect it earlier. So now we have a person. He came to us with shortness of breath, coughing. We do a chest X-ray because that's the first line modality, and then we see a mass. Now we want to be able to have more information about the mass, so we do a CT, okay? So now we see that this mass is crossing the midline. So this is the mass, this is the midline. It's crossing the midline. The patient is symptomatic. We know he's not a surgical candidate. Don't wait for X-ray. No, we do an X-ray first. I don't know why this is mentioned. Not a surgical candidate. How do we know this? So really simply, if it's an early stage, usually when it's detected by screening, if it's an early stage, it's detected by screening. That's the whole idea. You want to detect at an early age. Early age, you can resect it, and it's like easily resectable. If it's from the sides, it's either resectable. This one, it's crossing over the midline. Most probably has a lot of structures near to it, the heart, anterior mediastinum, a lot of structures, posterior vena cava, all of this, you know, so he's not a surgical candidate. So we have basically for every cancer, we have 3 lines, 3 basic types of treatment. We go for surgery, resection, or we go for chemotherapy or radiotherapy, you know, radiation or chemotherapy. Over here, we can't go for surgery, so we'll go most probably go for something else, okay? Now, we know it's crossing the midline. Before we start chemotherapy, the one more thing that we need to know is how much it's spread, okay? So over here, local spread, as we said, was done by a chest CT, okay? Now, if we want to do staging for lymph node, we can do either PET or PET CT, okay? And this is the FDG, let's memorize, okay? Because you took another lecture of PET with Makhlad, okay? Just memorize this. If it is a metastasis, again, so if we want to check which lymph nodes are affected, most probably if it's regional lymph nodes, regional means thoracic. Regional lymph nodes means lymph nodes in the mediastinum. It could be lymph nodes elsewhere, so we have to do a chest of the, oh my God, we have to do a CT of the chest, abdomen, and pelvis, okay? All of them. Usually for staging, we do all 3 of them, okay? That's called CT cap. C for chest, abdomen for A, and pelvis for P, okay? P for pelvis. And also, we also want to check for metastasis to the brain, okay? So this is important. Lung cancer can go to the brain. CT, you cannot detect metastasis with CT, so you have to do an MRI, okay? Make sense? Okay, so over here, this is telling you that it is stage T4 because it's closer with the midline, whatever, you don't need to know about the staging. It's when they did a PET CT, they found out that contralateral lymph nodes were affected. Contralateral means on the other side. So if the mass is on this side, it's on the other side crossing the midline, okay? And then once they did the metastasis, they found out that they did the brain MRI. They found out that over here, there was also metastasis to the brain. So now we know this is stage 4. The only way to treat it is going to be either chemotherapy or something, okay? Why did we do this? To find out how much it's spread, basically for staging. But this one is for local staging, I would say. So we did X-ray, we found a mass. Okay, so you do CT. Yes, but CT you do of the chest, abdomen, pelvis. Or you just do for the chest, whatever you get in the exams. PET you do for, again, chest, abdomen, pelvis. You know, this whole thing is being PET scanned. Brain for MRI, MRI for brain. Just remember brain is different. You can do either CT or PET, doesn't matter for staging. MRI for brain, yep. Okay. So we're done with lung cancer. Any questions about lung cancer? It's clear, right? Sorry. Okay, again, lung cancer, screening, CT. Asymptomatic, screening, CT. Once they have developed symptoms, they come to the clinic. First thing you do is X-ray. Why? Because it could be anything, you know? It literally could be any other reason he's coughing. But when you do an X-ray, first line, faster, less radiation, whatever, you see a mass. Now, once you've seen that mass, you want to know, okay, what exactly is the mass? How far has it spread? Local staging of this. So you do a chest CT again. Now, if you're thinking, oh, okay, it's definitely a mass. You did the biopsy as well with the CT, confirmed it's a cancer, confirmed it's a metastatic cancer. Now you want to do staging for the whole body. So for the whole body, you do either PET or you do chest, abdomen, pelvis. And also you do a brain MRI to check for metastasis in the brain. Make sense? Good recap? Good summary? Okay. Now we're going to talk about colon cancer. So colon cancer screening, how is it usually screened? It's done by CT colonography. Okay. One thing that I have to tell you from now, next year when you learn in comm, the screening is going to be by colonoscopy. Colonoscopy basically means, you know what endoscopy is? So you basically take a scope, which has a camera, and you insert it into the esophagus, and then you see everything down there. Same thing with colonoscopy, only you place it from the anus to the rectum, and then you see the large intestine. The reason why I'm saying this is because you may be confused later on. Over here, notice you don't have an option of colonoscopy, firstly. Secondly, it's a radiology lecture, so you don't expect that. Thirdly, you can also screen by CT coronography. It's just more recent. It's in the newer guidelines. Usually they did colonoscopy, okay? Oscopy, scoping. Scope means camera. Graphy means pictures. Make sense? Okay. So colonoscopy, the cool thing about this is it's CT, so you can do two dimensions, and then you can also do it in 3 dimensions because it's fancy CT, okay? So what are the abdominal findings you can find over here? You can find either narrowing of the bowel, or you can find something like a polyp. That's usually the most common finding that they find. So if they find a polyp, so the person was abnormal, no symptoms, nothing, no constipation, no bleeding per rectum, no symptoms of weight loss, whatever. The person was asymptomatic. They did a colonoscopy, CT colonoscopy, and then they found out polyps. So now what they do? They confirm this with biopsy. Okay, fine. Then they do staging. For staging, what do they use? They use CT, abdomen, and pelvis. Okay. So again, for screening, it's going to be CT colonoscopy. For staging, it could be CT, abdomen, and pelvis, or it could be an MRI in cases you suspect something wrong with the liver. Because you know how in CT you can't really tell what's going on with the liver. Also with rectal cancer. So you have to do MRI for these 2 things, okay? Rectal cancer, because it'll give you more details, more than the CT. Okay, make sense? That's literally it for colon cancer. You may notice that the amount of information is decreasing as they go on. Same thing for the questions. Most likely you'll get questions about breast cancer, lung cancer, less likely to get questions about colon cancer, right? So now we're moving on to lymphoma. What is lymphoma? Lymphoma is basically tumor of the lymph nodes, okay? As simple as I can put it, okay? So tumor of the lymph nodes. Now, when do we use imaging for this? I don't think there's a screening for this, okay? So screening, we're done. Lung, breast, and colon, khalas, done. Osteosarcoma, beginning we discussed, we don't use screening for that. Lymphoma, the only time you use it is going to be staging, okay? And depending on the different findings you see, there's going to be a different stage 1, 2, 3, 4. You don't need to know the details at all, okay? The second reason is for follow-up of the therapy. So you did chemotherapy for this, okay? You treated them for it, and now you want to see if they still have problems or not, okay? So what do you use for lymphoma? You either use CT, but CT, fine, you can tell something, but then you use PET scans, okay? I'm pretty sure you covered this already with Maqlad, or you're going to cover with the doctor already, okay? So just remember, lymphoma, PET scan, or CT, chest, abdomen, pelvis for staging and for follow-up of treatment. Treatment follow-up, what they're trying to show you is, oh, okay, so you see all of these hot nodules. You can detect them over here as well. You can really detect them here. Once the treatment is done, now you know, okay, so the treatment is affecting, at least they're reducing. And you also know that, okay, so the treatment is not fully done because some nodules are still there, you know, so it helps you out. Okay, beyond diagnosis. Now, this is basically the next lecture. This is nothing over here. What they tell you about here is that you can use radiology for a number of things. So it's screening, it's diagnosis, it's staging of the disease after you have diagnosed it. And you can also use it in some forms of therapy. So the most common form of therapy that you need to know is going to be chemoembolization of the liver. Yeah, and radiofrequency of the liver itself. This, they mentioned it, I don't think they will ask you this, you know, kidney and lung. Okay, so for lung, in certain situations, you can get rid of the cancer by thermal ablation, okay? Thermal ablation, which means that you provide heat to the area. Cryotherapy means you freeze the area. RFA means radio frequency ablation. Basically, you apply a lot of radio waves to a targeted area and it burns the cancer in these two locations. Chemoembolization basically means that you are providing chemotherapy to a specific area in the liver, which is basically a liver cancer, or you are embolizing it. Embolizing, we'll discuss it in the next lecture. Literally, that's all the next lecture is about, but basically it means to fibrose the blood vessels which are supplying the area. So when you fibrose the blood vessel, that means that the vascular supply to the cancer will be gone and it's no longer there. So just remember, chemoembolization, liver cancer. Radiofrequency ablation, kidney and lung. That's it, all you need to know. Over here, they're showing you, oh, they're being fancy and they are applying radiofrequency ablation. Basically, they're burning this area. This is most probably the liver, which they're trying to burn, or this is a renal mass over here. Okay, so sorry, it was a renal mass. So they found that there's a tumor over here and they want to get rid of it. So they're going to use radiofrequency ablation, okay? So kidney cancer, radiofrequency ablation, lung cancer, radiofrequency ablation, liver cancer, chemoembolization, okay? Just memorize, move on. Pre-surgical localization, basically they're telling you that if, for example, they want to resect a tumor or something, imaging can be used to guide you to that. It's the same concept to biopsy. Biopsy was you take a small piece to be able to diagnose what the problem is. Now it's helping you to understand which area you want to excise, to resect, to take out in order to cure the cancer. Okay, basically that's the principle over here. You can use it in breast cancer, you can use it in lung cancer. It's really easy to remember because we also use these for biopsies over here and over here. Yeah, that's basically it. It helps guide surgeons. We're done with this lecture. Do you have any questions about this lecture? Anything you don't understand? Anything that was not clear? This lecture is just, the only confusing part in this lecture is the part where you don't pay attention to whether the question says screening or staging or diagnosis or follow-up of treatment, something like that. That's all they're going to ask you. So in case of this cancer, for staging, what do you use? For screening, what do you use? Stuff like that. So it's just memorization and some basic understanding, Okay, now the last lecture. Okay, so this last lecture, I'm sorry, I'm not going to give you a break for this because it's going to be really short, inshallah. Okay, few points about this lecture. Firstly, we did not take this lecture. 11th class did not take this lecture, so I have no clue what the guy wants to focus on. That's number one. Number two is this lecture is about interventional radiology, and that is a huge topic. And I think the focus of this doctor over here was just to give you an overview of this, okay? Just where these are used, where interventional radiology is used, okay? No, 11th class should not take this. I'm sorry, you will have to go to the recording or transcription for, you guys will have to do the transcription or recording if you guys are really curious about this. I personally think there's not much questions he will bring from this, because most of this is really, really advanced. The thing that I think he can ask you, I'll tell you, I'll tell you what to focus on. So basically over here in this slide, I think, oh wait, firstly, did you guys take this lecture with the doctor already or not? Most importantly. Oh, okay, took it. How many attended that? Or if you attended that, do you remember what he focused on? Because if you do, that would make my life easier. If you don't, that's fine. I'll tell you what I think is important. And you can, I don't know, transcription, recordings, or if you don't want to, just go wing it, I guess. I would honestly wing it at this point. If you remember anything, let me know. Otherwise, I'll just start. If you don't know, just say I don't know so I can start. It's fine. It's perfectly fine. There's no way I'm judging any of you. Perfect, no clue. Okay. Okay, so yeah, I think so as well. It's just an overview, and then they're going to bring random questions from this. Okay, so basically what he's trying to tell you in this slide, I think, is that radiology has two components. One is imaging, diagnostic, everything we did so far. Staging, blah, 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 blah. And one is intervention. So intervention means anything to do with treatments. Okay? that's basically it. As you can see, a lot of organ systems can be involved and a lot of different types of interventions are there. Next. Treatment guidance. So firstly, as we mentioned in the previous lecture, it helps guiding treatment in terms of biopsy, helps guiding treatment in terms of surgical surgeons where to go, okay? Then you have different tools. We'll talk about the tools as we get to them next. Okay, so what can we do? I personally think this slide is really important for your level, and I think this slide is what his emphasis of the whole lecture was on. So they may bring you a question, okay, what can intervention radiology be used for? So it can be used for removing blockages. We'll talk about all of these in details. So stopping a bleeding, creating new tracts, bypass, deliver medication, and taking samples, plus removals of feeding, okay? So these are basically going to be like the main points of this lecture, okay? So now we're going to talk about removing blockages, okay? So you can have blockage in all of these places. So you can have them in blood vessels, esophagus, duodenum, basically bowels, kidney, ureter. So any place where there is a lumen, you can have a blockage. So you can have a narrowing. So you want to remove the narrowing. Next, move on. Okay, so what are these? These are basically the abdominal aorta splitting into the external iliac, or the iliac veins, let's say that. Iliac arteries. Okay, so there's going to be a narrowing of the arteries. Where do we have this? Common example, atherosclerosis, most common example, okay? Do you know what atherosclerosis is? It's basically fat buildup of the vessels in case of a person who has diabetes, blah, 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 heart condition, okay? And the problem with this is it can lead to heart problems if you don't already know. So you can have a part of this fatty stuff, you know, block the flow to the heart, and then you can have a heart attack. If it blocks flow to the legs, you can have a thrombus in the leg, which if you watch House, you know, he had that, and that's why his leg can't function anymore. And you can also have a stroke, whatever, okay? So you basically can have an MI or stroke, and you want to basically remove the blockaging because you want the blood flow to be restored. So what do? You insert what you do is you insert a catheter. A catheter basically means fancy metal line through this, and you insert the catheter and you find the blockage because this is already imaging. So you know exactly where the catheter is and exactly where the blockage is, okay? I can't see any catheters here, or if they are there, I can't really tell. You'll probably see them somewhere else. But what you do is basically you insert a balloon, okay? So basically the catheter has a balloon on top of it. And then you insert the catheter, and once it goes through, this place has the balloon. So you inflate the balloon, and what happens is it gently like pushes out, you know? So the lumen is no longer blocked. So now you have normal flow restored, okay? So chances of stroke, chances of stroke, etc. are reduced, okay? So now once you put this procedure is known as angioplasty, okay? You've probably heard of it. Oh, a person has angioplasty done for his heart condition. This is what they're doing, basically removing the problem. The second thing that they do in this case is they don't want it to accumulate over time, so they place a stent over there, okay? So basically the stent, you know, it stops it from narrowing after, you know, some time. That's literally it. So balloon and stenting over here, remove a blockage, most probably atherosclerosis, okay? Now, remember how I said you can have a problem in the heart or this brain? You can also have a problem if this artery is supplying the lungs. So this is the lungs. If you can tell, these are the vessels inside the lungs, and you can tell that flow after this is no longer there. There should be branching, like there is branching over here and over here. So you know, okay, so the blockage is over here. What do? You do mechanical thrombectomy. Same procedure. You just go in there and get rid of the clot. Okay? Easy. Again, you can have a balloon, so balloon dilation, and then you can have stents. Stents can be made of plastic and metal. Wow, fancy. Not our problem, okay? Next. Now, this is kind of new, and you probably never heard of it. So this is basically a ureteric stent. So if you have a problem in the ureter, you can have, you know how you can have a, okay, let's say you have a stone, in the ureter. Okay, that's causing the urine flow to be obstructed. If it's causing urine flow to be obstructed, you have hydronephrosis. So you want to restore this flow of urine first, and then you want to worry about the stone, right? If it's obstructing the whole thing, because otherwise you'll have hydronephrosis, kidney failure. You don't want kidney failure, okay? So you can have a stone which causes this. You can have a tumor. So a tumor, an example of this, like think of a tumor which is outside the ureter. So it can compress on the ureter. It can cause it to like narrow down. And then you have a stricture basically means that the ureter itself, it got some fibrosis or something, and now it's narrow. So either way, what you want to do is restore the flow. So what you do is you insert this fancy tube. You insert it through the urethra. Yeah, through the urethra, you insert this tube. Okay, you can insert it in two ways. Either you insert it through the urethra or you insert it percutaneously through the skin. We're not talking about the skin one, okay? We're talking about through the urethra because that honestly makes more sense. So what happens is this is curved at the end, you see? Now this, you have to remember it's made of plastic or it's made of rubber. So you can literally like, you know, make it straight again. So once you're inserting it, you make it straight again, and then you keep on inserting it. And once it reaches the calyces of the kidney, you know how there's going to be some space around it. There's no longer the ureter. So once it reaches a place where it's dilated, it by itself, since it's rubber, it just coils up. Since it coils up, it can't be taken out. You know, it won't move from its place. So it's really smart how they make it go like up like this, and then it's also coiled over here. So there's two ways they can insert it, right? So over here, most probably, they inserted it from the skin, and it went to the kidney, and then it went all the way down, and it curved up over here, okay? Yeah, that's most probably what happened over here. The other way to do it is through the urethra, but in that case, I'm not sure how they're preventing it from curling over here, because it can curl in the bladder as well, right? This is the bladder. But anyway, the idea is that it'll curl both ways, so it'll stop it from moving around, okay? You don't need to know where it's inserted from, where it goes, blah, blah, blah. That was just logic that wasn't making sense to me at this time, okay? So again, if you have a problem with the esophagus, how can you have a problem with the esophagus? You can have a tumor outside the esophagus, which basically causes it to narrow down. Person cannot swallow properly. So the first thing you want to do is, you know, deal with the problem at hand. You want to be able to make them swallow properly. So you can place a stent like you placed for the blood vessels. Again, tubercle narrowing, you can also place a stent, okay? Remove blockages. Okay, so stroke thrombolysis, you probably know this better than I do. Okay, so these are basically vessels which are supplying the brain. In case you know, this is probably the circle of Willis, which is supposed to like keep on going and then goes up. Neuro people, I'm sure you know this. So over here, they didn't detect this. So what they did was immediate TPA, thrombolysis, and basically they prevented or they fixed the stroke problem, okay? Why do we want it to curve? Yeah, we just want it to curve to stop it from moving. Like, you know, we don't want it to move around from place to place. So we just curve it at the end, or it just curves naturally at the end. So it's just fixed. When we want to remove it, we can just pull it back. You know, it won't be a problem. Yeah. Okay, great. Okay, so we're done with the first basic category, which is removing blockage. So you can have any blockage, kidney, lung, iliac, aorta, and the brain. Cool, cool, makes sense, move on. Anything you don't understand, anything that wasn't clear? The curving is the extra information. That's just to help you guys understand it logically, okay? Okay, so now we have stop bleeding. So in case of stopping bleeding, what is the problem going on? There's going to be some bleeding going on that we want to stop that we cannot stop with other methods, okay? So, or there's some other treatment, okay? Or there's some other problem. Okay, let's talk about some other problem here. Let's cover it here. So the other problem can be that you want to stop blood, so it could be a hemorrhage. You want to stop the blood supply to an organ, a tumor to it, like, you know, to a tumor in an organ. Remember, okay, we'll talk about this. Don't remember yet. Okay, so over here, what's happening is that there is a person who came in probably with lots of bleeding in the lungs. So what do? They go to the bronchial artery, which supply the lungs. The pulmonary artery is for the gas exchange, okay? bronchial artery supplies the lungs with its own blood supply. So we go to the bronchial artery and then we basically insert something, some form of agent, which will cause clot formation. Previously, we wanted to get rid of clots because we had blockage. In this case, now we have either bleeding or we want to stop the blood supply, okay? So we are going to either insert a glue or onyx, same thing. You don't need to know the details of this. Either some particles which will, cause thrombosis, which will cause a clot, coils, whatever, okay? You just need to know these things cause clotting, okay? So this is the gastroduodenal artery. This you can probably tell is the lungs. This is bronchial artery, which is also the lungs. You can't really tell. Maybe you can tell that these go along the ribs, probably, I guess. A lot of imagination over here. Okay, so then there can also be a problem of fibroids, okay? So you do something, uterine artery embolization. I don't know if you remember from your ultrasound lecture, but in the uterus, we had a problem of fibroids, okay? And we used an ultrasound to check it out. So in the uterus, if you have fibroids, basically the problem is that the fibroids have a lot of vascular supply. They keep growing because they have a lot of blood coming to it. So an easy solution to this is just to block the uterine artery, just embolize over there, cause an embolus by ourselves. Over here, we're using particles. Okay, fancy, good to know. And it causes blood flow to stop over there. So now it's showing you this is a MRI. I don't know why they're using it here, but okay. So they're showing you an MRI. Oh yeah, they're using an MRI because fibroids can also be seen with an MRI, or they're usually seen with an MRI. So over here, they're trying to tell us, okay, so there was a large mass over here, which was irregular, whatever, and then they did an embolization, and now it's reduced. So the treatment was effective, okay? Pre and post treatment. Okay, so prostate artery, you can also do it to the prostate artery in certain situations. You don't need to know what they are. Yeah, okay, sorry. So a uterus is usually this size. Over here, the problem is it's so big that it's literally causing the uterus to expand itself. Or, okay, no, it's not causing the uterus to expand, but it's on an outer layer of the uterus. So you see this uterus? This is the normal uterus. You see this? This is on the outside wall, and it's grown so damn large that it's going to be causing a lot of problems. Like, it's going to be affecting the bladder. For sure, this person has problems with urinating. This person has problems with constipation because the bowel is affected over here. This person probably has abdominal swelling because, it's literally so huge, So this whole thing is a mass. This is still your uterus. Okay. So prostate artery, use something called particles for prostate artery in certain situations. I'm not exactly sure which situations, but I'm guessing cancer. Okay, bleeding cervical tumor. Again, mostly these are used for tumors. So cervix is somewhere down here. So you want to embolize. So pre-embolization, you see, oh, there is blood flow. There's lots of blood flow, tiny blood flow here. So you get rid of the internal iliac artery, and then all the blood flow stops. You're happy, okay? So the idea is you don't want to supply blood either due to the bleeding because there's bleeding, or due to a cancer in this case as well, because the cancer requires blood flow, blood supply to increase, to grow, angiogenesis, all of that, okay? Now, another thing which is different from bleeding and tumors is something known as AV malformation. Basically, in simple terms, what AV malformation means is that there's going to be, how usually there is an artery, and there's a vein, and then there's capillaries in the middle? Exactly. Sometimes you can have an artery which directly connects to a vein. So when an artery directly connects to a vein, it's going to be high pressure stuff, right? High pressure fluid going through it. When there's high pressure fluid, the vein is distensible, it gets really enlarged. So you can have problems like venous malformation over here. Artery venous means shunt between artery and vein. venous malformation, shunt between two big veins, okay? So it causes enlargement and it looks super weird and people are freaked out. And the only problem is high blood flow to random vessels over here. So what do? We embolize. So sclerotherapy, sclerosis, if you remember, sclerosis means fibrosis, which basically means fibrosing the affected vessels. Now, why would this not cause a problem? Why would this not cause necrosis to all of this area? Because you have collaterals. Collaterals are parallel vessels which will still supply the blood, but those collaterals don't have this problem of shunting, okay? So this is before and after. So this person had a huge AV malformation and it's like, you know, really difficult for the person to bear. And then once he's done with this, you then notice a lot of improvements, okay? So you can use coils, glue, alcohol. Honestly, I don't think you have to memorize particles where, coils where, just read through them. I think from what I remember over here, we use particles for whenever we want to stop excess blood flow. I don't know if it's important to memorize or not. If one of you goes through the doctor's lectures, probably, you know. Okay, so this is before this happened, a lot of blood flow, and then they sclerosed all of this. So now there's no longer blood flow, people are happy, okay? Now so we talked about three things: hemorrhage, tumors, AME malformation. The fourth thing to stop bleeding is going to be varicose veins. Now, varicose veins, if you don't know, it's a problem in the in usually the superficial veins of the legs. And what happens is the walls of the veins, you know how veins have walls, they become incompetent. Incompetence means they're no longer working. What happens is the leg can no longer push the blood up. That means that they accumulate in the leg. So you can have different types of treatments, like you can give them stockings, whatever, apply pressure outside, do a lot of stuff. However, in case that does not work, what you do is you sclerose this, same thing. Now, you can have two different therapies for this. You can either do it by laser. So you see there's this catheter, fancy tube thing that goes inside the femoral artery. No, what's femoral artery? It just goes into the saphenous veins, okay? It just goes in the saphenous veins. And then the area which is dilated, it just heats it up, and the laser causes laser, radiofrequency ablation, glue, whatever, it causes it to collapse on its own, okay? Why does it not cause a problem for the legs? Because they have deep veins as well. The problem here is just the superficial veins, which are, you know, causing pain because of the dilation, which is affecting the nearby structures, the nerves around it, okay? So over here, as you can see, this is ultrasound guided. Wow, fancy. Ultrasound was of use to us over here. Sclerotherapy usually means that they're using some chemicals, okay? So sclerotherapy usually means chemical agents, and laser is basically radiation over here, okay? Same principle. So as you can see, this was dilated, causing a lot of pains. After this, voila, you know, a symptomatic treatment. Okay, now we're done with the first two. Any problems with the first two, or can we move on? Okay, great. Okay, so now we want to create access, create new tracks. Okay, now this is the problem. This is where I had a problem with this lecture. You guys should not be learning about this in details, because honestly, we learned this in fourth year surgery. Whatever, I'll try to simplify this as much as I can, okay? So we have to create new access or tracks. When do we need to create new access and tracks? We'll understand it as we go along, okay? And there are new terms that are, like, you know, really annoying. Okay, so the first thing that we want to know is create access. Access means that you want to get access to inside of the body to either take blood tests from there, either take, you know, some values like, you know, what's the pressure over there in case of, what's the pressure in the heart over there, if you want to deliver any medications to this, like chemotherapy specifically in this location, or you want to do something else, okay? So that's basically what access means, okay? New tracks we didn't talk about yet. So what over here they're telling you is, and I think this is important, they may bring an MCQ on this because fancy different colors and stuff. You have different types of catheters that you can place inside the body, okay? And once you place these catheters in the body, so this portion is in the body, this portion is outside the body, okay? You can use it for different things. Over here, permacath is a type of catheter, which is this one shown over here. It's used for short-term dialysis, okay? So basically, it's used for dialysis. Do you know what dialysis is? First of all, sorry. Dialysis, basically, in cases of renal failure, people cannot use their kidneys anymore. So you have to connect them to an outside machine, which basically filters the blood for you. Number one, what is dialysis? Number two, for this, you need to have an access, or you need to have access to the blood supply. So you need one access for the arteries, one access for the veins. This is what we're using over here. So if you see, this has two channels. It has two channels throughout this, something like this. So one goes in the artery, one goes in the vein. No, in this case, it's going directly to the vena cava. Anyway, you have two, so blood goes through here, clean blood, and then, dirty blood goes through the artery, and then it's returned through the vein. And the vein is returned basically over here, okay? So this is basically a permacath, which is used for dialysis. Short-term dialysis, not long-term, okay. So a really common question, they may ask you, even though they didn't mention it, but what's the problem of having a catheter inserted for a long time? You can get infections because it's a foreign body, okay? So this is why you can't insert these for a really long time, okay? Permacath, dialysis, temporary. Okay, memorize, makes sense, move on. What does Hickman do? Hickman is literally the same thing. Something like this with two lumens going inside. It delivers chemotherapy. Yeah, this one is permacath. I think so as well. I honestly don't think they'll bring you pictures and ask you to tell which is the difference, but from what I know, permacath has two internal lumens and two internal things, okay? This is permacath as well. Also in permacath, from what I know, this permacath usually has one red and one blue. So okay, so this one attaches to the artery, this one attaches to the vein, okay? Hickman is the same thing as this. It has two, from what I know. It can have three, it can have four, okay? So you're right, this is probably Hickman. So if they ask you, this one with one blue, one red is probably permacath. This one is probably Hickman. When I studied in surgery, they told us two. It can have three, not a big problem. What's it usually used for? It's used for chemotherapy or other medications, but you memorize chemotherapy, okay? Hick is fancier, okay? Okay, one more thing. You see how dialysis is going right to all the way near the heart? This one? Hickman also goes somewhere along this path, okay? It goes really near to the major vessels, okay? It goes centrally, okay? So these are called central. PIC is percutaneous, and it's either, okay. So it's percutaneous, that means it goes outside. It can go all the way inside, but the way it's coming outside is usually going to be in the, it's going to be in the art, it's going to be somewhere peripheral, okay? It's not going to be right near the chest, okay? I guess that's the difference for PIC only. I don't know if Hickman goes directly or not, but I'm sure permacath goes, like, it's central. Hickman can be central. If it's chemotherapy, most probably it's central. Why is it central? Okay, let me explain. Chemotherapy burns cancer cells, right? If you do it peripheral, that means it's going to burn all of these vessels and then go to the place where you want it. So Hickman, you also want it to be central, okay? Logically, it makes sense. And then you have PIC, which is percutaneously inserted, okay? Usually PIC has one, or it's gonna have two, or it can have three, does not matter. Why do we use this usually? To insert medication. So, you know, whenever you get IV and you want multiple IVs, really common, IVs are really common. So they can be used for medications. It can be used to collect blood. Whenever you go to, you know, anywhere for a drip, whatever, it's usually going to be a percutaneously inserted catheter, okay? Usually it's called IV line because it's not a catheter. It doesn't go all the way in, okay? Catheter means it goes in. IV line is just, okay, till here, you know, it's short. Okay, but the concept is similar. Okay. So this was all about creating access. Okay, easy enough, makes sense. You don't need to know the details. Just memorize this, and I think you're good enough. pretty much the same thing, okay? Now we come to creating tracts. This is a bit more annoying. Okay, so firstly, we go to what does ostomy mean? Ostomy means it is a surgical procedure that is used to create an opening from an area inside the body to outside the body. Okay, so basically it's used, you have a hollow organ or you have an organ and you connect it to something else. You make an opening from the hollow organ outside. Okay, now over here they're telling you about gastrostomy. Gastro means the stomach, so it's something to do with the stomach, and it's an opening, if you can see, from the stomach to the outside. Opening from the stomach to the outside. So this is the skin over here somewhere, okay? From the stomach wall all the way outside. This part goes in the stomach, this, okay. So what they do is they insert this from outside into the stomach. This balloon is deflated. Then what they do is they inflate the balloon so that you can't take it out. You know, if something is, you know, inflated, you can't take it out anymore. So it stays in its place. That's the only reason why there's a balloon over there and why it's so confusing. This place outside is just for like, it's going to be on the skin surface, right? So just to give it some anchorage or something, you know, just to make it more firm or stable, okay? Not important. This part makes sense. And then this, all of it is going to be taking you to outside of the body. This outside of the body is used to deliver food and nutrients directly to the body in specific cases. Like for example, your trachea is blocked because, your esophagus is blocked because you have an esophageal cancer. You cannot no longer swallow food or liquid items. So what do? They place this temporarily until that's resolved, or they've come up with a solution and then they remove this. Make sense? So it's a temporary procedure only. Does this make sense? Cool. Okay, now again, this was creating tracts, you know, so this did not no longer exist. Ostomy stuff. Okay, now over here, it's a fancier word, gastroduodenostomy. So ostomy, you know, it's creating a tract, either from an organ outside to a body or from an organ to another organ. Gastro means stomach, duodenal means duodenum. So they're creating a tract from the stomach all the way to the duodenum. Why do they want to do this? Because there's probably a problem, duodenal cancer, the pylorus of the stomach is not opening anymore, you know, some problem in between these two areas, and they still want to feed. So they use this. Why are they doing it through the stomach and then the duodenum? Because, you know, stomach digests some protein, so it's better to give something over here. Protein, something will be digested over here, and then it'll go all the way from the stomach, and further digestion will take place in the duodenum. Okay, that's why they're doing this. Okay, so same thing, basically just creating a tract. As you can notice, this is also fancy curved. We know why it's fancy curved, because we don't want it to move outside. Not important, but whatever. Okay, now we have cecostomy. What is cecostomy? In the cecum. Where's the cecum? So this is the rectum, sigmoid, okay, ascending colon, transverse, descending. This is the cecum, and near the cecum, somewhere over here, this over here is the, come on, somebody please tell me what this is. Yes, thank you, appendix. So this is the appendix. You see how it's not dilated, not enlarged, so it's normal over here because it's the normal growing. Okay, so sometimes you can have problems with the small intestine, which comes over here, right? Or you don't actually forget problems with the small intestine. More importantly, you can have problems over here. Okay, so you can have colon cancer here, which is blocking this lumen. You can have problems over here, colon cancer here. Stricture over here, some problem over here, which is preventing the stool to move all the way out. Exactly. What do? They create this gateway over here, which can literally, it's like literally a gateway, which can, you know, take out fecal material. Okay, we said blockage. Yes, okay, so usually it's attached to a bag. When it's attached to a bag, it's called colostomy, okay? So maybe some of you have heard of colostomy bags. Same principle, they create an opening from here all the way here. The difference is, since I mentioned colostomy, I shouldn't have done that. Anyway, the difference in colostomy, now I have to tell you the difference. Colostomy is they literally take the small intestine, the colon, and they connect the colon to the outside cavity. So they literally take the colon and they connect it to the skin. Over here, it's a foreign body, you know? So over here, they're creating a new tract. Over here, they're not taking colon, attaching it directly to the skin, you know? This is some foreign body which goes from the cecum and this. Why is it coiled? So that it stays in its place. Because another thing, if you know, when it's coming from the terminal ileum, it's still going to be in a liquidy form. Stool hardens as it goes through all of this place and the water is resorbed, right? So over here, it's still going to be a brown liquidy stuff, you know? So even if it's coiled, even if it's small opening, the fecal material can go out. Does this logically make sense? Okay. Secondly, another thing is you can have something known as fecal incontinence. What does fecal incontinence mean? The only reason I'm mentioning this is because it's written here. Incontinence basically, okay, so whenever you have to pass stool, you have control over it. This control over it is usually sphincters, okay? And this is, you know, what basically happens with all of us. If there's a problem with sphincter control, it's known as incontinence. And in that case, again, you can do a cecostomy, okay? So you can have either a blockage or sphincter loss, basically, the summary of what I was trying to say. Okay, so creating tracts. Now, I know this is getting a lot of new information and it's really annoying, but I have to mention it. Creating tracts over here to get information, to get blood samples, deliver medications, dialysis. Over here to provide nutrition. Over here, again, nutrition, feeding again. Over here to get rid of fecal matter. Now this one, oh my God, I don't know why they brought this. Okay, this is a procedure known as TIPS. TIPS. Basically what they are doing is they are creating a shunt artificially between the portal system, if you know about this, and the systemic system. Why are they doing this? Because in some problems, you can have a lot of fluid accumulating in the portal system. Liver issues, exactly. Liver cancer, portal hypertension, something. There's a problem in the portal system, it's not draining. Since it's not draining, it's causing a lot of problems. To get rid of those problems, to make this drain, you know, usually what happens is that this changes to, portal vein changes to sinusoids, and then those sinusoids go over here, and then those sinusoids are again changed to venules, and venules are, you know, capillaries obviously, and then venules all the way go here. This system is not working right now. So what they do is they're like, okay, we'll create a high flow system ourselves to fix the problem. So they create this transjugular. I don't know what jugular means here. I'm sorry. Trans means through. Intrahepatic in the liver. Portal systemic from the portal system to the systemic system. Shunt, just connection. So variceal bleeding. Oh my God, they mentioned this. Okay. So basically what happens is if you have a lot of problems in the portal system, as you know, there are natural connections of the portal and the systemic systems in the body. For example, you have them around your umbilicus, okay? People who have problems with liver problems, which cause congestion in the portal system, can have something known as varices, which basically means, remember varicose veins, basically dilation of those specific connections where there's a lot of portal blood flow. So, and a classic sign of this is caput medusa. If you learned about this before, if you didn't, it's fine. I think you learned about it in the first year. Dilation of the portal to the umbilical veins, which causes same thing as varicose veins. It causes dilation of the veins, which looks like dilated veins spreading from the umbilicus, which they call caput medusa because it's like the hair of the caput medusa. Okay. Okay, and these can obviously bleed, which is going to be a problem because then the patient is losing blood. So to prevent all of this, you go for tips. Make sense? I'm sorry I had to go into the pathophysiology. Just for your understanding, you can forget it as soon as I finish. No. Okay. They told about this as well. This is percutaneous nephrolithotomy. Okay, what does this mean? Percutaneous means from the skin. Nephro means something renal. Lithotomy, you know there is a problem with the stone over here. So in some cases, when they want to break the stones, for example, you see this stone over here? Can you tell? This stone is huge. It is literally taking the shape of the whole system, whole calyces. This is known as a staghorn callus. In case someone mentioned it in the previous lectures, they didn't forget, okay? This one cannot drain through the ureter. It would literally, there's no way it's going through the ureter, right? So what they do is they create a tract in which they insert it directly from the skin, and then they go all the way here, and then they break it down to small pieces, and then they suck. This one is what they're doing over here. This one is what they're doing over here. This one over here, remember how I told you, you can have a shunt you can block the obstruction if you insert something over here and then you insert something all the way in the bladder. It's the same idea, but they're inserting it from the skin to here, to the kidney directly, because they want to drain it directly from here. Okay, so over here, this is drainage. This is not treatment. This is treatment. This is treatment as well. Okay, so they're showing you two different things, and it makes it really confusing. Okay. So this nephrolithotomy is this part. This picture over here should not be here. The only picture over here, why it's over here, is because it has something to do with the percutaneous part. Okay, makes sense? Cool. Okay, so now we are done with two really important things: creating tracts or access and stopping bleeding. Two major parts done. Okay. Now you want to bypass abnormal vessels. Well, this is what? Okay, same thing, bypass. Okay, so over here, wait, was this a new category or not? Sorry, I have to check. Yes, okay, so this is a new category. We're done with bleeding, we're done with blockage, we're done with this. Now we're talking about bypass abnormal vessels, okay? Now we're going back. Number 4. I should have numbered these earlier. Okay, normal, but so this is the only use that they mentioned over here, thank God. So basically, this is an aneurysm. What is an aneurysm? Basically, this is an aorta, abdominal aorta, and the wall, it gets really thinned out due to some problem. We don't care about the problem. The wall is thinned out. If it's thinned out, it's going to bulge. If it's going to bulge, there's really high risk. This is going to rupture. There's going to bleed. So what these smart people do is that they create a stent in the lumen, and since the stent is metal, it won't be pushed around, and they create a stent, and basically they repair the aneurysm, because once all the pressure is going through directly, blood flow over here will also go over here, you know, slowly, because there's no longer pressure over here, and it'll go back to its original size. So it's really smart way of you not having to perform abdominal surgery, which has a lot of risks and complications, blah, blah, blah. They just insert this, bypass the abnormal vessels, and it's treated. Cool, easy? Now, deliver medication. So deliver medication or local treatment. Now, one form of deliver medication we already discussed before, which is chemotherapy or something else in the PIC and the Hickman and stuff, okay? Now, over here, we're only going to focus on local treatment, okay? So what is local treatment? Number 1, I think that will tell you 3. Okay, so number 1 local treatment is going to be chemoembolization. Where did we discuss this earlier? We discussed this in the previous lecture where we talked about liver cancer. When we talked about liver cancer, they can develop, they can target chemotherapy specific to one location, right? Why? Because chemotherapy is really dangerous for the rest of the body, right? So they want to really focus on this. So what they do is same thing. They go through blood vessels, blah, blah, blah. They reach the hepatic artery. Once they reach the hepatic artery and they went into a specific location, they either do like embolization where they stop the blood flow, or they deliver chemotherapy. So chemoembolization, okay? Via catheter in the arterial supply. This is easy, huh? And then this is before and this is after. Yeah, where you see it's reduced, okay? Now, there's a lot of focal regions over here. By the way, quick question. What is this? CT or MRI? Let's see if you can tell by now. Why CT? Anything why CT, logically. Okay, just feeling is really nice, and I love that gut feeling, but also you can see that these are ribs. Ribs are bones, bones are white. This is bright as well. So yeah, just best to not trust gut feeling all the time. But at this point, yeah, I agree with you. Gut feeling works all the way. Okay. IVC filter. Now, what is this fancy thing? Do you know what a deep vein thrombosis is? Or no? Let me tell you anyway. Deep vein thrombosis is a thrombus in the veins of the vessels. Now, this is in the deep veins. Now, we talked about superficial veins, which can lose their valves, valvular competence. That is known as varicose veins. Good. So it's used over there. DVT is in the deep veins. It's a thrombus in the deep veins, and it can cause leg swelling, blah, blah, blah. The most important problem is it can cause something known as a pulmonary embolism. What does that mean? There's a small part of the thrombus can break off, and then you know how it's in the veins. It goes all the way to the heart and then the lungs. Yes. And then it causes problems in the lungs. Okay? Oh my God, sandal embolism. Perfect. Yes, perfect. So what we do is, if we are afraid in a high-risk patient that he can have multiple DVTs or something, after we get, like, you know, if it's a high-risk patient or if he had previous DVTs, whatever, we don't care, high risk, we can place something as an IV, known as an IVC filter. So you know how it's going to go from the vessels to the IVC anyway, because IVC goes to the heart. In the IVC, we've placed a net, literally like a spider web. What happens is, if there's a thrombus, it gets trapped in here. Since it gets trapped in here, and since over here, this is a large vessel, it can't block this vessel, so there's no problem over here. But once it goes to the tiny capillaries or tiny vessels of the lung, that's where it causes the problem, right? So over here, there's no problem. So we're literally, like, you know, catching them as they go further. This is known as IVC filter, okay? Okay, now we have something known as vertebroplasty. What is vertebroplasty? So in case of osteoporosis or metastasis, you can have problems where the bone is eaten out or the bone is really weak. When a bone is really weak and a person is still heavy or a person still has its weight, the vertebrae can crush on each other. When they crush on each other, what happens? They crush on each other, the bone fractures. Number one, bone fractures. Number two, you can have herniation of the disc. Number three, you can have collapsed disc, whatever. We don't care about the problems. What we do is, in case of osteoporosis or metastasis, you know, we know that there is a problem. We just be super smart and we inject cement over here to give it additional strength to prevent them from collapsing, to prevent any further problems. Okay? That's it. Over here. Over time, wouldn't it cause issues? Yes, you're talking about IVC, right? IVC over time would probably cause issues, and I think they change it after some time, like 2, 3, 5 years, they change it after some time. And the cool thing is, IVC, you can just do any radiological exam and you can tell how, like, you know, how much clots it has, what it has trapped and stuff. So you can remove it periodically and change it. Okay. You're right. It could get, you know, clogged up. Okay, next. Now we are going to deliver medication. So this is delivering medication. So remember how we talked about chemoembolization? Where was it? In the liver. Radio frequency ablation, where was it? in the previous lecture, in the lungs and in the kidneys. Yes. The reason why I did not specify over there is because you can also have radio frequency ablation for the liver as well. So easiest now is radio frequency ablation, all three of them. Just chemoembolization, liver only. Okay, cool, makes sense. Same principle, they're taking all, okay, so what they do over here is really cool. They have a catheter, and then they have this thing, which I think it's an optical fiber or something, right? So it's going to carry all the frequency, radiation, whatever, all the way till the end of this, and then they can choose specifically, okay, we want it to go in this place, okay? This is a CT because we can see the bones. Okay. Now the last category is samples removing pus and feeding. Okay. So biopsy, we already talked about this. So you can go directly under biopsy guided to take the biopsies to under CT, MRI, or usually CT and ultrasound guided imaging to, like, you know, take a specific sample. What is abscess drainage? Okay, so abscess is basically, abscess is something that looks pretty similar to this, okay? Wait, you took POD, right? I shouldn't explain abscess. Abscess is basically infection walled off. You took POD, damn it. Okay, so abscess is walled off. The problem with the abscess is the only way to treat it is to drain it. You cannot use antibiotics unless you drain the pus first. So to drain the pus, you can literally do the same thing, insert something over here directly. You know exactly where it is because you're using CT, and then you drain the abscess and you're done, okay? So we're done with this. And now I think this is the only other really important slides where he's actually going to bring MCQs from. So advantages, it works, minimally invasive. You don't have to open up the person that has a lot of issues later on. Replaces supplement surgeries because a lot of surgical procedures in the past, which they had to open up the people, now they just have to, like, you know, insert the tiny cuts, which does not have any problems, less chance of infections, blah, blah, blah. Day case, so they don't have to be admitted into the hospital. They don't have post-op problems, you know, like, you know, less hospital beds are used, all of this. So they just come in the day. IR stands for interventional radiology, not infrared. Yeah, this whole lecture was interventional radiology. Day case, basically they don't have to admit them in the OR, into the hospital, saves a lot of money for the hospital. Less transfusion, ITU, I don't know, GU, I don't know, but I'm guessing these are infections or some problem like this. Oh, sorry. GA means general anesthesia, so they don't have problems with general anesthesia. ITU, don't know, but something similar, okay? Google it. I'll Google it, it's fine. ITU. ITU stands for intensive therapy units. Fancy, shouldn't they say ICU? Anyway, no ICU, no beds, again, same thing. Patient tolerance. So the patient is more likely to be tolerant of this therapy. It's more likely to work on them. Because a lot of patients, if they have problems with the heart and the lungs, they probably can't go under general anesthesia, okay? So it's easier for these patients as well. Less disruption to daily life because you have to take less days off of work, better economy, less chance of infection. Okay, and this is it. We are done with interventional radiology. Wow, okay. Any questions, anything that was not clear, anything you want more information on? Anything you think I could have done better? Please let me know. This is my email. This is my phone number in case you, or 8528-261, in case anyone wants anything. I'm sorry it took a lot of time. Most of it went to MRI. Apologies for that. If you have anything, please give me good feedback. Good feedback, I mean constructive feedback, in which how we can improve for the next vlogs, how we can shorten the time. A few more things. We tried to give you this earlier because we know it's been going to be recorded, and we also don't want to stress you out later on. And also, we will not be free later on because we have exams and stuff. So we wanted to do this earlier on. Thank you so much for the people who stuck along with us. Honestly, you guys are epic. Inshallah, you guys, all of you get A's. But it was really good for us as well that some people stayed so that we could explain it earlier. So thank you so much for that. Also, please remember us in your prayers because we really need prayers. And if you have anything at all, feedback is really important. Thank you again for the PAL team, to Nora or Noura. I'm sorry if I pronounced it wrong.